We are live now.
So, a very good morning, ladies and gentlemen. On behalf of the Organizing Committee of the Association of Breast Surgeons of India, East Zone and Association of Surgeons of India Jharkhand Chapter, I, Dr. Arunima Verma, welcome you all to this very special and historical occasion of the inaugural ceremony of the first web-based conference of this zone. I would like to welcome the dignitaries, our Chief Guest, Dr. P. Raghuram, Guest of Honor, Dr. Pavninder Lal, ABSI President, Dr. Som Shekhar, ABSI President-elect, Dr. SVS Dev, ABSI Immediate Past President, Dr. Diptendra Sarkar, ABSI Secretary, Dr. Ashwin, ASI Secretary, Dr. Sanjay Jain, ASI Jharkhand Chapter Chairman, Dr. Uday Srivastav, ASI Jharkhand Chapter Secretary, Dr. Muhammad Azad, ASI Jharkhand Chapter Patron, Dr. R.P. Srivastav, Organizing Chairman, Dr. Sunil Kumar, and all delegates to this conference. I now request the Chairman Organizing Committee, the very dynamic and popular surgeon of Jharkhand with international fame, Dr. Sunil Kumar, to formally welcome the gathering.
Thank you, Arunima. Good morning, everybody. It's my proud privilege as a Chairman Organizing Committee of this very nice conference, which is being held virtually, to welcome all of you. I will have to take few names. To start with our dear friend and chief guest for the occasion, Dr. P. Raghuram, whom I had the occasion to know not personally and physically, but through media when both of us were in United Kingdom and shared the same passion. Dr. Raghuram, the very dynamic ASI president, has been leading the ASI from front for the last many months in this pandemic era. And he has shown to the whole surgical fraternity how can a person be dynamic, give a fulfilling experience to the whole of the surgeon, and remaining humble and grounded. It's my very proud privilege, Raghu, to welcome you on this occasion. Our guest of honor, Dr. Pavninder Lal, whom I had the occasion to meet first time during the Royal College of Surgeons exam in Kuala Lumpur way back in 2007, and then we have been meeting each other. And he has brought laurel and pride to all the surgeons by getting into as the Executive Director of National Board of Examination, which is the most in the forefront of giving a push to the postgraduate activity in India. With his dynamism, we are expecting that there is going to be much more collaboration from Indian surgeons to international surgeons, and his passion for training and teaching is unparalleled. Welcome, Pawan. I take this opportunity to welcome ABSI President Dr. Som Shekhar, ABSI President-elect Dr. Dev, immediate past President and dear friend Diptendra Sarkar, Secretary Ashwin, ASI Secretary Dr. Sanjay Jain, our dear friend Professor Chintamani, whose passion for teaching is unparalleled, and he has been a very popular teacher amongst young surgeons and postgraduates. All my DNBs only try and hear his lecture, and sometimes they tend to ignore us also. So welcome, Chintamani. And also I'm welcoming R.P. Srivastava, our patron, and he has brought laurel to Jharkhand by being the first ASI national president. I'm hoping in few years to come, some surgeons from ASI will also crown that post. I take this opportunity to welcome ASI Jharkhand Chapter Executive Committee, including its chairman and secretary, and also our friend Dr. Ghosh from UK. Welcome to India. After all, you are from Indian origin, but it's my proud privilege to welcome Dr. Ghosh and greetings from India. And welcoming at the end all the EC of ASI Jharkhand Chapter, EC of ABSI Chapter, all the delegates and all friends. Thank you. Arunima, you're mute.
Mute.
Arunima, unmute yourself.
Light is a symbol of brightness and prosperity and expels darkness and illuminates our path. So let us start this morning with lighting the lamp and embellish our knowledge. For this, I request our chief guest, Dr. P. Raghuram, and guest of honor, Dr. Pavninder Lal, to symbolically light the lamp. brightness of this light keep us enlightened and help fade away the darkness from all aspects of our lives. ABSI was formally made a part of ASI a decade ago and since then has been actively working towards various goals. I now call upon the very dynamic Secretary, Dr. Ashwin KR, to present the Secretary's report.
Thank you, Dr. Anurama. Did you get my presentation?
No.
Okay.
Madam, you need to stop your presentation.
Please share your screen.
You can see that?
Yeah.
Right. I thank the organizing chairman, Dr. Sunil Kumar, and also the organizing secretary, Dr. Arima Verma, for this great initiative. So I'll be presenting about ABSI. I'm the honorary secretary. So the Association of Breast Surgeons of India, the section with the section of ASI, was started in 2011 at Hyderabad, and with the founding members being Dr. D.D. Patel, the ASI president, Dr. Raghuram, the ABSI president and my mentor, Dr. Somshekar, Dr. SVS Dev, Dr. Diptinder Sarkar, and about 15 members when we started the ASI. The commitment, it included not only just surgical oncologists, but also general surgeons, plastic surgeons, and all those who are treating breast surgery. So it was basically the commitment was just like all over the world to improve make it a super specialty and also improve the art and the treatment of treating of breast diseases. So what started as a small chapter has grown in the last 9 years to over 784 members. And the main commitment and our aim was to develop breast surgery as a super specialty and subspecialty in India, and most importantly to standardize the breast healthcare in India so that the same type of treatment is given by all the doctors. So a few of the ABSI achievements are that we have created the ABSI modules, which are presented all over India to guide and also to educate the doctors, the young surgeons, and also not the pathologists, radiologists. And we run regular courses in imaging for the surgeons, also oncoplastic skill courses for the doctors, and we are mainly into academics and research. And one more crowning glory is the Indo-UK. We have a close contact and commitment with the UK doctors, and we have a fellowship too. So these are we have the annual conferences. We till now from 2011 to 19 we have had 8 conferences, and these in each conference we make sure we call eminent international national doctors to present their data and to also to teach the young doctors in India. And not only that, it's usually a 3-day event where the radiologists come and they teach the doctors and delegates how to do breast imaging workshops. And in Delhi and in Bangalore, we even have cadaveric oncoplasty workshop to teach them the right way to put incisions and to operate. And it is not only teaching, it is also we are into social activity where Dr. Raghuram had done the pink ribbon walk, and we make sure that we increase the awareness, it being since it's now the most common cancer over the world. One one more important thing is that to get uniformity and effective standard of care in breast surgery, we have published this important Indian solution for Indian problem. It's basically a practical consensus that we had created 2 years back, and it has been authored by Dr. Somshekar, Dr. Raghuram, Dr. Chintamani, Dr. Dev, and Dr. Diptinder Sarkar, where we brought out guidelines and we told them what is the proper consensus statement with respect to diagnosis, pathology, and even treatment. Like I said, one more important the thing that we do is the training for the students. So we have the Indo-UK coordination program, and Dr. Shankar Narayanan till last 5 years, who was a coordinator, and now is Dr. Parmeshwar from Manchester. So we usually provide opportunity for a young surgeon to train in UK, and it is not give, and the fellowship is given as a part of a prize for the best paper award. And the young doctor is able to go to UK, train there for a month, and he's able, and the entire whole thing, the travel, the stay, and they are even given the opportunity to attend a conference, the ABS conference, and everything is provided by the ABSI, and it's called the Manipal ABSI fellowship. So it's a great travel opportunity and stay opportunity, and I'm fortunate to say I was one of the winners, and I got trained under Dr. Shankar Narayanan at Stoke. And one more good news is the recently the Walters Kluwer, the publishing giant, came to us and they approached us and they wanted to have a journal with us. And we, under the banner of ABSI, we are going to have the Annals of Breast Diseases, which have been created. And very soon, probably in November or in December, we plan to get out the first issue. I think Dr. Somshekar sir will be able to explain more, since it was his brainchild and it was his initiative to do this. And I would like to encourage everybody to please visit absi.in, our website, dedicated website, and please become a member, full-time member. And with the membership form is downloadable. All you have to do is just mail it to us, and we'll be able to provide you the full-time membership. And there's a lot of good initiatives, and it will help the members. Thank you.
Thank you, Dr. Ashwin, for the crisp report. I now request the ABSI president, the very versatile and talented surgeon with a lot of drive, Dr. Somshekar, for his presidential address.
Thank you very much, Arunima. At the outset, I start showing my great respect to two most important persons, the chief guest, ASI president, our Dr. Raghuram, and the guest of honor. And they are the main leaders who helped us. I show my great respect before I start my address. And I also start congratulating, thanking Arunima and Sunil team for fantastic event. Already I am just getting superb, congratulating messages from all over India. It's like it's looking like much better than an actual live conference. And I need to, I welcome all of you as a president of ABSI on behalf of office bearers and executive committee, Dr. Dev and Dr. Dipten, Dr. Ashwin, Dr. Jain, and the entire EC to this ABSI East Zone ASI Jharkhand Chapter joint meet. And I have to tell, I can't believe it is almost a decade. I just remember me and then, Dr. Dipten, Dr. Chintamani sir, and all of us just went to Boathouse Club to meet Raghu in Hyderabad, and already it is 10 years. This is the youngest subgroup chapter of ASI and fastest growing chapter. This is one of the main platform to be the voice for breast diseases for breast surgeons. And then, it is not just doing a conferences, academic, fellowship, training, standardizing, everything has reached great heights. And this is a brainchild of our current president, my very close friend, my brother, Dr. Raghu, in association and guidance from Dr. Chintamani, Dr. Didi Patel sir, Dipten, and Dr. Dev, and all of them. And it's really, I'm the junior most person, but it's happening when I am a president in such a great meeting. So I wholeheartedly thank all of you, welcome all of you, and I call this particular program a great success for full day. And I request all the people to record this and use this and post it on various platforms of their medical college. Welcome all of you. Have a nice day of academic bonanza, and I thank Arunima and Sunil for this. Thank you.
Thank you so much, Dr. Somshekar, for all your support and guidance throughout. As we move in our journey of ABSI, we are looking forward to the magnetic leadership of our President-elect, Dr. SVS Dev. And now I request him to briefly address the gathering.
Good morning, everybody. First of all, I would like to congratulate the ASI Jharkhand Chapter, Dr. Sunil Kumar and Dr. Anima, for taking this lead. You all know, I think we have been going through one of the biggest crises in the humankind. The entire medical field Every human being, we have faced the crisis. And this event symbolizes the strength of the spirit of the human beings, and we, especially the doctors. So we forgotten everything about COVID and everything. The moment you started the planning for this event, everybody is back on track. So that is what I think symbolizes these societies, our efforts. And I think people like Dr. Arunima, Dr. Sunil Kumar needs to be congratulated for organizing this fantastic event. We are putting our past, we are putting all the troubles of COVID, what the stresses we have gone through, and we are bouncing back. I think these events, it's not only the advancement of breast cancer and breast surgery, but we are also able to overcome the tragedies which we are facing collectively by organizing these kind of events. So I would like to thank everybody, and I wish all the success for this program. I'm sure all the youngsters will have a very useful day today with our motto of ABSI, spreading the quality and standards of breast cancer surgery. Thank you, everybody. Thank you.
Thank you, Dr. Dev. We are sure to reach milestones in future with your guidance.
Thank you.
It's my proud privilege to call upon the immediate past president of ABSI, a very passionate and dynamic surgeon from our East Zone, Dr. Diptendra Sarkar, to say a few words. Sir, please unmute yourself. Dr. Diptendra.
Good morning, everyone. And I hope the morning shows that we are able to fight and win against the virus and the pandemic in the fantastic possible way. I feel privileged in two ways because I was part and parcel of the small boat club meeting that took place in Hyderabad under the guidance of my dear friend, Dr. Raghu. And at the same time, I feel the same passion burning within me when I saw the first conference of the ASI Jharkhand Chapter, and under the leadership of Professor R.P. Srivastava. I still remember those days when I have traveled to almost, till now I have almost traveled to 5 different conferences, and I had the privilege to deliver an oration in the Jharkhand chapter also. It is possibly the best possible unification of the two fastest growing chapter and the section in ASI who comes together to form this wonderful event. At the beginning of the inauguration, I didn't know that I'm going to see a lamp being lighted, and it gives me a true feel of being physically present in the conference. I hope after the pandemic is over, I am going to see a non-virtual banquet dinner being hosted by Dr. Sunil Kumar, where beyond lightening of the light, we are going to get the passion of the wonderful hospitality physically as well. So once again, congratulations to Team Jharkhand for this wonderful meet. I am looking forward to the day today to learn something from all of you. Thank you very much.
His actions inspire others to dream more, learn more, do more, and become more. He is one who starts where there is no path and leaves a trail. His innovative, decisive leadership has made history in these troubled pandemics. And it is definitely an honor to welcome our guest of honor, Dr. Parminder Lal, Executive Director of NBE, to the conference. Sir, we request you to say a few words.
Very good morning to all of you. Esteemed chief guest for this function, my dear friend, Dr. Raghuram, the organizing committee chairman, Dr. Sunil Kumar, Dr. Arunima, the organizing secretary, the entire leadership of the National Committee of the Association of Breast Surgeons of India, led by Dr. Somshekhar, the immediate past president, Dr. Diptendra, and and Dr. Deo, the leadership of the ABSI East Zone of the Jharkhand East Zone, and the ASI Jharkhand Chapter, and very senior eminent surgeons, including Dr. Srivastav. Thank you very much, Dr. Arunima and Dr. Sunil, for this very kind invitation. It's a great privilege for me to be a part of this August function. which is marking almost a decade of this start of uh, this chapter, which started as a initial small meeting, and then, as you can see, has grown into an independent organization under the leadership and guidance of uh, none other than Dr. Raghuram. And what a nice way to invite him today, 10 years later, from that board club meeting, where he would be seeing this as such a wonderful fulfillment of a dream of having started this association, and which has grown from that handful people to around 800 odd surgeons now. So it's an immense feeling to be this morning, to be with all of you, and to see the successful use of this online webinar platform for the conduct of this meeting. Um, we have, as everyone said, have gone through these very difficult times. And as a national medical university, National Board of Examinations has risen up to this challenge. And as you are aware, in the months of July and August, we have delivered OSCE-based exit examination in the entire country. Up to 40 centers were connected with the National Board at one time for various subjects. We have already done the subject of general surgery, and the results have already been declared. And therefore, in pandemic times also, we have shown that we could move forwards with due diligence and due precautions, maintaining social distancing, and at the same time, moving ahead with a new pattern of examinations on a virtual OSCE, using virtual OSCE. And we have, out of the 18 subjects that we had started with, we have as on date completed 11 subjects. 7 more are to be completed in the month of August, and 9 more have been announced for the month of September. So this gives me an immense pleasure to say that we have moved with the times, and the National Board of Examinations is geared to look after the interest of all surgeons in the country, including in the specialty of breast surgery. At this time, I would like to make a request to the leadership of the Association of Breast Surgeons of India, both in the country and in your East Zone. National Board of Examinations conducts 2-year fellowship training programs, which are post-doctoral programs in many, many specialties. I don't think breast surgery is an existing fellowship training program. If your leadership thinks that a 2-year program post MS or post DNB surgery is something that you can conceive of, then I, on behalf of the National Board of Examination, would give you 100% support. And in the next year's fellowship examination, that is in 2021, you will find a fellowship in breast surgery as a new fellowship in the whole country, which can provide hands-on training to committed postgraduates, qualified surgeons who are keen to undertake breast surgery as a career option, and will add to the list of some of the surgical specialties which are already there in the fellowship, like minimal access surgery or other smaller or focused surgery groups. So through this invitation, Dr. Arunima, you have given an opportunity for a new fellowship program to be conceived by the leadership of the breast surgeons. And I'm sure with Raghu's presence and with the presence of leaders like Dr. Deo, Dr. Diptender, we are going to see formation of a specialist board for the subject of breast surgery, and curriculum be designed, the training content being designed, and whatever are the requirements, what kind of a department should get accredited, what are the minimum number of procedures that are required to do that fellowship program. There is a format for that. If all that can be completed, then I think my presence in the national board would be duly justified in helping the cause of breast surgery in the country. So with those words, I would like to once again thank the organizing committee for this very kind invitation, and wish this conference all success. Thank you very much.
Thank you very much for sparing your time and sharing your thoughts. And most important, you have made this another historical event by extending that invitation. And all the people who matter in the APSI, the Dr. Som Shekhar, Dr. Dev, Dr. Diptendra, Dr. Raghu, they are already here. I'm sure they have taken note of it, and we'll surely see a breast fellowship in few years. Thank you so much for that invitation on behalf of ABSI. And thank you, sir, for sharing your thoughts. With a list of laurels to his name, passion and dedication to the surgical fraternity, outstanding social services and strong stand for surgeons at all levels, and one who stood by his promise of creative leadership and accountable governance, it indeed is a glorious moment to welcome the 82nd President of ASI, Dr. P. Raghuram, as the chief guest for this conference. I request you, sir, to address the gathering.
I'm not able to share the screen.
Sir, I'll give you the permission. I'll stop sharing. You please share your screen. Yes, sir, please share your screen.
Okay. Good morning. I always consider every opportunity to speak at such special gatherings, first of all, a blessing. I count my blessings every single day. So I consider it, first of all, a blessing to be amongst you, a great honor and a privilege to be addressing you this morning. And as my dear friend Pawan has clearly stated, this is a very nostalgic moment for ABSI having completed 10 years. And I think this is the first time that I'm coming across a meeting which has been jointly organized by a chapter and a section. I think this speaks volumes of the collaboration that Jharkhand chapter has with ABSI. And I think this is a role model for other sections and other chapters to follow so that a lot can be achieved in one go. In fact, my dear Pawan has borrowed thoughts from my mind already. It is, I think, telepathy as a result of 20 years of friendship. I guess this is exactly what I wanted to request him. Him being here as a guest of honor, I thought this will be the opportune moment, and I will steal the thunder by asking him if a specialty course, a specialty fellowship could be initiated, and he has already announced that. I would like to pay respects to a doyen in the field of surgery, the founder secretary of the Jharkhand chapter, which was formed 20 years ago in the year 2000, a former president of the Association of Surgeons of India, who has been a guiding force and a good friend, Dr. R.P. Srivastava. We acknowledge your presence at this meeting. And of course, we know these two dynamic people, my dear friend Sunil, whom I have known from my UK days and then back here in India, and an esteemed colleague on the National Executive Committee, who is the force behind this meeting, along with Dr. Arunima Verma. Actually, your efforts have been tremendous, and your hard work, meticulous attention to detail has resulted in this conference, from the birth of, having this conference, from the thought of having this conference to implementing it. I think full credit goes to you. The ABSI journey began when I was in the UK, when my mother was diagnosed with breast cancer, having made the committed decision to relocate to India. When Professor D.D. Patel came to the BASO meeting, the penultimate year before I relocated, I requested him whether we can form a similar association, just as the Association of Breast Surgeons or the American Society of Breast Surgeons. He said, Raghu, whatever you decide, I will stand by you. and he stood to his word, and he stood rock solid behind this vision, which resulted in the formation of the Association of Breast Surgeons of India. There were a lot of difficulties right from 2007 when I returned. The birth of this transformed to ignite the minds of several colleagues up and down the country who shared my vision, who worked hard through focused efforts and rock solid determination. Despite so many hurdles and hassles, we were able to get the Association of Breast Surgeons of India established as a section of ASI, which was approved in December of 2010. So it's almost 10 years since the formation of ABSI. And this is an association which was formed along the lines of the American Society of Breast Surgeons and the Association of Breast Surgery in the UK. And I'm so delighted that we are really have become the voice for breast surgery in the country over the past 10 years. I've always believed in this, and I continue to believe in this forever, because gratitude is the best attitude that one can have. This vision of ABSI could not have been completed without the visionary people, Dr. Chintamani, who was the president of ABSI after Dr. Devendra Patel, and my dear friend Dipten, with whom I spent many evenings together, and a good friend he is, and he served as a treasurer, he served as the honorary secretary, and he served as the president of ABSI. And this picture speaks a lot. My dear friend and brother Som, whom I would call, is the president of ABSI during my term as ASI president. And this is the best gift that I give for myself, that my dearest friend Som is the dynamic president of ABSI during my term as ASI. And I'm sure he will fulfill the dream of developing the fellowship program. He's a live wire. He will not leave Pawan till the fellowship program gets accredited in a very short span of time. And the future of ABSI, Dr. Dio, who is the president-elect, and my dear friend Sanjay Jain, who is my buddy, good friend, close friend, honorary secretary of ASI, who helps shaping the various dreams of ASI and is now also the current treasurer of ABSI, and the young dynamic Ashwin, who is taking the lead in organizing ABSI's activities. So I must also place on record the ABSI's contribution during this COVID pandemic of 2 lakhs, very generous contribution for a young section. And do you know what? This amount has been contributed thanks to Dr. Somshekhar and the Executive Committee of ABSI to Assam and Northeast to provide the much needed PPE when there was acute shortage in the months of April, May, and June. So I would like to, my wish and my desire is that in the next 10 years, between 2020 and 2030, ABSI emerges not just as the voice for surgery in India, but as a voice for breast surgery in the Asia Pacific region. And I'm sure that the current leadership and the future leadership will take it in that direction. Now, what do I have to say as the president of ASI, as a president of this association? I would like to thank every member who is watching this program for their generosity, for standing shoulder to shoulder with ASI at this time of crisis. We have emerged from 2 phases, if I may add, during this year. The first 3 months of intense academic activity was seen between the months of January and March. And in March onwards, ASI was at the forefront in philanthropy and in voicing the concerns of the association, of the members, of the medical fraternity, boldly and fearlessly on national television and print media. And now We have from the months of June, we have started intense online academic activity thanks to the extraordinary help from Dr. Santosh John Abraham, who is the Director for Academics. We have started off with the online National Skills Enhancement Program, which is now seamlessly transforming to the online RRCs. For the first time, all 6 zones postgraduates will be able to witness the academic activity all through from Monday to Saturday until end of September. And finally, I would like to place on record my heartfelt appreciation to the Jharkhand chapter, Dr. Uday Srivastava, the chairman, Dr. Mohammad Azad, the honorary secretary, and my dear friend, colleague on the National Executive Committee, Dr. Jugal Kishore Chaudhary, and everyone on the executive committee of Jharkhand State Chapter and the ABSI, and to all the members, I with folded hands, I once again am very grateful for the kind invitation that you've extended to me. I wish you happy learning, stay safe, and keep smiling. Thank you.
Thank you, sir, for your encouraging words. And I'm sure all your dreams will be a reality with the passionate leadership that we have. On behalf of the organizing committee, we would like to present the e-memento to our chief guest, Dr. P. Raghuram. And we now present the e-memento. We now present the e-memento to our guest of honor, Dr. Pavninder Lal. On this occasion, we would also like to felicitate Dr. R.P. Srivastava, who made Jharkhand proud on various occasions. Interestingly, he was the founder secretary of ASI Jharkhand Chapter and was the national ASI president when ABSI was formally proposed. And the two bodies have come together on this occasion to again have the first web-based conference. Sir, Jharkhand is proud of you. As the organizing secretary of this conference, I would like to thank our chief guest, Dr. P. Raghuram, guest of honor, Dr. Pavninder Lal, all the executive committee of ABSI and ASI Jharkhand chapter, all the faculty who agreed to be a part of this conference at such short notice, all chairpersons for their participation, and each delegate registered for this conference. Each one of your participation adds to the success of this conference. Last but not the least, I would like to thank Mr. Anand and Mr. Sachin from our website team, who worked relentlessly, taking all our constant alterations in the programs and still making this a reality. I would now request all of you to rise up for the national anthem.
Jana Mana Adhinayaka Jai Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkal Vanga Vindhya Himachal Yamuna Ganga Uchchal Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you very much, everyone. And now we start with the scientific program without wasting any time. Thank you all the dignitaries for your precious time, and we go ahead with the scientific program.
Do I begin?
Just one second, sir. Yes, sir. So we begin with our first session, that is the guest lecture. And I invite our chairpersons, Dr. R.P. Srivastav and Dr. Som Shekhar. Dr. R.P. Srivastav needs no introduction. I've already introduced him. He is our patron, and he has got a lot of things to his laurels and brought a lot of laurels to Jharkhand. He's a senior consultant laparoscopic surgeon of Jharkhand and was the former ASI president. Dr. Som Shekhar again needs no introduction, but he is the ABSI president at the moment, and he is the director of HIPEC program at Manipal University, Bangalore. So please take over.
Once again, namaskar to everyone. Namaskar because I'm thankful to your wishes and the Almighty's desire that I should be available to serve the colleagues, the humanity, and my extended family once again in life, along with my better half. The other thing which I'm really enthused this morning is World Tribal Day from Jharkhand. I'm talking, and there are two things happening together: 2 decades of Jharkhand chapter being, and 1 decade of the section into being. And the first speaker is Professor Dr. Raghu Ram, who doesn't need any introduction, like Ram doesn't need any introduction, Jai Jai Siya Ram. So Raghu Ram also doesn't need any introduction. He has been absolutely right from the groundwork to the finished product. He has been exemplary. I have seen him doing the groundworks during my tenure of activity, and I'm seeing him from the background of doing chiseling and finishing products, giving it a shape. So Raghuram doesn't need any introduction. One thing I have to say, dear friends, and I give it with an instinct, that you will agree with me, particularly to the breast surgeon group, you will agree with me that take a dream on this count this morning, that every surgeon who is passing from any university or national board should be empowered and absolutely skilled to do one small thing for all the breast diseases. When it comes to giving a biopsy specimen for histopathology to a colleague in Department of Histopathology or Pathology, then it really becomes a challenge. We'll leave our patients to the mercy of they sticking in a needle or they asking you for giving a sample. So Dr. Raghu, Dr. Som Shekhar, Sunil, Chintamani, and Pavninder Lal, may I call upon you to empower every trainee surgeon and every surgeon across the country doing a best service towards the breast surgery or this organ or this women group, to train every one of them about true cut specimen provision. If you have done that, it will go as a quality delivery beyond self breast examination and chiseling the product right on the top, training them, sending them UK, sponsoring them. Those are very sporadic things. But please do a broad-based across the country effort. And I call upon all of you, you are so exemplary in your own esteem, that if you take a vow that, okay, every surgeon will be chiseled, at least not to fear the true cut biopsy, but he will be providing the specimen to the pathologist in a very well mannered way, so that the pathologist help the early diagnosis as well as the plan of the surgery well. Having said that, again, excision of culmination of 2 decades of Jharkhand chapter into being, which I conceived in 2000, year 2000, when Jharkhand was formed, and this chapter came into being in 2001. And see, when 2011 came, Raghu's all spade work culminated into breast surgeon's chapter section. So it is a very deep coincidence. And let us take it forward. I invite Raghu, who needs no introduction, to deliver his lecture.
It's my pleasure to request Padma Awardee, BC Roy Awardee, President ASI, founder secretary who went on to become president of ABSI, my dear friend Raghu, to give a special invited guest lecture on the topic of benign breast diseases, what to do and what not to do. And I request every, not just student, senior surgeon, to really record this. It's going to be a fantastic talk, and this is it's a textbook in itself. Over to Dr. Raghuram.
Thanks very much, Professor Srivastava. I would like to also place on record that it was during your time as ASI president in 2009 that this hurdle started getting resolved into formation of ABSI. I'd like to place on record, it is indeed a very, very special moment that, you're in Jharkhand and we are in the Jharkhand chapter meeting. So it's a very, very nostalgic moment. Thank you very much, my dear Som. And I would like to begin by stating that the expectation of a surgeon dealing with breast diseases is confined only to the management of breast cancer has long disappeared, because benign breast disease is associated with considerable morbidity and anxiety, and it is ever increasing. The effective management lies in accurate diagnosis and counseling. I'd like to stress the word counseling, because reassuring the worried well helps to resolve the vast majority of people who have benign breast disease. So the aim of my presentation is just very briefly to touch upon some of the do's and some of the don'ts, emphasizing on the don'ts. You look at this clinician and you can look at this patient who's sitting at the edge of the chair, very frightened, very anxious, and she can't open her mouth. The only person who's opening the mouth is the clinician, which is exactly not to do. What should the clinician do? He should be able to listen to the patient. He needs to be a listening physician. And that is what is really essential in the management of benign breast disease, like in many other diseases. So it's essentially, you need to talk to the patient, but before speaking to the patient, you must allow this patient to speak to you first. Triple assessment is the gold standard, and there should be only 3 outcomes of the triple assessment. There is either no problem, a diagnosis of benign problem, or a diagnosis of cancer, and assessment should end at diagnosis and not before. So what are the 3 components? We already know this: clinical breast exam, imaging, and biopsy. I'd like to emphasize core needle biopsy and not FNA is the gold standard, and FNA is only reserved for aspiration of cysts, and that too if required. So just as a clinician requires a stethoscope for diagnosing conditions, particularly a cardiologist, for a breast surgeon, the stethoscope is a breast radiologist and a breast pathologist. You, however good you may be, however great you may think you may be, if the breast surgeon does not work closely with the breast radiologist and breast pathologist, you cannot deliver an effective breast service. In our unit, everyone is same. No one is superior over the other. The breast pathologist, the breast radiologist, the breast surgeon, all are equal members of the team who can be approached by just a phone call. So there are no ego hassles, and that is when you can deliver a good breast service. Is triple assessment essential for every breast lump? Yes, the answer is yes, because it reduces patient anxiety and most importantly ensures that a minimum number of women undergo surgery for benign breast disease. Clinical breast exam gives an understanding, but it's not accurate, and therefore breast imaging is the cornerstone for detecting things, which is coupled with a core biopsy. Many women do not want to go and get themselves a mammogram done because they think it's very, very painful. If you train your radiographer well, the discomfort is momentary. It should not be painful. And radiographer training, attention to detail is very important. Many a times the patients first report to the radiographer, not to the surgeon, not to the radiologist. They report to the breast center, or it may be a radiology service. So you need to train your radiographer to speak to the patient, to calm the patient, and then take the patient. And then if she is trained properly to do the mammography, it will not be painful apart from momentary discomfort. These are small things, but they matter a lot in clinical practice. And the other reason why women don't like to go for mammography is because they think it causes radiation hazard. Radiation from mammography is less than a dental X-ray, and if they're explained, if they're empowered, if awareness is created, more and more women will come forward for mammography. And in this day and age of digital mammography and 3D mammography, the discomfort, radiation, everything is much less and the accuracy is much better. These are small pointers which I'm trying to explain. When someone comes for a mammography, the important thing a radiographer must ensure: no skin lotions, no deodorants, no powders, because they mimic microcalcifications, and therefore it's very important to ensure that they don't have. Many a times we come across imaging reports and images saying suspicious microcalcifications. When we repeat the test at our center, there are no microcalcifications. So it's a very, very important point to note. The third component of the triple assessment is definitely an ultrasound guided core needle biopsy. You know exactly where the lesion is and you know where the needle is, and you can reassure the patient. Say if this was to be a benign lesion, you can say, this is the lesion, this is the needle, this is the biopsy report, this is not a cancer, you don't need surgery. So reassuring, this picture always helps to reassure the patient. So why do we need a needle biopsy? Because it avoids unnecessary surgery. And I won't go into the details apart from stressing this fact that the sensitivity, specificity, the positive predictive value is 100% if it's done properly. The false positive is 0 if it is done under ultrasound guidance. And therefore, core needle biopsy is the gold standard. So some of the conditions which I shall be highlighting: mastalgia, the commonest complaint that a woman presents to the breast unit; cyclical mastalgia seen in premenopausal women; non-cyclical mastalgia, which is seen in postmenopausal women; and chest wall or musculoskeletal pain that is commonly mistaken for a breast pain, which in fact it is not breast pain at all. And it's very important that when you roll the patient to the side and you lift the breast away from the chest wall and examine the patient, you can easily distinguish between a breast pain and a chest wall pain. And why is breast pain also important is that in a small proportion of patients, they can present with cancer, but it's very, very rare. Majority of women who present with breast pain do not have cancer. What should be the treatment? The treatment should be reassurance, reassurance, and reassurance. Advising them to wear a correct fitting bra. Sometimes if it's very particularly in non-cyclical breast pain, NSAIDs, and changing the pill to mechanical contraception, and very rarely tamoxifen for a short duration might help. And for chest wall pain, the Tietze syndrome, where it's costochondritis, very rarely in patients who present with very severe pain, injection of local anesthetic also is done. But I must emphasize that it is not common to use it because it is so rare. What should not be given is vitamin E, evening primrose oil, which is very commonly prescribed by our gynecology colleagues and the GPs. It's very important to emphasize that it's just a placebo effect. No role for antibiotics, no role for diuretics, no role for restricting coffee, tea, chocolates, or soya. These are things which should not be done in breast pain. Fibroadenoma, young women present with a small lump. This is somebody who had a lump and a mammogram was done, and a typical ultrasound picture, it's oval, smooth, internal echoes, partial transmission, and edge shadowing. With ABSI starting breast ultrasound courses, this is something which can easily be replicated by any surgeon in the clinic. What should be done for a fibroadenoma? Should FNA be done? Should excision be done? The answer is an ultrasound guided core needle biopsy, because you can get a diagnosis, and if it is small, you can advise the patient. You can bring the patient back in 3 months and repeat an ultrasound scan just to reassure the patient that it's not getting bigger. The only time you want to excise a fibroadenoma is when it is very large, a giant fibroadenoma causing a lot of discomfort, or the patient says that I want to get this lump in the breast removed. And it takes, I can tell you with hand on my heart, despite the fact that I work in a private center, unless the patient really asks for an excision for a small fibroadenoma, we don't push for it. And in this day and age of vacuum assisted biopsy, smaller lumps up to about 3 centimeters can be excised in the office under ultrasound guidance. And I don't know whether this video will play. Yes, so this is a fibroadenoma that can be removed in the breast unit under local anesthesia for someone who really wants to get the lump removed. So normally vacuum assisted biopsy is really so good for indeterminate lesions and for very small focus of DCIS, but really I think for fibroadenoma excisions, it is an exception. But when we have patients who want to get it excised, we do undertake excision of these fibroadenomas under ultrasound guidance. So this is the ultrasound picture after the excision of the fibroadenoma. Many times young women come forward with small fibroadenomas, multiple fibroadenomas. What should be done is not to meddle with them and undertake more surgeries. These are women who usually come for a second opinion, third opinion, fourth opinion for an excision. The last thing you want to do is excision. Phyllodes usually presents in older people, and this is an ultrasound of the patient with phyllodes. What should not be done is an FNAC. What should be done is a core biopsy. Despite doing a core biopsy, you cannot get a diagnosis of whether, you can't distinguish whether it's benign or malignant. And more often than not, you need to do a wide excision. And if it's a very large phyllodes, you may end up having also to do a mastectomy. Cysts very common in women, usually between perimenopausal period, 40s to 50s. They present with sudden onset of having noticed lumps. This is a lady who had multiple lumps in both her breasts and a typical appearance, which is smooth, anechoic, well-defined walls with enhanced through transmission. Should you aspirate every cyst? The answer is no. If you aspirate the cyst, should you send it for routine cytology, culture sensitivity? The answer is no. The only time you want to aspirate a cyst is when it's large, when it is causing pain, when it is infected. That is the only time you want to aspirate. And even after you aspirate an infected cyst, there is absolutely no role for sending it for cytology, culture, or sensitivity, because it has no value. It may show a false picture, and it is certainly not cost effective. The only time you want to send the fluid for cytology is when the cystic fluid is bloody. That happens when you have an intracystic carcinoma like this, which is again very, very rare. Microcalcifications, many people coming for screening mammography have benign microcalcifications, which is very often because of lack of expertise. It is reported as suspicious, indeterminate, clinically correlate. You cannot clinically correlate somebody who doesn't have any lesions, and you need to rely on your expertise, your knowledge. These are all benign microcalcifications where nothing needs to be done whatsoever. What is needed is reassurance. Patients presenting with abscesses is very common. Should you do an incision and drainage? No. Early recognition, early institution of antibiotics, and to encourage women to breastfeed as far as it's possible, unless the lesion, the abscess is very, very close to the nipple. So what should not be done is giving antibiotics like ciprofloxacillin, suppressing lactation, putting ice packs, because it's only going to make things worse. Incision and drainage should be the last option. And even when you do these ultrasound guided aspirations for these abscesses, you'll have to bring the patient back very often to do the repeat aspirations. It won't go away in one go. And if it is multiloculated, if it is not responding to antibiotics and repeat drainage, yes, an incision and drainage has to be done. Galactocele, nothing needs to be done. Typical fat fluid level. The only time you want to aspirate a galactosele is only when it is infected and large. And that is the only time you do that. This is a typical mammogram picture, looks like a cancer, multiple mass lesions, pleomorphic microcalcifications. When you do an ultrasound, multiple pockets of abscesses are seen. Breast TB, something very common, very badly managed. In our center, we see at least 2 patients presenting with breast tuberculosis every week, and they present with recurrent ulcers, recurrent abscesses, and you find patients like this who have had multiple incisions and drainages for an abscess and disfigured this young lady's breast. This is something that should never ever be done. What should be done when someone presents like that? Early recognition, high index of suspicion, ultrasound guided core needle biopsy, and if the biopsy shows features suggestive of chronic granulomatous mastitis with caseous necrosis and Langhans giant cells, even though you don't get AFP positivity, which you will rarely get, we must start anti-TB medication in consultation with our pulmonologist. We always do that. We counsel the patient, we sit them down and say, look, there is no established diagnosis, but this is TB. These are the medications to take. These medications have a lot of side effects. So you prepare the patient's mind, take them into confidence, and you will have near 100% compliance. We usually give them for 3 months as an empirical course. Once it works, we continue it, and patient compliance is very, very high. So surgery as far as possible must be avoided in breast tuberculosis. Nipple discharge, my good friend Sanjay is going to be addressing this issue, so I shall not dwell upon it, apart from emphasizing that fact that unless it is blood stained, there is no role for sending the fluid or a nipple discharge for cytology at all. Accessory breast, very common in young people. What should you do? Reassurance and reassurance and reassurance, unless it is causing a lot of discomfort, because excising that will leave the patient a scar, and that scar also can cause discomfort. So unless it's really required, we don't need to do that. I would like to end by saying that in 2007, impressed with the Prime Minister's Digital India campaign, because we want to ensure that particularly women with benign breast disease, because out of 10 problems in the breast, 9 out of 10 are benign, they need reassurance. So with that in mind, we launched the world's first mobile app on breast health, which is called ABCs of Breast Health, which is in 12 commonly spoken Indian languages, and it is freely downloadable on App Store and the Google Store. And this was launched by none other than one of India's icons, Amitabh Bachchan. This is a gentleman who grilled me for about 2 hours before launching this, wanted to know every nuance of this app, wanting to know a lot about breast health before he launched this app. So in conclusion, I would like to emphasize that triple assessment is mandatory in the evaluation of any breast health lesion. Communication skills have to be at your best. Most benign breast health issues, 9 out of 10 problems are benign. They can be managed conservatively. And a multidisciplinary approach, you need to work alongside your breast radiologist and your breast pathologist to ensure that the patient is reassured, and you can only do it by working as a team. And your decision to think right, choose right, and do right will rarely, if ever, be the easiest course to follow. And I must say that in that process, we should never do any harm. And finally, my heartfelt gratitude once again to the organizing team for giving me this wonderful opportunity to deliver this presentation. Thank you.
So thank you, Raghu. 3 things happened. The first thing happened is that everybody is sitting in the comfort of their own walls. Second thing happened that this digital conference came into being. And third thing which happened is that the first time the speaker is sitting on the comfort of his chair and addressing. So 3 things happened today, and it is absolutely a marvelous display. The only thing which I was asking, that you mentioned that with the core with the ultrasound guided. What did you say? Ultrasound guided biopsy.
Core needle biopsy.
Core needle biopsy. So vacuum assisted excision also is possible, and if it is possible, up to what size of lesion is it being practiced?
Yeah, comfortably 2 centimeters, but it can be done up to 3 centimeters with experience. I think not beyond 3 centimeters because it can cause a lot of hemorrhage, and hematomas can be seen, and also there is a possibility of leaving behind tissue. So up to between 2 and 3 up to 3 centimeters it can be done, and we do it from time to time. Only if the patient says, doctor, I don't want the lump in the breast. Now, if I take the patient to theater, it would cost the patient. So we economize by doing this procedure in the office procedure, and it doesn't cost much at all.
Oh, that's
and
great.
The patient goes home within 3 hours.
That's great, because our own young female who will have this, they have to cross over from their own parental house to the in-laws' house.
But sir, I would like to emphasize here that the vacuum assisted biopsy should not be sold as a treatment modality for fibroadenoma, because it can be misused by people, by centers, by private hospitals as well. It is only we sparingly use it, and we ethically use it only and only if the patient insists on surgery and the size of the fibroadenoma is within that size where we can remove it, rather than taking the patient to theater. But if you start doing vacuum assisted biopsies for every fibroadenoma, it would be very unethical, I would say.
No, we didn't say that. You even didn't say that it should be done for every fibroadenoma. That's why I asked that what is the limit, and there has to be a selective approach to the patient's need and address the need. So good. Thank you very much. It's well done and nice beginning. Thank you all for participating. Dr. Somsekhar, you have to say something?
No, fantastic. I just know Raghu's message. Most important is, how to do ethical, right, evidence-based practice. This is the talk. I always carry this talk to teach my fellowship program students in breast surgery, and also surgical onco students and general surgery students. Fantastic talk, Raghu. Thank you very much. And we can actually take the questions in the chat box later, and it's going to be compiled by Arunima, will be answered. Thank you.
Yeah, thank you very much, chairpersons and Dr. Raghu. And here we just present the e-certificate for participation to Dr. Raghu and our chairpersons, Dr. Somsekhar and Dr. R.P. Srivastava. Thank you very much. And without wasting any more time, we will go on to our next session. And our next session, so our next session starts, and I invite our chairpersons, Dr. Kumkum Singh and Dr. Sheetal Malwa. Dr. Kumkum Singh is the ex-senior professor and head of the Department of Surgery of JLN Medical College, Ajmer, and she is also the Director of Education of ABSI West Chapter. And Dr. Sheetal Malwa is the Professor of Department of Surgery, RIMS, Ranchi, and is the Consultant Surgeon, ex-Secretary of ASI Jharkhand Chapter. Sir, over to you.
Thank you, Arunima, for the kind introduction. I invite Dr. Sanjay Jain for his talk. Sanjay is well known among the ASI. He has held important posts like as being the secretary and the treasurer. And we all know that nipple discharge is a very worrisome problem which can occur, and the patient runs from pillar to post thinking it's cancer. So without wasting much time, I invite Sanjay for his talk. Dr. Sanjay.
Thank you, ma'am. Thank you, chairpersons. And just a minute, let me share my screen. Good noon, everybody. And first, at the very outset, I would like to, I will say congratulate or thanks, because what the East Zone of the ABSI and the Jharkhand chapter, everybody is thinking and planning for an e-conference. They actually did it. So it's a pioneering work, and I really congratulate them. Dear friends, in next 10 minutes, I will be trying to cover the key points in approach and management of non-propural nipple discharge. So the importance of this problem is that this is the third most common breast related complaint after a pain or a mass. So we can understand that means it's so common, and up to 80% of the women will have an episode of nipple discharge during their reproductive years. So the problem is very means it's for majority of the women. It is 5% of the women presenting in the breast clinic, but the sigh of relief is what even Dr. Raghuram said, the majority are benign. The malignancy varies from 3 to 7%, and the incidence may still be higher if there is an underlying mass. Is there any abnormality detected in the mammogram and in postmenopausal women? So they are the high risk patients. Now, to make the topic simple rather than making it more difficult, what is important? Nipple discharge may be a physiological nipple discharge or it may be a pathological nipple discharge. The pathological nipple discharge can further be either a benign discharge or a malignant discharge. And our aim is to differentiate between a physiological and a pathological nipple discharge. And when it comes to the pathological nipple discharge, we have to make sure whether it's a benign one or a malignant one. So these are the few points which are very important. In a physiological, nipple discharge is usually bilateral, while pathological being the unilateral. The physiological is a multiple duct discharge is this physiological, while a single discharge more chances of being pathological. The expressed one is a physiological and a spontaneous, and the copious discharge is a pathological discharge. The color, like multicolored, milky, gray, green, yellow, or brown, they used to be the physiological discharge. The blood discharge, of course, it creates a lot of problem. But what we do not think is the serous or a clear discharge, it is also pathological. So a serous discharge should not be overlooked. And then coming to the consistency, the thick and sticky discharge tends to be physiological, while watery and copious, what I have already told, is the pathological nipple discharge. The various causes for a physiological nipple discharge are hormonal, like hypothyroidism, various tumors which secrete the hormones, like pituitary adenomas. It may be pregnancy related, post-lactational. Mechanical stimulation can cause discharge of the nipple, galactorias, infections like Jushka's disease, a fibrocystic disease, a neonate in what we call the witch milk. These are the physiological. The pathological, fortunately, the two most common reasons. The first is the benign intraductal papilloma, and the second one, which accounts for more than 1/3 of the cases, while the duct ectasia is the second, it amounts to 17 to 36% of the cases. The other causes are papillomatosis, papillary carcinoma, duct epithelium hyperplasia, a ductal carcinoma in situ, invasive ductal carcinoma, or a fibrocystic disease. Now, question is how to proceed if a patient comes to you with the nipple discharge. Of course, the golden rule of triple assessment prevails in each and every breast disease, and breast nipple discharge is no exception to it. So we will proceed with the history and examination. The points which have to be covered, as I have already narrated, whether it's a unilateral or bilateral discharge, single or a multi-duct discharge, is spontaneous or patient has to express. If express, what is the trigger point? Whether this discharge is scanty or copious, is there any history of trauma, medication, itching, associated mass, or fever? Then the color and nature, as I have told you, are also taken in the history, and they are verified by the examination. Coming to the investigations, we have two kinds of investigation again, the imaging and the pathology. So imaging, our regular tools are mammography, high resolution sonography, MRI of the breast, MRI ductography. The two which are addition in evaluation of the nipple discharge are ductography and ductoscopy. I will come to one by one after to them. Then the nipple discharge fluid aspirate, as Dr. When we are suspecting any malignancy, so a cytology is to be done, and the biochemical markers like LDH and carcinoma embryonic antigen, when they are raised, they indicate toward the chances of a malignancy. FNA or the definitive will be a core biopsy or a biopsy that will be definitive in the diagnosis of a malignant nipple discharge. So mammography, the indications are above 40 years of the age, and with patients with pathological nipple discharge, it may be normal even in patients of cancer, or it may miss. So it should not be the final tool. The high resolution sonography is using 13 to 50 megahertz probes. It can detect lesions up to 0.5 centimeters. It has got high sensitivity than in conventional ultrasound, that is to 75% versus 30% in conventional ultrasound. And this is an ultrasound picture showing the filling defect of an intracystic papilloma. The ductography is the evaluation of the duct by cannulation, putting a water soluble contrast. Here, the only change is that we take the images on a mammogram rather than a plain film. The findings seen on ductography are cutoff sign, duct dilatation, filling defect, irregularity of the duct wall, duct narrowing, and distortion. These are the pictures showing the cutoff sign and the filling defect. The ductoscopy is an emerging investigation where a sub-millimeter fiber optic scope is used to visualize the interior. Every and any surgeon would like to love. And these are the pictures where the first one is the normal duct bifurcation we can see, and in second you can see the intraductal papilloma. The recent evidence is suggesting that this can be used not only for diagnostic, for therapeutic purposes also. The main disadvantages are availability, since it is not available everywhere, and the cost, of course, the cost comes with the new technique also. The next is the MRI, and in MRI I would like to say this is an excellent tool. A fusion imaging of MR ductography and contrast enhanced mammography can tell us the extent of disease, size and shape of the problem, and it can also help in planning surgery and breast conservation. Cytology, of course, when it is required, we do the cytology. The sampling method are used. We have to go for cell concentration methods and routine H&E stain or a pap smear. It can, but here something which is very important is the high false positivity or false negativity rate. It limits its use. Coming to the management part, once you investigate a patient, there are two options, two things which may happen, that it may be an isolated nipple pathology. So in isolated nipple pathology, it can be a single duct pathology or a multi-duct pathology. In a single duct pathology, we proceed with the microducectomy. When multiple duct pathology, we do the central or the major duct excision, that is known as the head field surgery. And for there may be the other subset of patient which has got underlying mass or a problem or malignancy, then it has to be treated as per the guidelines of the surgery. This is the picture which shows about the various steps of the microducectomy. Here, the most key point which I would like to tell, you should tell your patient not to express the discharge before they coming for the surgery. Otherwise, it will be very difficult to get the affected duct. And the second point which is important, if you take a periareolar incision, you should avoid taking more than 1/3 or at the max 50% of the circumference. Otherwise, a necrosis may develop. And this is the central or a total or a major duct excision when the discharge is from the multiple ducts. Here, this can be done only on those patients who have completed their family, and since the breastfeeding will not be possible since you remove all the ducts, and the complications are explained well in advance, and these complications include nipple tip necrosis, altered sensation, shape, size, color of the nipple, nipple inversion, and infection or a hematoma. And these risks are more when we do a total duct excision and breastfeeding is no longer possible. So patient does not have the chances of litigating you at a later date. So, with this, I conclude my talk. Thank you very much for patience listening, and thank you all.
Thank you, Professor Jain, for very excellent covering of the topic.
There are no questions in the chat box. But thank you, Dr. Sanjay. And very importantly, what you have stressed is that a periareolar incision should be used always when you're excising the duct instead of putting an incision on the nipple, which many surgeons in the periphery are still doing. So thank you again for a lucid presentation, and we can now move to the next presentation, please.
Thank you.
There are no questions in the chat box.
The chat box questions are coming actually on the YouTube live streaming. So I request all speakers that after your talks, please go to the YouTube live streaming and answer those questions. Thank you very much. And here I would just like to present the e-certificate to Dr. Jain for his talk, Dr. Kumkum Singh for chairing the session, and Dr. Sheetal Malwa for chairing the session. Thank you, chairpersons and speakers. Now we go on to
Thank you.
Now we go on to our next topic, and I request Dr. Vijay Pratap Singh, who is a consultant surgical oncologist and managing director of Savera Cancer and Multi-Speciality Hospital, Patna, who is also the director of education of ABSI East Zone, and Dr. J.K. Chaudhary, senior consultant surgeon, Devghar, to kindly chair the session and introduce our speaker.
If you enable screen sharing for me, please.
Yeah. I'll stop sharing the screen. I was just waiting for the chairpersons. Dr. Vijay Pratap, are you there? Dr. Vijay Pratap? Yes, Dr. Vijay Pratap Singh, can you please unmute yourself and introduce the speaker?
Am I audible now?
Yeah, you are audible.
Yes.
Yeah, please introduce the speaker.
Yeah. Dr. Salvi Radhakrishnan is a well-known figure. She practically is from, she's a consultant oncoplastic breast surgeon at Chennai Breast Center. She has done her DNB FRCS, and she has got special interest in oncoplastic breast surgery and breast imaging. And the topic again is ultrasound imaging and breast cancer. Yeah, as you know, ultrasound is a very handy instrument with a surgeon, and you can do any possible thing with ultrasound. So we hand over the mic to Dr. Selvi. Please take over. Dr. Selvi, are you there?
Yeah, I'm there. Are you seeing the screen now?
Yeah.
Are you able to see my screen?
Yeah, Selvi, yeah.
Yes. Thank you. Thank you for involving me in this meeting. So just like how the gynecologists, obstetricians have taken over antenatal ultrasound, the cardiologists have taken over echocardiography, I think breast ultrasound is something that should become an extended hand of a breast surgeon, and it has a various applications, mostly in diagnostic and assessing the extent of disease, in staging, and also as for interventions. So I'll just run through a few. So it's difficult to do justice for this topic in 8 minutes, but I'll do my best. I'll run through a few slides explaining its role in diagnosis, staging, and in interventions. So one has to learn the language of ultrasound. And when you look at standardizing the reporting systems, BIRADS is a standard criteria based on which the reporting is classified as lesion of BIRADS 1, 2, 3, 4, 5 up to 5. And for a biopsy proven cancer, we use a BIRADS 6 criteria. So the BIRADS uses some standard terminology to decide on the criteria. So I've just pulled out the most significant ones, something simple which surgeons can understand and start looking for it when they see ultrasound images. So to start with, look at the shape of the lesion. So, it falls under 3 categories. So it's all, the terminologies are the same. And I think one should standardize these terminologies, and it has to, the shape when you describe has to fall under one of these 3 things: rounded, oval, or irregular. When you look at margins, it has to be one of those 5 things: circumscribed margin, like you see a margin all around; indistinct margins, where you don't see a border clearly; and spiculated margins. So you see those nice fine spicules around, so that is a spiculated margin. If you see an angle like this in the lesion, it's called a lesion with an angular margin. And if you see small lobules like this, it is a microlobulated margin. So the margin assessment should fall under one of these 3 criteria, one of these 5 criteria. Of course, you can have more than 2 types of margin in the same lesion. Partially it might be circumscribed, partially spiculated. So that all depends on the biology of the lesion, but the descriptive terminology should fit into one of these criteria. The third thing that you look for in ultrasound is echogenicity. So echogenicity is in relation to the surrounding fat. So the surrounding fat should be set medium gray, and there is usually, there are standard ways in which you set the gain in the ultrasound machine. So the fat is set at medium gray, and against which the lesion is compared. So if you look at this lesion here is brighter than the fat here. So this is usually, fat is brighter than a lipoma is usually brighter than the surrounding fat. So this is clearly a lipoma. So this is something, when you see something bright like that, you can dismiss it off. It's clearly a lipoma. It's benign. Nothing further needs to be done. And if you look at this here, the surrounding density is the same as the lesion here. So you would call it same echogenicity. So we would call it isoechoic. Here it is hypoechoic. When it compared to the surrounding fat here, this is darker, slightly darker. So it's hypoechoic. And again, there is no feature in this. It's completely black. So that is anechoic. So anechoic is obviously fluid, cyst. Hypoechoic is usually malignant. Isoechoic is usually benign, although you find some benign lesions that are hypoechoic too. So these are the criteria to describe echogenicity. And then the orientation next. So benign lesions respect tissue planes. So they are oriented in a transverse plane, because they don't fight against the surrounding tissue to grow. So they respect tissue planes, and therefore they are more parallel in orientation, more horizontal in orientation. So the horizontal diameter is larger than the vertical diameter, whereas malignant lesions do not respect any tissue planes, and they would just infiltrate wherever possible. So these lesions generally, not always, but generally are taller than it's wider, like a cone tree, like a pine tree that is taller than it's wider. Then the next feature that you look at is the posterior shadowing. So what happens behind the lesion? When sound waves pass through the lesion, does it get attenuated? Does it get enhanced? Or is there any feature at all? So this is actually, obviously, when there is fluid, it gets enhanced. So this lesion is a cystic lesion. So this is a cyst with a little bit of turbid fluid there, and you see it enhancing. This is a very water-containing lesion. So this again is attenuating behind. So if you see this lesion, it does not do anything behind. So it is the same as the rest of the surrounding tissue. So this would be no posterior enhancement. Whereas here in a malignant lesion, if you see, it throws some shadow behind. It's called after shadowing. So this posterior acoustic shadowing is classical of a malignancy. So sometimes you find this even in, basically sound waves do not go through, and it's hard, it does not pass through. That is why it's shadowing behind. So it can happen in calcified fibroadenomas too. So that is why it's always best to compare an ultrasound image with the corresponding mammography image, just to make sure that you don't end up calling this malignant and end up biopsying your needle only bend and break, because it's all stone hard. So the next thing is what happens to the surrounding tissue. This boundary of the lesion is usually where the reaction to the tumor is, the body's response to the tumor. And generally in benign lesions, there is no reaction, because again, it is benign, so therefore there is no host response. Whereas in a malignant lesion, there is a lot of host response. And that is usually seen as a little halo around the lesion, so that the boundary is usually brighter than the lesion and the fat. And you see a halo there. And then sometimes you see calcifications within the lesion. And so, mind you, calcifications can be seen better only when there is an hypoechoic site. Calcifications alone cannot be imaged very well on ultrasound, but if you have calcifications within a lesion, that is usually seen on ultrasound. And then you look for extensions from the lesion. So you see satellite nodules, you see duct extensions like this. This usually means there's some DCIS component. This helps us surgeons to plan excision. If you see this, you would take a bit more tissue on this aspect of the, so you see those little nodules. So when you do an excision, apart from that 1 centimeter margin, you actually take a bit more on this margin. So again, here you see this is a lesion, some specks of calcification. You see a duct that is going all the way up to the nipple there. If you see that, you won't just do a breast conservation doing that. You would want to excise this lesion, this extension as well. So it's useful for planning. Another example to show how you find satellite areas and then duct leading up to the nipple. And then you also find some distortion of normal architectural distortion in ultrasound too. And then you look for vascularity. So when you put a Doppler, benign lesions usually grow in the periphery, and you see a lot of blood vessels in the periphery of the lesion, whereas malignant lesion, there is a lot of neoangiogenesis and there is central vascularity too. And particularly, you can see this very clearly here in a cystic lesion, in a solid component of a cystic lesion. So usually papillary lesions present like this is a lot of cystic component, and there is a solid component attached to the wall. And to differentiate it from a debris, you put a Doppler, you see a lot of blood vessels. Whereas if it's a debris, you won't see any blood supply. And then the other feature that most of the newer machines have is elastography. So based on the principle, Pascal's law, based on the principle that benign lesions are elastic and therefore are soft when you examine on elastography, whereas malignant lesions are hard. Because they're more scabrous in nature, they are hard and therefore exhibit certain amount of lesser elasticity, and it's perceived as the hardness. And so different vendor-driven calculations are there. Some of them use strain principle, some use shear wave principle. So it's color-coded, and it's more a learning curve when one gets it. So the other thing what ultrasound is useful for, apart from diagnosis, apart from assessing the extent of the lesion, is to stage the axilla. Now, axillary management is equally important when you as the primary, and just like you like to conserve the breast, axillary conservation has also become equally important, and the sentinel lymph node biopsy has become the standard of treatment now, particularly in node negative stage 1 and 2 breast cancer. So if you see an axillary lymph node here, so that is a cortex, it's a uniform cortex, there is no unequal thickening, and you see a nice medulla, and you see a blood vessel going into the lymph node through the hilar vessels. So normally blood supply to the node, it's maintained its shape as well. The blood supply to the lymph node is usually hilar. And if you see this node, this is obviously a metastatic node. So this has an unequal thickening of the cortex. And not only that, there are blood vessels from the periphery of the lymph node. That usually means that it's a metastatic node. So through a process of neoangiogenesis, develops blood vessels all around the capsule. So this is obviously a metastatic node. So why? And then the third most important therapeutic application is, diagnostic application is image-guided biopsies. So why do we need to use image guidance for biopsy? Why? Because it's inaccurate. It's surprising how much you can actually mistake the depth of the lesion, and you think by holding it clinically and putting a needle, you're going through the lesion, but in fact, you end up going away from the lesion either anterior, posterior, or above or below, and miss the lesion, and then you get a wrong diagnosis. So you visualizing it on ultrasound, the biopsy is targeted accurately, and then in a lesion like this, so this is actually a triple negative breast cancer, you see the lesion is necrotic in the middle. So triple negative breast cancers, high-grade cancers grow very fast. It outgrows its blood supply and the center becomes necrotic. And this, if you put a needle in and take a biopsy without guiding it, then your pathologist is going to tell you there's only necrotic tissue. So you don't have a clear answer, which is why guidance is useful. You put a needle through the periphery of the lesion where there is more hypoechoic tissue, where there is viable tissue. And then you will also avoid creating a hematoma. When you see a Doppler like this, you can put a needle there and then avoid hitting that blood vessel. So as surgeons, we do not like hematomas before we operate, because we go by finger palpation when you plan a breast conservation. And you have a biopsy related hematoma, your assessment of intraoperative assessment of margins by palpation becomes very challenging. You end up taking less tissue or more tissue, and that can be avoided by guiding your biopsies appropriately. And then the other application for ultrasound, obviously, will be placing markers. So when you see a lesion on ultrasound and you want to give neoadjuvant chemo or hormone therapy, and then intend to conserve the breast at a later date, post-therapy, then you would like to leave behind the marker. So this is a lady who actually had neoadjuvant hormone therapy. So we put in a marker here. So you can see the marker actually ideally should be in the center, but this is slightly in the periphery. And this is pre-therapy. So this is the start of the treatment, and this is after 3 months of treatment. And you see the lesion has responded considerably, and you see the marker still there. So and this is how it looked on mammogram. So you actually see the marker there in the periphery of the lesion. And then the lesion disappeared after treatment, and you see the marker more clearly, where in mammographically the marker has, the lesion has disappeared. So, and then it is useful to actually target the marker and do your limited excision post neoadjuvant chemotherapy or hormone therapy. And the other important application for ultrasound is biolocalization, because if you have small non-palpable lesions, it is important to localize correctly to remove the targeted lesion adequately. So otherwise you might end up just as, we keep seeing this off and on in practice. So if somebody just goes and does a blind excision, takes out some bit of normal tissue comes back as normal, you reassure the patient, and then she comes back with a very bad disease. So this is very important to localize. So you put a hook wire under ultrasound guidance. You see that hook wire there, and that actually you position it in or around the lesion, and then excise the lesion, get a specimen X-ray done to make sure that the lesion is excised with the hook in situ, and send it to the pathologist. And we heard some earlier discussions about VAC-guided excisions. Yes, I would reiterate, small fibroadenomas, if you're sure that it's a fibroadenoma, do not need excision. And if the most common application for VAC-guided excisions will be papillomas. And so the papillomas, generally we're not comfortable leaving them behind. So if there is a nipple discharge, majority of nipple discharge are due to papillomas, and you can actually excise them using a vacuum-assisted excision. So that vacuum-assisted excision needles are usually 9 or 11 gauge needles, can be as big as the little finger, and just done very much similarly to the core biopsy, except that instead of going through the center of the lesion, you can actually place it at the base of the lesion and open the trough. This is usually single pass, so you don't have to keep taking the needle out. So once you position it, so some vendors have the rotating mechanism, some actually has this mechanism where you just place it below the lesion gets sucked into the trough, and you keep cutting. And when you're happy that the excision is complete, then you take out the needle and send it for histopathology. Again, if there is a suspicion of malignancy, it's better not to do this, because you can't assess margin, and a lot of things, becomes messy if it is so that's why you have to have a biopsy proven diagnosis before a VAC excision is attempted, and then a clear plan to excise. So I think I've kept in time and finished it all, although I had to sort of gallop with like a speed train. So if there are any questions, I can take.
It's not a question, it's an appreciation, Selvi. 10 years back, when I was president in 2009, your efforts, we had started appreciating. And a decade later, you are such a phenomenal speaker and such a volume of experience you have put in your slides. I appreciate.
Thank you, sir.
So if there are no more questions, I think, thank you, Selvi, for the excellent deliberation. And now we'll move to next speaker. Hello. Hello.
Hello.
So should we conclude to move to the next speaker now?
Okay. Vijay, unmute yourself and then say. Arunima, take over to the next speaker then.
Yeah.
Yes, sir. The questions are coming in the YouTube box. If you all can please go to the live streaming of YouTube. The questions are coming there, and I request the speakers to please go and yeah, so we would just like to give a e-certificate to Dr. Selvi Radhakrishnan for her talk and Dr. Vijay Pratap.
Thank you, Arunima.
And Dr. J.K. Chaudhary has not been able to join in, but anyways, hopefully we are going to see him. He's a bit caught up somewhere, as Dr.
He is actually caught up. He is actually caught up in caring for a relative who is afflicted with COVID. That's what he told me just now.
So we move on to the next topic, and I invite Dr. Anand Kumar Mishra, Professor and HOD Endocrine Surgery from King George Medical University, Lucknow, and Dr. Muhammad Azad, Senior Consultant Surgeon, Giridih, Jharkhand, who's the Secretary of the ASI Jharkhand Chapter, to take over the session.
Hello.
Yeah.
Good afternoon, everybody. Our next topic is pain management in breast diseases, and it will cover both benign and malignant conditions. And for this, I would like to invite the speaker of the topic, Dr. Samita Chatterjee, Professor, Department of Surgery, IPGMENR, SSKM Hospital, Kolkata. Over to Professor Samita Chatterjee.
Thank you, sir. Am I audible?
Yeah.
Good morning, everybody. Really feel privileged to be part of this ABSI initiative, and I thank Sunil sir and Arunima for keeping me in mind. My talk today is pain management in breast disease, and what I realize is a part of it will be overlapping with Dr. Raghu has said. So I'll skip through those parts as much as possible to make up for time. When we talk of the word pena, pain, it comes from the Latin word pena, which means suffering. Suffering inflicted because of something wrong that you have done. But the first thing that ladies need to know that they are not being punished for something wrong that they've done. But the fact remains that it is very common, but it is still a big enigma. Though it was described way back in 1829, it still seems to be underestimated, and often the effect it has on quality of life is also ignored both by the patient as well as the treating physician. The etiology and the optimal treatment also remains undefined, leading to a lot of confusion, a lot of fluctuations in treatment in all over the places. Now, what is the main concern when a lady comes to you with breast pain? Her biggest fear is that she may be suffering from cancer. That is the main concern. At the same time, we cannot forget that severe pain can also affect her quality of life and interfere with her daily activities. And persistent pain can cause a negative physical and psychosocial impact on patients' lives. 80% of women experience breast pain in some part of their life or the other. 80% is a huge number. And even if the pain is mild, you can imagine how great the total magnitude of that will be. But the only blessing is that only 5% of patients who present with breast pain also have associated breast cancer. So you really cannot ignore those ladies who get concerned about the pain and when they suspect that probably it is due to cancer. So mastalgia, thankfully, is mostly, I emphasize, mostly a feature of benign breast disease. Now, whenever a patient comes to you, what are the issues that you keep in mind? Is it mild, moderate, or severe? Is it unilateral or bilateral? Is it intermittent or constant? Cyclical, non-cyclical, focal, diffuse? Is it associated with any nodularity or lump or any nipple discharge? Now, when we answer all these questions, the only way to know it is go through a very thorough history and clinical examination. Investigate judiciously. I emphasize judiciously because we should not get overboard with our investigations. The whole idea is to rule out cancer, and we have to reassure the patient and thereby manage it. Now, as Dr. Raghu has already said, that there are of three types: cyclical, non-cyclical, and extramemory. Cyclical being the commonest one, and it is usually predominant in the third or fourth decade. It is related to the menstrual cycle, more in the luteal phase, that is the second half, relieved by onset of menstrual flow, and may be resolved with a hormonal event like pregnancy or menopause. The good thing is that it is usually bilateral, poorly localized, and more in the upper and outer quadrant. And many ladies will complain that it radiates to their arm and axilla. It may or may not be associated with a nodularity. Now, to establish a cyclical mastalgia, we must ask them to chart their pain and see that whether there is at least 7 days per month of pain duration and the relation of the pain with their menstrual cycle. Non-cyclical mastalgia, on the other hand, about 1/3 of the cases, it is constant or intermittent, not associated with menstrual cycle, and it usually happens in older ladies and also maybe postmenopausal. Anatomical causes are much more than hormonal causes in these cases, and the crux of the thing is that we have to rule out a neoplasm. There are a lot of medications which are associated in mastalgia. The list is long, but the common things we must remember in a young lady: is she on oral contraceptives? Is she taking antihypertensives? Domperidone, another medication which is used randomly by patients. So if there are histories of these medications, that also has to be kept in mind when we are dealing with mastalgia. Extramammary pain, on the other hand, is because of a pain of some other origin, which is mimicking a breast pain. So again, there may be a lot of diseases, but the commonest, as Dr. Raghu had said, was either costochondritis, but we should not forget that it might mimic angina, a pulmonary embolus, or even a cholelithiasis or a peptic ulcer disease. So again, the necessary investigations will only rule out whether we are dealing with a real breast pain or an extramammary pain. Principles remain the same: a good triple assessment, meaning a history and clinical examination, a good imaging, it could be a bilateral USG or a mammography, pain assessment and documentation, and obviously a histopathology if an associated lump is present. But most importantly, we have to rule out malignancy. Even a single patient should not miss your radar if it is suffering from malignancy. If you make a list of management protocols, I think the first Y10, it could be the 100, will be reassurance, reassurance, and reassurance. You have to explain to the lady that, no, this is not cancer. And let me assure you that this, when you do this effectively, half your job is done. Improve mechanical support adds to it. And there are a lot of other practices like warm process, gentle massage, relaxation technique, low-fat diet, caffeine restrictions. We have variable reports about each of them, but they're such harmless things that if you explain it to the patient and she gets relief out of it, I don't think there is anything to lose from that. So the good news is that most patients will respond just with this, but there will be a 15% who will require pharmacological intervention, and surgical treatment is rarely ever needed. Now, when you talk about pharmacological management, there's a long list of medications, but honestly, if you look at the left side, the column on the left, most of them are not used anymore. Now, regarding the ones on the right also, they all have historical value, but most of them have gone into disrepute and disuse. Evening primrose oil, beautiful flower, beautiful oil, but is it effective in benign breast disease, nostalgia? Studies have shown that the effect is equivalent to a placebo, though some centers still prefer to use it, particularly our gynecologist friends are very fond of it. But let me tell you, it has been proven that it is equivalent to a placebo. Danazol used quite commonly by our senior colleagues, but the initial dose has also been variably reported to between 100 and 400. Those that use it ask for about a 50 milligram BD. But the problem is there are intense androgenic adverse effects. A lady might have eruptions on her face, lose hair, change in voice, weight gain, none of them which is welcome by her. And obviously danazol is not used anymore. Tamoxifen, another common drug used. It's a selective estrogen receptor modulator, useful both in cyclical and non-cyclical. But this again has adverse effects like DVT and endometrial carcinoma. The point is these adverse effects are usually with long-term use of tamoxifen and not the 10 milligram per day, 3-month course that we generally prescribe for benign nostalgia. Initially, a 20 milligram per day dosage was used, but by reducing it to 10 milligram, it's been seen that it is equally effective, but fewer side effects. But when you are using tamoxifen, the very important thing is that you have to counsel the patient very well. Because the moment she goes to the pharmacy to pick up her medication, she will be told by somebody or the other that this is a treatment for cancer. And I'm sure you're having cancer, even though your surgeon has not told you so. So do counsel her that yes, it is a treatment for cancer, but in the dosage that we are giving, for the duration that we are giving, this is definitely not for cancer, just for your pain. So counseling has a very important role when you are prescribing tamoxifen. Centroman, another very commonly used drug now, a made in India drug that we can be very proud of. Another non-steroidal selective estrogen receptor, that is ormeloxifene. It has a potent anti-estrogenic activity in breast and uterus. Initially, we were trying it for 30 milligram alternate days, but we found that patient compliance for alternate day therapy was poor. So now we are giving it at 30 milligram daily. It's cheap, easily available, and very comfortable for our patients from our country. It does cause some menstrual irregularity, but that's in a very small percentage of patients. And it is very safe in unmarried women or young women who wish to conceive, because very quickly after termination of therapy, the lady can get back her fertility. If she is breastfeeding, the amounts that are secreted in the milk is also so minimum that there is no deleterious effect on the suckling babies. Side effects, unlike tamoxifen, danazol, and the previous ones, are very low. And I hardly have any patients who come back to me telling me that they've had any problem other than the menstrual irregularity. Lots of trials on centroman, and most of them have gone favorably in there. Last but not the least, we cannot forget the NSAIDs. It may be oral or topical gel, and effective in both cyclical, non-cyclical, and extramammary pain. Oral is more potent, but obviously it has its side effects. And it was seen that when you put in the apical gel, the effectivity is equitable. At the same time, the side effects are minimum, easy to apply, and results are comparable to the hormone-containing drugs, with none of the side effects that we commonly see with the hormone-containing drugs. Now, if I go to this chart and we come to this patient with nostalgia, obviously the first thing will be the triple assessment. Now, if you find a lump or anything which tells you it could be going in that size towards malignancy, obviously you work along that line. If your examination is normal, your imaging is normal, the first thing, and why first 10 things that you do is reassure her that there is nothing much to worry. And as I said, about 80 to 85% patients, that is all that you need to do. But there will be those small percentage of patients who will be requesting treatment, who will be requiring treatment. And what I generally start off is with a topical NSAID locally for 3 months and usually get good response. If somebody does not respond to this, I don't jump to tamoxifen immediately. I put centchroman in between because of the stigma that tamoxifen is associated with and the side effects which may be seen in some patients. So I generally squeeze in centchroman here. Up the ladder, if I at all need to go up, will come tamoxifen, and danazol, definitely I don't use it anymore. Now, in certain literature, goserelin has been told, but I have never used goserelin. But literature says that in patients who are not responding to any of the usual treatment, a 3.6 milligram monthly subcutaneous injection may be given. But remember, again, there will be a compliance issue. And again, it may induce rapid relief of symptoms, but then there are again side effects. I'll be honest, I've never used goserelin. Now, if you think about, now these were the ANDES that we were thinking about, all the benign causes. There are some other common benign causes that we cannot forget when we talk of breastfeeding. Has there been a history of trauma? Is there any mastitis, any abscess? The common things that we always get in our general surgical OPD. So the pain management, treatment modality remains the same. You give good analgesics, you give good breast support. If she's a lactating mother, ensure that she's emptying her breast. Warm fomentation does help, but please do again counsel her that she need not stop breastfeeding her child. Now, if it progresses to an abscess stage, obviously antibiotics may be needed. We generally do a USG guided aspiration, and in those rare cases where there are too many loculi, we are not being able to empty it, an incision and drainage may be required. Non-lactational mastitis, the treatment protocol remains similar to lactational mastitis. But we have to definitely rule out malignancy in these cases. Now, we said that most patients of mastalgia are actually suffering from a benign breast disease. But you do have some patients of malignancy who also suffer from pain. And this is something we have to be extra cautious about and extra sensitive about. Now, a patient complaining of only pain as a presenting symptom in breast cancer is extremely low. It may be associated with a breast lump, and a breast lump with pain is seen in about 5% of cases. Early breast cancer seldom present with pain, and the pain is usually either due to disease progression or due to treatment-related side effects. So when it comes to disease progression, classically, it is a unilateral, constant, and intense pain. There may be either pain due to stretching sort of a pain due to rapid enlargement, or due to posterior infiltration into muscles, ribs, and intercostal nerves, not to forget inflammatory breast cancer, which has its own presentation. Pain due to treatment-related side effects, post-mastectomy, some of the patients feel the phantom breast, just like a phantom limb after amputation. She might suffer from chronic intercostobrachial neuralgia, pain due to other nerve injuries, neuromas, and a very sensitive scar. Post-radiotherapy, there may be painful lesions at the radiotherapy site, where the skin care with lotions and emollients become an integral part of the treatment. And we cannot forget the cervical or the brachial plexopathy, which is often associated with radiotherapy. Again, there can be pain due to metastasis, obviously an abdominal pain if there's liver mets, bone pain with bone mets, severe headache with brain mets. So the International Association for Study of Pain have found that persistent pain after surgical intervention is more in younger patients, those who've undergone axillary dissection, and those who are receiving radiotherapy. So that's a large number, and we really cannot ignore the symptoms of these patients. And 20 to 50% suffer neuropathic pain after surgery. Now, in malignancy, the main crux of pain management is pharmacotherapy, but the principles have to be very clear. They're usually oral analgesics. They have to be by the clock. You have nothing like an SOS treatment. You have to put it by the clock. You have to follow the analgesia ladder. You cannot jump steps. And obviously, you have to individualize it according to the patient's symptoms. So the WHO analgesic ladder says that in mild pain, you can go for non-opioids like paracetamol, ibuprofen, or diclofenac. Mild and moderate pain may need a weak opioid like a tramadol, but there will be patients with severe pain who might need strong opioids like morphine. Now, in addition to the analgesics, you might need some adjuvant medication like tricyclic antidepressants, pregabalin, that is a gabapentinoids. You might need steroids like prednisolone and dexamethasone in some patients. And in case of bone pain, you might need bisphosphonates, that is zoledronic and pomidronic. Post-mastectomy pain syndrome, we often use local anesthetics in addition to pregabalin and amitriptyline. In bone meds, in addition to bisphosphonates, you might need external beam radiation therapy. Painful brain meds, in addition to radiotherapy, may require stereotactic surgery, and liver meds with pain might respond to systemic chemotherapy.
Dr. Shamita, can we finish it?
Just give me a minute more, sir, if you wish.
Yeah.
Okay. So last but not the least, we have to remember there is something called interventional analgesia, and our pain clinic colleagues are very fond of it. And there are only about 2 to 5% patients with advanced cancer who might require, who might not respond to the oral analgesics and may benefit from image-guided nerve blocks. But the recommendations are still weak, and we are not following it very routinely. Non-pharmacological therapies definitely do help. A lot of these relaxation, yoga, music therapy, whether you believe it or not believe it, there are patients who do benefit from it. So in ending, we have to remember that you will have most of your patients who will respond just to reassurance. There'll be some who will need a solution, and there'll be some like those with advanced malignancy who, in spite of everything, do not get comfort. So you have to offer solace to them so that the pain can at least be bearable for them. Thank you so much for giving me this opportunity. Thank you.
Thank you, Dr. Shamita. It was a wonderful lecture. I enjoyed it. I think all listeners must have enjoyed. Actually,
Thank you so much.
We are slightly late in the schedule. So maybe we will take the question on the chat box only.
Right.
So
I'll request all speakers that once you finish your talk, please go on YouTube live streaming, because the questions are coming there, and I request you all to answer the questions there.
That will be okay, because we are slightly late, so we can answer the questions on the chat box only.
Thank you. Thank you so much.
Thank you.
So we end this session and we present this e-certificate to Dr. Shamita, Dr. Anand Kumar for chairing the session, and Dr. Muhammad Azad for chairing. And now we go on to our next topic. And I invite chairpersons Dr. Vijay Pratap Singh, consultant surgical oncologist and managing director, Savera Cancer and Multi-Speciality Hospital, Patna, and Dr. Abhiram Maji, associate professor, Department of Surgery, Calcutta National Medical College, who is also the ABSI Executive Committee member from East Zone. So please take over.
Thank you, Dr. Ridima. Am I audible?
Yeah, you're audible.
Yeah. So here we have a stalwart, Dr. S.V.S. Dev. He heads the Department of Surgical Oncology at AIIMS, New Delhi, and President-elect for ABSI. He was the treasurer for Breast Surgery International, in charge of Delhi Cancer Registry. And frankly, Dr. Dev does not require any introduction, because he is well known all over, not only the country as well as the world, I would put it as. So his topic is incision planning in breast surgery. Over to Dr. Dev, please.
Thank you, Dr. VP Singh. I need permission to share my screen. Yes. Thank you, Dr. VP Singh. We are running behind schedule. So what I would like to do in my talk is to quickly finish a very important topic, that is how to plan incisions for breast surgery. Uh, a lot of surgeons, it is not the breast surgeons. If you see the breast surgeries, these problems are very common and they're being handled by general surgeons, breast surgeons, endocrine surgeons, surgical oncologists. A wide spectrum of surgeons handle breast problems at a community level. And majority of the surgical procedures, if you see, the various kinds of incisions are being used. If you see the patients in the clinics, there are no ground rules which are followed in most of the situations. The trainees and the surgeons who practice breast surgery should need to know certain important fundamental points with scientific basis and which have a bearing on the cosmetic and long-term outcome, how to plan incisions for various conditions of the breast diseases. Any breast surgical procedure starts with creation of incision, it ends with the closure of the incision. And as far as patient perceptions are concerned, it is the incisions and scars. That's what when she wakes up from anesthesia, this is what she looks at, not the complexity of the procedure. She is not witness to what you have done. So the scars and incisions are very, very important from patient's point of view. A modern breast surgeons who are practicing breast surgery in the current era should have a domain knowledge in the anatomy, the vascularity of the breast, the radiology, the pathology, medical and radiation oncology parts, surgical and oncology parts, as well as plastic surgery awareness, and certain basic skills are very, very important. You should integrate in the thought process the aesthetic and cosmetic outcomes of breast surgery. When you plan a patient, when you see a patient in the clinic with a breast problem, if you decide for surgery, your minds should start clicking, not only the exposure, the removal, but also the final cosmetic outcomes you have to keep in mind. So your ability to imagine, visualize the final surgical outcome, okay, that is very, very important. Always try to visualize, take the radiology information, see the breast size, where the lesion is, what kind of incision you want to use, and what will happen after you close the incision. So this mental exercise has to be done before you go to the operation theater. So what are the aims and objectives of a good incision for a breast surgery? They should be aesthetically placed, should cause minimal scar burden, should give adequate access to optimal cancer surgery, and it should conform with the needs of reconstructive surgery if you're planning some oncoplasty. You should always balance your oncological and aesthetic and reconstructive surgery needs. The incision should complement both the components of surgery. The important point is there should never be a compromise on the oncological aspects of surgery for the sake of cosmesis. Okay, so you should never compromise if you are dealing with a breast cancer. For a good cosmetic outcome, never compromise and violate oncological principles of surgery. Okay. Optimum size of incision, there are no fixed dimensions. It varies from patient to patient. Gone are the days where big surgeons use big incisions. Now big surgeons are using, in the era of minimal access surgery, they are using small incisions. What is the ideal location of incision? So there are certain points, certain tips in the breast area where you can hide your incision. When you plan your surgery, you can hide this incision. That includes the inframammary crease, the periareolar area, and the subaxillary area. I will show you a picture. So whenever it is feasible, you can use these locations. You see here in the subaxillary area, you can use any lump located in the upper outer quadrant, or if you're using incision for axillary access, sentinel node biopsy, you can hide your incision here. And for any tumor located in the central quadrant around the nipple areolar complex, you can use a periareolar approach. And any tumors located in the lower quadrant, you can nicely hide your incision through the inframammary crease. So these are the certain areas where you can hide your incision when you plan your surgery. Types of incision for a breast tumors, you have either a direct access or an indirect access. What do I mean by direct access? Means you give an incision directly over the tumor where you are palpating and try to remove it and down. Okay, you go straight down to the tumor and remove it. That's a direct access. In certain benign conditions and certain malignancies where the situation is suitable, you can go through an indirect access. That means tumor is located somewhere here, but you are going through a separate incision, periareolar incision, and you're creating a tunnel and trying to remove the tumor. That's called indirect access. You need more experience, especially if you're dealing with cancers. In the beginning, I would urge all the trainees to practice a good direct access first. You should know how to remove a tumor with a margin negative resections through a direct access. As you gain experience, you can start doing the indirect access. Always remember the important anatomical landmarks of the breast. Okay, the God has created a beautiful organ. It has got certain anatomical landmarks. Always keep them in mind when you plan your surgery. The most important is the inframammary crease. Never violate the inframammary crease. Nipple areolar complex. Remember the size, location, and symmetry. And it is a paired organ. So whenever you are planning a complex surgery, always keep the contralateral breast in the field of surgery. So you can always see the contralateral side and match the size and shape of the breast when you suture it back. If you are operating on a single breast alone, sometimes you are in a rush and you try to close in whatever form it's comfortable. But if you keep the contralateral breast, always it will remind you, okay, what is the normal breast. So you can always see that and try to achieve a good cosmetic outcome. Adhere to normal anatomical boundaries. When you do a mastectomy, remember this, never violate these anatomical boundaries. Superiorly clavicle, inferiorly inframammary crease, medially its lateral border of sternum, and laterally its axillary fold, anterior axillary fold. Always remember them. You should be familiar with the Langer's lines or skin tension lines. It's very important. In a breast, the orientation is different, but never violate these lines because they will end up with a bad scars and a distorted breast in the long term. You should always plan incisions which are parallel to your Langer's lines. In the breast, if you see, this is how the Langer's lines are. In this, you see, this is circumarular part. This is when the patient is standing. This is how the skin tension lines fall here in the upper part. So your incision should be either periareolar or linear here. Never give vertical incisions in the upper part of the breast because you are cutting across the tension lines and they will heal in a very awkward fashion. Coming to the lower half of the breast, if you see the skin tension lines are vertical. So you can use these incisions, radial incisions in the lower half. So what are the factors that will affect planning of incision in a patient? Every patient you need to individualize. All right. The various factors which can affect your incision include the patient-related factors, tumor-related factors, treatment-related factors, and what's your expertise. Patient build and body habitus. What is the breast size, shape, how much of ptosis, what is the NAC size? Always keep it in mind. If you are a postgraduate, if you are working up a patient, even if you are treating a fibroadenoma or a benign condition, try to document these findings in your clinical assessment because this will give you a good idea how to plan your incision. Every patient is different. So previous surgical scars, any comorbidities, tumor-related factor, where the tumor is located, whether it's central quadrant, peripheral quadrant, always put a picture in your clinical assessment. What is the size of the tumor, distance from NAC, skin involvement, is it single tumor or multiple tumor? So all these factors you need to assess. So when do you remove the skin if you are doing a breast surgery? All right. So for a benign tumors, it's rarely required to remove any part of the skin. All right. Unless it is a very advanced benign phyllodes tumor with stretching of skin or something like that, there's no need to remove the skin as a part of excision. As far as biopsies are concerned, so there is a myth that you should access the core biopsy tract. It is not mandatory. A core biopsy site and the tract, there's no need to access the tract. Oncologically, there's no need. But if you are encountering a patient with an incision biopsy or open biopsy, always include that scar in the excision. All right. And whenever a tumor threatens the skin, it's very close to the skin, we should always include a little bit of skin as an anterior margin. So these are the indications for removal of the skin when you plan a breast tumor excision. So here, if you see, this is a central quadrant tumor close to nipple areolar complex, stretching the skin. So if you want to do a central sort of excision, you need to excite the nipple areolar complex as well as part of the skin to get adequate margins in this malignant tumor. Assessment is very important. You see these patients, once you take the history, always assess these patients when they are comfortable, when they are alone, always take the help of a sister. Examine them in a standing, sitting, and supine positions. Because what normally happens, you examine these patients in a standing or a sitting position, but you operate them in a supine position. So whole anatomy changes. So what you feel, the location may totally change when the patient is in a supine position. So do these assessments pre-operatively, measure the landmarks. You can put a skin markers if you are planning a complex breast surgery. Do all this in the preoperative phase. And in complex surgeries, make it a habit to document. The photographic documentation is very, very important in most of these patients. Intraoperatively, how do you position your patient is also very important for breast surgeries. If you see the symmetry, it's very important. Don't put big pillows, don't roll over the patient, it will distort the anatomy. Patient should be in a neutral position, avoid hyperabduction of the shoulders, keep both the breasts in the field if you are planning complex surgeries, and exactly abducted at 80 to 90 degrees, both the arms, so that both breasts are symmetrical, there is no distortion, so that you can achieve good cosmetic outcome. So positioning on the table is also extremely important whenever you are going for complex breast surgeries. Don't use big pillows, big supports, and extreme rotation and extreme abduction, hyperabduction of the arms. Coming to breast conservation, you have what kind of incisions that are recommended for breast conservation. It depends what kind of surgery you are doing. It's a with oncoplasty or without oncoplasty. You can use either a single incision for a tumors located close to the axillary tail and upper outer quadrants for both axilla as well as the primary, or normally it is recommended to use two separate incisions for primary and axillary dissection when you are dealing with a breast cancer where the tumor is located away from the upper outer quadrants. And certain golden rules. Tumors located in the upper half of the breast, always avoid radial incisions. Never use a radial incision if the tumor is located in the upper half of the breast. Use a circumarular or elliptical incisions in the upper half of the breast. Tumors located in the lower half, you can use radial incisions. You can use inverted T. I will show you some pictures here, and reduction mammoplasty approach. They heal very nicely. So every patient is different. Depending, you see here, there is a wide variety of tumors, wide variety of patients, wide variety of breast sizes. Your approach is different in each and every patient. You see here in the upper part, we are using a curvilinear incisions. Upper outer quadrant, you are using a single incisions. And here already the patient had a scar. You cannot avoid it. You are using an incision which encompasses the scar. And upper medial quadrant, again, you can use a curvilinear incisions. For a tumors located in the inferior part, I told you a radial incision or a V or inverted T. So these are good approaches. You can see how these wounds can be closed nicely without distortion of the breast. Never use a circumarular or a curvilinear incisions in the lower part of the breast that will distort the entire ptosis and inframammary crease and can cause bird beak deformities. For coming to mastectomy, this is the last part of my talk. So what are the incisions? So we have a lot of types of mastectomies in the current era. When we were residents, we were only aware of a radical mastectomy, modified radical mastectomy, but we have a whole spectrum of mastectomies, including skin sparing mastectomy, non-skin sparing mastectomy, skin reducing mastectomy, nipple areola sparing mastectomies. Okay, so you must be familiar with these technologies and terms. And the conventional mastectomy incisions, which you perform for a patient with breast cancer, are mostly elliptical or transverse in nature. You can modify these incisions depending on the breast size, either into a sigmoid or modified Weiss pattern incisions, so that you can achieve a good tension-free closure. Here you can see these are the common traditional mastectomy incisions, the transverse elliptical incision, and this is a oblique incisions. If the patient is small, the breast is small, you can change your incision into a sigmoid incision or a Weiss pattern incisions. So these modifications can be used to achieve a good tension-free skin closure and removal of the tumor. Okay, so these are certain modifications which can be used, and these are the not common incisions. We mostly use for a nipple areola or a skin sparing mastectomies. We use either the circumarular incisions, transareolar incisions, inframammary incisions, and a rocket incision here. This is an example of a skin sparing, nipple areola sparing mastectomy completely being done through incision in the inframammary crease. There are no incisions in the anterior part of the breast here. The entire procedure was done through an inframammary crease, and we did a reconstruction here. You can see here on the left side mastectomy completed. We did implant-based reconstruction, and the scar can be nicely hidden in the inframammary crease. And when the patient stands up, you will not see any scar at all, even though she had a complete mastectomy in this patient. So just to conclude my talk, planning incisions is extremely important in breast surgery. There's a need to have a good familiarity with the anatomy, oncological principles, and plastic surgical techniques, some aesthetics. Your mind should have some aesthetic sense when you plan breast surgeries. And planning is individualized. Every patient is different. It should be tailored according to the patient, tumor, and treatment needs. And you should always try to balance oncological and cosmetic outcomes. Thank you very much.
Thank you very much, Dr. Dev.
Thank you, Deo sir, for your excellent presentation.
Thank you.
Hi, Vijay.
Hi.
Thank you, Deo sir.
Thank you. Thank you, Dr.
Maji.
Maji. Thank you.
Yeah.
Thank you, Dr. VPC. I will take the questions on the YouTube.
Yeah,
Thank you.
Okay.
That will be great. Over to you, Arunima.
Yeah. Thank you so much, sir, for the presentation.
Thank you,
And, now we just present certificate to Dr. Dev for his talk.
Thank you.
Dr. Vijay Pratap Singh for chairing the session. Dr. Abhiram Maji for chairing the session. Now we go on to our next session.
Arunima. Arunima, I think I'm audible. So here, since Abhiram Maji is on, he is on chair, I want to put on record the appreciation of me and my family to Abhiram and Dipten. You know, my mother suffered cancer breast, and at that time I was totally confined in Bokaro. And when I thought that she was not able to walk because she had her hip prosthesis and it had shortened the limb. See the friends rising to the occasion. I just made one call to the competency of Diptendra and Abhiram, and both of them traveled all the way from Calcutta to Bokaro. And my family is really indebted. And this is what we can do to our own family, dear friends, all over you are listening. Capacity building for ourselves. And both of them came, and with all humility, they served my mother. And my mother survived for another 2-3 years to bless all of us. And I salute them, and my family is really indebted to both of them.
ASI Jharkhand Chapter is indebted on your behalf. Thank you.
Thank you very much. And I think ABSI is a family. I'm sure we all will do for each other. Thank you. So we now move on to the next session. That is the third session. And I invite Dr. Chandra C.K. Naidu and Dr. Uday Srivastava to chair the session and introduce our speaker. Dr. Chandra C.K. Naidu is Senior Consultant Surgical Oncologist and Oncoplastic Breast Surgeon from Hyderabad, and he is a life member of UICC Geneva and ABSI Director of Education of South Zone. Dr. Uday Srivastava is ex-Senior Research Fellow, CSIR, and Consultant Surgeon of Ramgarh, Jharkhand, and he is right now the Chairman, ASI Jharkhand Chapter. Over to you, sirs.
Good afternoon, Dr. Arunima. And first of all, I would like to convey my congratulations to you. Wonderful program. And good afternoon to everyone there, sir, Dr. Srivastava. And today, this topic is various techniques and role of sentinel lymph node in breast cancer. The speaker, Dr. Somsekhar, needs no introduction. It's like presenting another, giving another presentation if I start reading about him. So Som, very happy. And briefly, he is the chairman, Manipal Oncology Institute, and is director, Surgical Oncology, Manipal Institute, and also he was a good student, good teacher, leader. So you can continue your topic.
Thank you very much for excellent words, and at the outset, fantastic, what a program it is, and thanks to Sunil and Arunima, it takes spearheading the ASI Jharkhand Chapter and ASI Joint Meet. Excellent talks, excellent program. I will try to be crisp and clear in my talk because I know there are students, general surgeons, breast surgeons, surgical onco, and all group it is there. So what is the various way we can do sentinel lymph node cancers and why? I bring warm regards from ABSI Association. Remember, during my surgical training, we used to think that disease cancer is bad. So much so that patients are afraid the treatment of cancer is more dangerous than the cancer itself. They wanted to run away from the cancer specialist because we used to bombard the people with maximum tolerable treatment, biggest surgery, radical mastectomy, removing pectoralis major muscle, node involved or not, all axillary clearance, giving them all the complication, maximum chemo, the maximum radiation. At the end of it, a tired lady with all the complication would go home. And now we know breast cancer is such a good disease. Most of them are cured by law and rule. So now we understand in last 20 years, it is not the maximum tolerable treatment, but the minimum effective treatment that is most important. Not compromising the quality of life and cancer cure rate and oncological principle, but yet retaining cosmesis. So we moved from radical mastectomy to modified radical. From there, we moved to breast conservative surgery. Almost no contraindication to do breast conservation now. Similarly, the minimal access treatment in axilla is moving from complete axillary clearance and its complication to sentinel lymph node in the breast. So this is a thin ideal line. We should not mutilate and do major surgery or treatment to cause damage and quality of life. If you know all the patients who are cured of breast cancer who come and follow up us at 10 years, 20, 30 years, they will not be happy that I'm cured. They'll always complain, I have shoulder problem, neuropathic pain, lymphedema. So this complication become very important after the fear of cancer is gone and cure has been achieved by 10 years. So we have to thank this particular William Halstead in NSABP 04 brought cure to breast by local surgery. But then the maximum tolerable treatment has moved to minimum effective, which is organ preservation in breast, maintaining cosmesis quality of life. So William Halstead, Bernard Fisher to Giuliano, who brought SLNB way back in 1985. Why axilla is important? Never say that my hands, I am a professor of a medical college, I am a professor of surgical onco, my tip of my hands has got ultrasound, I keep the hand finger in armpit and say, oh, there are no lymph nodes. Don't ever say that. Axilla has to be staged in all invasive breast cancer because even when 1 centimeter small breast invasive cancer is there, there is a 25% chance there could be occult metastasis. If there is node positive, stage goes up, they may need Taxol chemo and you should not compromise. So elective axillary dissection will accomplish this, but at a lot of cost. Axillary sampling is not a proved technique. So you have to know, even in clinically N0, ultrasound N0 axilla, what actually is the cause. This looks very good. You know, when we do this, it looks very beautiful. Wow, nerve, axillary. But remember, this level 1, 2, 3 clearance has no benefit if the patient is truly pathologically node negative. So that's why the morbidity of axillary dissection is lymphedema, intercostal numbness in 78%, nuisance to carry whole life, restricted shoulder mobility, paresthesia, seroma formation, prolonged hospital stay drain. This increased morbidity not justified in all the cases, especially when 70% node could be negative. This is a very debilitating. Only a lady who develops this knows its problem and the lymphedema problem. So routine axillary dissection does not benefit the 70 to 80% in whom pathologically nodes come negative, even in T1, T2. So sentinel is the first guard in that fort who stands high on the highest part of the fort. From far away, many miles ahead, can see the attack coming. So this is the first echelon lymph node which receives the cancer. And if that is negative, if there is a way we can know which is a sentinel node in that given woman, in that breast, other nodes will be negative. So now there are enormous hundreds of trials, large randomized trials, which show and level 1 evidence, it is crime not to offer sentinel lymph node to a lady with stage 1, stage 2, and up to 5 centimeter early breast cancer. ASCO has told the best technique is to use a combination of 2 techniques to have high detection, and you must do this. Otherwise, it's crime not to offer this in this era of modern science. And this was an early Indian experience, which from 2001 to 2005, I did it and we published from our group, where in India, you can replace it with methylene blue with a very high sensitivity specificity published in the journal. Now, what is the best way to do sentinel node? Why? You must identify a right, correct technique to do, so you can spare unwanted axillary dissection in negative. Also identify the patient who are positive. What is the current guideline as per ASCO? Any woman who is not in locally advanced breast cancer, any woman where the tumor size is less than 5 centimeter, clinically and ultrasound of axilla is negative, should undergo SLNB. Now, this is the law. What are the increased success? It is very important. The ASCO recommends at least 20 lymph node first validation trial the institute should do. The surgical team, the pathology, if you're using a nuclear medicine, and prove that your false negative rate is less than 5% before you start offering it. So all of us did. These are the various large 1,000 patient trial done, which shows it is very safe you can do. And also now it is approved where to inject the dye. If you're using ICG or anywhere, is it peritumoral, intratumoral, intradermal, upper outer quadrant, retroareolar, all the issue has been sorted out now. No matter where the breast lump is, in which quadrant, single 1 to 3 ml of retroareolar SAPI plexus if you inject, for that patient, sentinel node for accuracy is same. So this controversy is solved. Now there are 100 dyes. Vital dye, isosulfan, patent blue, indocarmine, methylene blue, colloid albumin, dextran, technetium, what to use. All the issues sorted. No matter which of these dye you use, all of them are equivalent to single dose of ICG also. Type of dye doesn't matter for you. Now we actually, published this particular area combination of dual dye, which was a standard of care. And we brought a Indian solution for Indian problems, a consensus practical recommendation guideline from ABSI. Thanks to Dr. Chintamani sir, Raghu, Diptain, Gaurav, all of them. In Indian journal, we published recommendation for Indians, which is there very well. You can see the practice of sentinel lymph node in India and what is the node positivity. The guideline is there. All of you go download this and read this article. And it's very important to also know, gone are the old days when we thought all in women are LABC. Now 40% is the breast conservative rate in across India, even in government hospitals and also government setup. You check with Dr. Dev and Diptin, lot of women undergo breast conservation. Now women come in early area. This is a paper which we published. Now the current recent advances is fluorescence imaging using ICG. Why is it so? This is a very well indigenous developed, make in India, which we did, and this indocyanine green is available. It is a real time. You put a small dye, you can see the primary site, the lymphatic and the sentinel node in front of you in matter of seconds and minutes, and they glow. So you don't need nuclear medicine department. You don't need expensive radiocolloid. You don't have to have a nuclear medicine probe which runs into lakhs and lakhs. And it is a dynamic scan. Even before you keep an incision on the skin, you can identify this. So this is very, very useful to do it. And we did a 2-arm study where we found whether you use combination of blue dye with handheld gamma probe expensive or ICG alone with this indigenous, it is equivalent. We published and presented in San Antonio Breast Congress, and we also presented this in Indian journal. We did a very good, well-structured trial which we published. Now there is a short video. After this, there is only one slide and thank you slide, which explains you everything about sentinel node. So the first node in that woman is not fixed. A sentinel node location varies from level 1, 2, or 3 in each woman. So there must be a way for you to know. There are 3 techniques you can use. You can use a blue dye or a technetium colloid, injected peritumoral, just about 10 minutes before surgery, the blue dye. If you're using a radiocolloid, then it must be injected 1.5 to 2 hours before. And then once the patient is induced, anesthetized, and you give this particular combination of dye or ICG dye, then you scrub and come back. If you have a handheld gamma probe, the setting is very, very important. If you are doing for sentinel lymph node, then it needs to be 1:1000 setting. And the first node in the axilla is 1:20 hot node, is called the sentinel node. After you remove that node, the background activity in the axilla should be less than 1:10. In the initial learning curve, it is good to do radioscintigraphy to see where the primary site, the nodes, whether it is internal memory, axial level 1. So you can see that in this primary site is injected. Sentinel node has already come in the level 1 of the tail of the axillary breast. You can use a commercially available methylene blue or ICG. And then you use a gamma probe, which also shows you a radio reader as well as audio. But now we have totally switched over to a ICG, which I use a iRelic from nm.nm. So you can see that. site of injection, identify what is the marking value, and divide it by 20. So if you have a recording of say 10,000, so any reading 1 in 1,000 in the armpit is the hot node. So you can have a fluorescent node, you can have a hot node, or you can have a blue node. So you keep this particular probe and navigate and identify 1:20 and you mark it on the skin. The problem with this gamma probe is it is not a dynamic scan. Unless you keep an incision open, you cannot identify. So you can use either a peritumoral. Now we totally switch over and we give a single shot of retroareolar dye completely now. So you can see that you can inject this particular dye here. And then once you do this, if you're doing mastectomy, raise the upper flap, reach the axilla. If you're doing a best conservative surgery, identify these lymphatic channels easily. Then you go and gently open it. Remember, don't dig the axilla too much. In the disguise of sentinel lymph node, don't dig the axilla and cause nerve problem and lymphedema. And if you have this straight away, you can visualize it and check the reading. It needs to be 1 in 20 reading, which you need to have. And then you need to, once you remove this particular node and navigate it and take the node outside, then you know the corresponding reading in vivo in vitro should be the same. If you're doing a breast conservative surgery, first go to axilla, identify the hot node or the fluorescent node, and check the node both in vivo and in vitro count. It should match 1:20 of the primary site, like this, outside the body. So then you need to navigate the axilla for any activity 1 in 10. If it is negative subcuticular, this is all a lady takes. If you don't have any facility, best is to use ICG. And I told you the best way to use it is you take 3 ml of the dye, pinch the nipple, not intradermal, into the retroareolar sapi. No matter where the breast lump is, single shot of this, if you give it, and then when you go into the axilla, it will be very, very easy for you to navigate and then go and find. But now totally we have replaced everything with a fluorescent dynamic scan, because after we did the study, we found this is far superior. So you take an ICG, you give a single site of injection in the retroareolar plexus of SAPI, and with this special probe from the iridic, you can see even before you keep an incision, fluorescent primary site, the lymphatic site. So retroareolar SAPI of plexus, single dose. You can visit my YouTube. There is a detailed video of this. So there is no contamination. In front of your eye like this, the lymphatics travel. See that in front of your eyes, even before you keep an incision, like this. Straight away it would go and it will stop in the axilla and you know which is the first node. That way don't make a mistake and pick up a second echelon node and think, oh, I removed a sentinel node, it is negative. You would have actually missed the primary node. So real time it will go there and it will stop in the axilla before you keep an incision. Fluorescence, it comes in 3 different modes, color mode or a white mode or a green mode. You can look at it and you can see the lymphatic channel is going down there and you can identify as lymph node and put an incision there straight away dedicated for you to go and pick up. This is something which is very easy to identify, economical, any medical college, any center can practice, and the node fluorescence, no nuclear medicine cost, no nuclear medicine department required, no exclusive cancer center required for you to do. Just one shot on the retroareolar. This is available in India. You can go back, and this is a study we published in the best clinical breast journal, which was a study which showed that it is equivalent and superior to both techniques. So now totally I have replaced this. So to end, in conclusion, we do minimal access surgery and do breast preservation. Same way minimal access treatment to axilla. It is crime not to offer sentinel node in this era. And from maximum tolerable, we must come to minimal effective treatment and retain cure rates. So more is not always better, less is not inferior. This is the era of de-escalation treatment. Thank you very much.
Thank you, Dr. Somsekhar.
Thank you, Dr. Somsekhar. Released presentation. Lot to learn, students, for sentinel node. Thank you.
Thank you. I will take all the questions on the chat and I'll write the answers there. Thanks.
We would like to present e-certificate to Dr. Somsekhar for his talk, and chairing the session, Dr. Chandra C.K. Naidu and Dr. Uday Srivastava. Thank you very much for chairing the session. The next topic in this session is by Dr. Debashish Ghosh, and I welcome our chairpersons, Dr. Chintamani and Dr. Diptendra Sarkar. Dr. Chintamani needs no introduction, but he is Governor and President of American College of Surgeons of India Chapter. He has been the President of Association of Breast Surgeons of India in 2013 and 2015, and also the President of Association of Asian Society of Mastology. And there are a lot more laurels to his credit. And he had been he's the joint editor of Indian Journal of Surgical Oncology and a professor at Bardhaman Mahavir Medical College, Safdarjung Hospital. Dr. Diptendra Sarkar is in charge of Comprehensive Breast Service and Breast Cancer Research Unit, Department of Surgery, IPGMER. And he has been the immediate past president of ABSI and honorary secretary of Asian Association of Mastology. So please take over.
Thank you, Arunima. First of all, many congratulations to Sunil and his team. That is you and Dr. Sunil. And of course, the Jharkhand team. The ASI Jharkhand is a very active, happening kind of a chapter. I've traveled there for a couple of orations, and my greetings to all of them. And of course, to their patron, and of course, the patron to all of us in ASI, Dr. R.P. Srivastava. So I'm truly delighted, and it's truly an honor to be a part of this wonderful ABSI meeting. When Raghu and Som were talking about the days when it was founded, I was really, it was nostalgic as to how did we start and what all it took. Dipten was a part of it too. All of us were together, and that's how it happened. Well, ladies and gentlemen, it's truly my pleasure to introduce a very dear friend of mine, a very distinguished educator and a very well-known breast surgeon. Again, doesn't need a lot of introduction, but as is customary, it will be truly, our pleasure. I'm speaking on behalf of Diptendra too. Dr. Debashish Ghosh is a consultant oncoplastic breast surgeon at the Royal Free, London, and he's also associate professor at the University College of London and the undergraduate lead at the same medical school. He is, of course, somebody who's into bringing a lot of positive inputs in terms of education for breast diseases and also in general. It was a pleasure associating with him when it came to education of the postgraduates in India, and he's very keenly involved in it. He's an MS FRCS from Edinburgh, FRCS General Surgery, FEBS Breast, FEBS Surgical Oncology. Dr. Debashish, truly a joy to welcome you to this conference, which is outstanding as it is. All credit to Arunima and Sunil. Over to you, Dr. Debashish, please. I hope you could hear all that I spoke.
Dr. Debashish, please unmute yourself and you can share your screen now.
Thank you very much, Dr. Chintamani, and thank you very much, Dipten. I think it's a wonderful organization, Arunima and Dr. Sunil. Just to let you know, I wish this was real and this was in real time, because my father's family and my dad, they originate from Jharkhand, Sahibganj. So it would have been really nostalgic to be there. And as I start this topic on oncoplastic breast surgery, I'm just getting my PowerPoint presentation on. For some reason, I am unable to share the screen. What has happened here? I have just 1 minute. Yep.
Do you need any technical help, Dr.
No, I'm open. I'm just trying to, okay, there you go. Okay, there you are. Because I had too many windows open. Sorry about this. So I'm going to talk on oncoplastic techniques in breast conservation surgery. And I belong to the era when I was initially trained in India. Breast surgery was very much looked down upon. And I remember very well long ago, 1992 October heat, sitting in Grant Medical College, 9th floor. there was a surgeon from UK, Dr. Dominic Pinto, who was a friend of Tanton Udvadia. He was invited. He was the first breast surgeon who had come to give us a talk. He worked in Omagh County Hospital in Tyrone. It was in the middle of Northern Ireland, and it was when bombing is going on. And that was the route most of the GMCites or the Grant Medical residents would be sent across to UK to do an overseas doctor's training scheme. However, via PLAB, but that was the first meeting of breast surgeons. And however, one thing I would say, it was always looked down upon in the general surgical community as breast surgeons. They said they are lipoma surgeons. And during my training in UK, I was doing my high specialty training, and we were doing colorectal surgery and breast in one unit. This was 2002. And that was the beginning of oncoplastic surgery just taking place in UK. And oncoplastic surgery was a branch which was established for the first time. And people had started doing reconstructive surgery earlier in the States, but formally, oncoplastic surgery as a branch was established in 2002. I was in the right place at the right time. And I didn't want to be a lipoma surgeon only. So hence, the plastic component interested me, and hence my jump into oncoplastic surgery. And currently, I do pure oncoplastic surgery and breast surgery. I do not practice any other general surgery. Very much a lipoma surgeon, but doing it in an aesthetic way. One of the other things I always say is breast cancer is not a fight or a battle. It's a journey. And it's a journey for the patient, and we are here to support the patient. I always have to say one thing very important. The cancer is part of you. If you start fighting a part of you, you will lose. We can fight the COVID virus, but we do not fight cancer. We have to be with it, overcome it, and our job as surgeons is to help the patient. And oncoplastic surgery, it's not a technique on its own, it's a way of thinking. We believe it's a comprehensive approach to surgical planning that combines the principles of surgical oncology, plastic, and reconstructive surgery. And the whole aim of oncoplastic surgery is not only to conserve the breast, it is also to maintain the breast aesthetics and also remove the complete cancer with very good margins. Now, I'm not going to talk about reconstructive surgery or breast reconstruction of mastectomy today, because otherwise it's a big topic. So I will just stick to breast conservation surgery and oncoplastic surgery in its all. And in the realm of oncoplastic surgery and a reconstructive surgeon, we have breast conservation, which has therapeutic mammoplasty, lipofilling, and local flaps. And the aims of and advantages of oncoplastic surgery is very, very clear. That we have to preserve the body image, maintain the well-being of patients, and they have a good psychological balance. And to achieve these objectives, one has to leave the patient with a normal anatomy and a very good aesthetic outcome. Now we have moved all the way from Halstead's radical mastectomy. This is how people were left, where every patient would have a Halstead radical mastectomy for big surgeons, to having skin sparing mastectomy, then lumpectomies. And now I will go around to different approaches of oncoplastic surgery. And when we did a research and a survey of patients, we found that most patients were really upset with the scars they were left with. Their self-confidence was completely shattered after having cancer. And most patients, after having mastectomy or lumpectomy, were unable to have intimacy. Now, we always treated the patients for cancer, but we left them with very poor survivors. And hence, oncoplastic surgery takes a major role in not only leaving a patient, cancer patient complete, but leaving them with a self-confidence to survive this whole journey, maintaining their intimacy, body image, and self-confidence. And you can see we moved all the way from the beak-shaped breast conservation surgery where we slashed directly over the tumor with scars being seen, and to a major part where lumpectomy is done and no scars are seen. And again, the breast cancer surgery, reconstruction, mastectomy has evolved from skin sparing mastectomy, nipple sparing mastectomy, and to scars very well hidden where we cannot see where the scars are and patients have mastectomy. Now, traditional lumpectomy, the scar was placed directly over the tumor. Scar is visible when healed. Whereas in hidden scar lumpectomy, incision is made in a place where it's very hard to see. And that's what Dr. Dev was trying to show us. And how we choose our scar in oncoplastic surgery is extremely important. Again, we have to, before we decide on what kinds of oncoplastic surgery we have to perform, it's very important to know and how to assess the patients. And here is a very simple guideline which we use. This was developed in Nottingham, part of their oncoplastic group, and where they divide patients' size of the breast along with their ptosis. And you have grade 1 patients who have small volume breast with no ptosis. Then you have medium volume patients with mild ptosis, that is cup size C with mild ptosis, and large volume patients with cup size D and above with large ptosis. Then you combine that with small defects, that is less than 25% of breast being removed, moderate defect where more than 50% of breast is, about 50% is removed, and large defects where there's more than 50% of the breast is removed. So that can be divided into A, B, and C. That's a very good classification. And if you keep this in mind when you're assessing patients for oncoplastic breast surgery, once you know this, we can very clearly decide if the patient can be given just simple wide local excision, just glanduloplasty, or go down the route of reduction mammoplasty. So it's no point taking a 1 centimeter tumor where we are taking about 10% of the breast and doing a major therapeutic mammoplasty. Please remember, therapeutic mammoplasties and large volume breast reduction have their own morbidities. And we don't want to give that kind of morbidity for a small tumor. On the other hand, you can remove a 5 centimeter, 6 centimeter sized tumor in a large breast with a very good therapeutic mammoplasty and very good results. And hence, we divide the complexity of oncoplastic surgery depending upon if we are doing simple glandular mobilization, if we are filling the defect with local flaps, or we are bringing distant flaps to fill the defects. And we use the principles of breast reduction surgery and different incisions which we use in breast reduction to plan our incisions. And here I have shown you different figures where we can choose our incision depending upon where the tumor is placed. We can have a simple round block mammoplasty, or we can have a Weiss pattern mammoplasty, bat wing pattern. Here you can see in this patient where we have done the nipple has to be removed, and we have moved a local flap in there called the Grissotti flap. So different flaps are used in order to fill these defects. So again, coming back, how we fill these defects, you can have a simple glandular rotation, you can have a dermoglandular rotation, a tumor reduction mammoplasty, or we can bring in currently a lot of local chest wall perforator flaps and advancement flaps are being used. Local advancement flaps like local thoracoepigastric flaps, and you can also do mini LD flaps. Now, markings for therapeutic mammoplasty. In this patient, this patient has a large tumor at 7 o'clock position. You can see the tumor is actually pushing the nipple on the left side. We mark the patients with, and we have got away with simple round block mammoplasty, also called Benelli's mastopexy, and patient gets a very good result. Again, this is a very good technique, easy technique for all of us to use. We use deepithelialization of around the nipple. You can take a large chunk of tumor, you can see here, close, and gives you a fantastic result where patient gets a lifted breast, round block, incision is placed, and you can see the patient's breast shape and size is well maintained. And again, then going to the large tumors. This is a 5 centimeter size tumor. Patient had large breast, ptotic breast. We were able to do a therapeutic mammoplasty via Weiss pattern using inferior pedicle flap and did a therapeutic mammoplasty. Again, this is a large reduction mammoplasty. Patient had a big tumor in the inner quadrant. Remember, inner quadrant tumors are the most difficult to treat. And these are tumors where we use a Weiss pattern, inferior pedicle flap. We have taken the whole upper inner quadrant, and you can see patient left with a very good result, therapeutic mammoplasty at the end of 2 weeks' time. Again, similar situation, large tumor behind the, you can see at 12 o'clock position, just above the tumor. This we did using, again, inferior pedicle flap. One of the other things, as we say, we keep bringing new things in. And previously we used to use a lot of wires to localize breast tumors in large breast or small tumors, microcalcification. And currently we have just completed a large trial in our hospital, and we are the first ones to use radar technology where we put a, you can see on the right, a scout localizer. This is a clip which has radar sounds which are emitted, picked up by sound localizers. We can plan our, without doing wire localizations, we can plan our therapeutic mammoplasties based on this. We can localize the tumors on table and do the operations. Again, vertical mammoplasty for central tumor excision, doing bilaterally tumors. Previously, all patients with central tumors, we used to do a mastectomy. And now we can get away without doing a mastectomy in these patients. We can do a Grissotti flap, as you can see in this patient. And this patient has had a full central wide local excision, nipple has been excised, and Grissotti flap. Patient with a large tumor in the upper outer quadrant, we were able to do a therapeutic mammoplasty. This is immediate post-op, bilateral breast reduction. Central tumor, I think this is a tumor patient I remember very well. She was the mother of one of my theater managers. She was going away for her 50th golden anniversary wedding celebrations, and she was advised a mastectomy with reconstruction. And I was able to do a central wide local excision, vertical mammoplasty. She didn't want any nipple reconstruction, and she was left with that. Now, we have patients now who have small breast, cup A to C. And these are patients who may have a 3 centimeter, 4 centimeter tumor. And to achieve a good wide local excision, you have to take literally half the breast. And that's where chest wall perforator flaps came in. And as we say, we are learning constantly. And one of my colleagues in UK, who's also a very good friend, Amit Agarwal, started doing a lot of chest wall perforator flaps, light cap flaps. I have learned to do light cap flaps along with our plastic surgeons. We now do light cap flaps where we can take literally half the breast off, mobilize a light cap flap from behind the chest wall. You can see we have raised, this is not, we have left the latissimus dorsi muscle, just picked up the skin and the fat over it, and we have advanced it. Of course, the patient is left with a large scar behind, but you can see a fantastic result where literally more than 3/4 of the breast has been removed in a small C-cup breast, and patient is left with a very good aesthetic results. But not always everything is good. This is my results. These are my patients where things have gone terribly wrong, where patient can have complete nipple areolar complex necrosis, loss of nipple sensation, T-junction breakdown, very common. And this is something I always tell patients, be very, very careful, have the right training, just don't listen to a talk and don't just watch some YouTube videos and start doing oncoplastic surgery. It is a skill which you have to learn with different levels of training, go to good centers where high volume cases are performed, And again, I was lucky. I was trained by Krishna Kloff, father of oncoplastic surgery. I had the great benefit of being mentored by different surgeons. And I'm still learning. And if you are learning as a practicing surgeon, go on, get people to mentor you, work with them, buddy up together. And that's how you learn new techniques and learn about where things go wrong. Learn from people where they have made the mistakes so that you do not have to suffer mistakes. Again, take home points here. Choose the right patient, choose the right procedure, know the complications, set the right expectations with your patients, have the right training, and never be ashamed to ask for help. And at the end of it, always know what women want. Thank you very much, guys.
Thank you, Debashish. That was wonderful, as always. Truly a joy. I'm sure there must be many, 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 many questions. So I think we leave it to the YouTube streaming, and please do reply to their queries. I could see that there are many. Thank you very much, Dr. Debashish. Over to you, Arunima. Thank you.
Yes, sir. Just giving a e-certificate to Dr. Debashish for his talk, and one to Dr. Chintamani for chairing the session, and Dr. Diptendra Sarkar for chairing the session. Thank you very much, sir. And now we move on to our next topic, and I welcome chairpersons Dr. Somshekhar and Dr. Sanjay Jain. Again, Dr. Somshekhar, I don't think needs any introduction. So I'll just introduce him as the ABSI president. And we have got Dr. Sanjay Jain, who is the professor of Department of Surgery, Gandhi Medical College, Bhopal, and is the honorary secretary of ASI, honorary treasurer of ABSI, and executive council member of ASI. So over to you.
Yeah, it's pleasure and unique honor not only to welcome my dear friend and colleague, but an excellent teacher, teachers of teacher par excellency, Diptendra Sarkar, who is in charge of comprehensive breast services and breast care unit in Department of Surgery, IPG MER, and he has a very unique honor of being a visiting professor, Mayo Clinic, Rochester, a visiting Hawk professor. It's hats off to you, given to very excellent academicians, and it's honor of India and also ABSI that Dipten is regarded and is invited and appointed as one of a visiting professor in Mayo Clinic, Rochester. He is also our immediate past president of ABSI and honorary secretary of Asian Association of Mastology, and a very active member in ASI. More than that, my dear friend who is going to host our next ABSI Con in Calcutta next year. Over to you, Dipten. For you, we are eagerly waiting to hear your talk.
Thank you very much. And if Arunima, you can put me into a screen sharing option, please.
Sir, you already have the screen sharing option.
Okay, I got it. A warm good afternoon to everyone of Jharkhand Chapter, to Association of Breast Surgeons of India, and I am truly honored to be part of this wonderful historic endeavor. And I am sure Arunima has set a standard which is very difficult to attain, even for a physical conference to happen. And I was asked by my good friend, Dr. Somshekhar, to speak on this topic, that is gray zones in benign breast disease. And of course, there are multiple gray zones. And I remember one of my mentor who happened to be in an international conference and came back that when I went to the conference, I was very clear about what I should be doing. And when I came back, I'm completely confused. Breast cancer is a discipline which is evolving every day, and newer evidences are coming and making us obsolete, as Dave Ghosh just showed us that things can change overnight, and therefore we need to keep ourselves updated. And today, therefore, I chose to talk on a topic which I am sure is a big issue for everyone who is sitting across your computers or your mobile phone and trying to understand how we should be dealing with this condition called granulomatosis mastitis. And the reason I chose this topic is, one, because I have been burning my fingers about this disease over almost a decade now. And that forced us to sort of to run a sort of prospective trial. And I will be talking to you in terms of the trial that we are still running and what are the evolving evidences and what exactly you can do to deal with this notorious condition of granulomatous mastitis. When I was invited to deliver this lecture in ABS last year, and there I saw that the world is divided into two groups. One is the ones from the developed countries, and they truly believe, because they have not seen tuberculosis, that it is a truly idiopathic. And most of them would feel that steroid therapy or methotrexate is the best treatment. And I do hear about some people who told, why on earth would you like to treat them? They resolve on their own. While on the developing country front, I am sure you would be seeing a large spectrum of idiopathic granulomatous mastitis with peau d'orange and all those notorious features. And for them, it is an easy diagnosis to tell that it can be tuberculosis, and most of them would put them on anti-tubercular therapy empirically, though they are not able to prove. And in some case, they might end up in doing a surgery which they would not have liked to do, and they have burned their fingers like what I have been doing in the last decade. And therefore, if you look at the tricolor of evidences, we have the black zone where there is no evidence. And as of now, for IgM, there is no evidence. It's a free for all world. I mean, you can choose to do whatever you like and get away, because there is nothing clear-cut written in the textbook. And therefore, people are, you are always correct or you are always wrong. On the other hand, we would look at evidences which are backed by proper meta-analysis or randomized control trial. Unfortunately, there exists none. So we are left with a gray zone. And therefore, it is a zone.
Dipten, can you share the screen? We have not yet been able to see your screen.
Yeah, I mean, are you able to see it now?
Yeah, can you make it full screen now? Yeah. So, yeah, thank you. Yes, please go on.
So, as I said, the tricolor of evidence-based medicine is evolving. And on one side, we have no evidence, which is a free-for-all, and the other side, you have stronger meta-analysis and randomized control trial. But in IgM, unfortunately, we are at the era of weak evidence or evolving consensus, whatever way you would like to look at. So we designed this trial with the aim to look into the pattern of granulomatous mastitis, to understand the etiopathogenesis of the disease, to evaluate the role of surgery, and to suggest a guideline based on the available evidence. So this started sometime in 2017, December. And what we did, we included only patients who were histopathologically proved as idiopathic granulomatous mastitis. We excluded all the patients who had tuberculosis or had a multicentric disease. I mean, if you have a disease where it's a complete peau d'orange of the whole breast, or the whole breast is sort of almost necrosing, we would exclude that. So we are focusing at present on unifocal lesions which are proven as idiopathic granulomatous mastitis. And we divided or randomized the groups into three. The group A, where patients were given on steroids only. Group B, the arm which is gradually getting excluded. We no longer perform a wide local excision, but that's historically one of the cohorts of wide local excision. And group C, which comprises of the surgery that we have planned, and I am going to show you why we have planned that. It's called wide local excision with total duct excision or partial duct excision, depending on the scenario. While we analyzed the data, we found that of the patients who present to us with granulomatous mastitis, around 16% will have definite microbiological evidence of it being tuberculosis. So you are not going to do any surgery on them. You are going to put them on anti-tubercular drug therapy. That's clear, and it's a full stop on that. Unless you have a very ugly looking breast where you need a sort of debridement, or else it is anti-tubercular therapy. 79% of them would have a pure idiopathic granulomatous mastitis. A 4%, a very minority of them, would be having mycobacteria of other types, which I think gradually will shift to idiopathic granulomatous mastitis. It's a long story, but I'm not going to go into the details of that. So presentation-wise, those who are hearing this lecture would agree to me that in Indian subcontinent, the majority of around 80% of the presentation is pure chronic breast abscess. And you are forced to drain it because it is multiloculated. You have sent it to your radiologist friend, and he or she told you that, Selvi tells you that there are a lot of pockets and it's impossible to drain it with a pigtail. So you chose to drain it, and now you have burnt your fingers. You have taken a small biopsy from the edge, which shows it's an idiopathic granulomatous mastitis. In others, it's pure poderange, looks like a cancer, and you don't know what to do, and then it comes out to be an idiopathic granulomatous mastitis. A pure small lump is a rarity. In our series, it has been only 7%, but make no mistakes, the number is increasing in terms of finding a pure lump, which is not quite rare in the Western subcontinent. Radiologically, it is basically inconclusive. As I said, there is no role of FNA. You have to go for a core biopsy if you have any lump in the breast, and once in a while you might get an idiopathic granulomatous mastitis. But the most common way that we have found the diagnosis is, guys, if you are draining an abscess, do not make the mistake of taking a small biopsy from the wall. Really, you might have a cancer, but idiopathic granulomatous mastitis is becoming a frequent diagnosis when you are taking a biopsy from the wall. So in 2017, we believe that you must resist all temptations for revision surgery. And it is indicated only for residual disease after adequate medical treatment, I mean with steroids or whatever form you have chosen, you have given, and then you would choose to do an excision. From 2017 onwards, we started evolving on trying to nurture a new hypothesis, understanding why it occurs. And this is one of the first index case who had a bad sinus, discharging sinus with a lot of induration. And we did an excision and did a little bit of volume displacement. And we had an acceptable response in terms, because we did a microdocectomy, or a total duct excision, a total duct excision, en bloc removal, along with the sinus and the indurated mass removal. So the hypothesis, because based on the success we set, was IgM is an autoimmune disease which causes ductal leakage, leading to extravasation of irritant intraductal fluid, which is rich in cytokine. It's interleukin 6. Thanks to the nomenclature that we have started learning in the pandemic era. It's pure interleukin 6 related activation and destruction of periductal tissue. And therefore, if it is a disease which is originating from the duct, excising sort of a perianal fistula, the opening only, doesn't help. So it has to be an en bloc excision with the organ of origin, that is the duct system. So the data that has evolved, that's the result of the interim data that has evolved as of now on 53 cases, is that in out of 18 cases, and now this number has gone to almost 35, but out of 18 cases, we did not find any recurrence. And this is the published data. Of 35 cases, we have now 1 recurrence. But the interim published data shows there was no recurrence, versus 26% recurrence in steroid arm versus 75% recurrence. So if you try to go for an unguided excision, almost all the patients are going to come back with a recurrence. So the middle arm has gradually getting extinguished, and we are focusing on steroid versus wide local excision and total duct excision. So the confusion continued. We had to prove whether there is a ductal leakage or not. So we asked our pathologists to do multiple sections to understand. Now here you look, this is the area where you get, these are two areas where you get a non-caseating granuloma. In tuberculosis, you will get a central caseation. In idiopathic granulomatous mastitis like sarcoidosis, it's a non-caseating granuloma. And look at this, that's the area where it is started to communicate with the duct. Now this is again a periductal, that's the duct that is going. And you will find the lesion just at the periductal level, signifying the fact that it originates because of microscopic leak in the duct system. And gradually the whole duct system melts. And if you are going to excise this lump in the macroscopic form, the patients are going to come back with a 75% chance of having a recurrence. So the paradigm shifted that it's an autoimmune disease. And ladies and gentlemen, I am going to introduce to you a new concept of prolactin being the culprit. Now we have been told about the role of prolactin, which we know is in breastfeeding. But if you read carefully, prolactin is also a cytokine at the local level. And if there is a polymorphism in this prolactin gene, it liberates interleukin-6, and that causes periductal damage. And most of your patients, if you remember, they are going to come back with joint pain and joint effusion. That's the reactive arthritis they are going to have, which behave exactly like a small little cytokine storm. And this is going to go into a form, we call it the Frankenstein phenomenon of prolactin in idiopathic granulomatous mastitis. So this is the mechanism by which it acts. So coming to removing all the complications of the pathways, the prolactin, when there is a polymorphism through the major histocompatibility antigen presentation by T cell mediated as well as innate immunity mediated, it is going to trigger the release of interleukin-6, which promotes apoptosis of the periductal tissue and ductal damage. And this is the phenomenon that happens. And you are going to have destruction of the periductal thing because of the extravasation, and it leads to the idiopathic granulomatous mastitis. Now this is when, if you are trying to excise, you are going to find something like this. You are going to have a duct which has got solidified and pesty secretions coming out of those ducts. In most of the time when you are trying to excise, just try to recollect what did you find. You will find pesty greenish secretion coming out of the duct. And if you try to excise it in this way, as I said, in 75% of cases, you are going to have a recurrence. But if you excise the duct system, the recurrence rate drops down to almost zero. So this is one of the patients where we did a complete duct excision by opening the whole breast in an extended resection with ductal excision. And these are our patients where we have multifocal, unifocal lesions we excised and re-excised and did a volume replacement. And most of the time they would come back with an acceptable scar. This is our publication that we had in the European Journal of Surgery only this year. Actually, it was supposed to be presented in the ABS, and we are putting it up. Last year, we had this presentation. I did an invited lecture, but this year it is going to come as a presentation. It has just been accepted in the European Journal of Surgery. So before I end, what we could decipher is that idiopathic granulomatous mastitis is not tuberculosis. Granulomatous mastitis is a broader term in which tuberculosis is a component, but idiopathic granulomatous mastitis is an autoimmune disease. It is caused due to polymorphism of the prolactin gene, resulting in activation of the major histocompatibility antigen presented, leading to interleukin-6 liberation and periductal destruction. And ductal leakage is the key factor in progression of IgM. The treatment is total or partial duct excision with en bloc removal of lesion, which is curative. Surgery is contraindicated if you have multicentric lesions. I mean, if you find it's a poderange which involves the whole breast, I mean, surgery is not going to help you. If it's a grossly infected case, you should be just draining, just as if you are draining a perianal abscess, and do not try to treat it as a fistulectomy, the way we deal in a concept of a perianal fistula. So this is the shades of gray that we are looking at, and we have the darker shades of confusion. And hopefully, if this data evolves in another 6 months' time, we'd be able to go into a whiter zone of confusion. So thank you very much. Thank you, Arunima. Thank you, Dr. Sunil, for giving me the opportunity to present the cause of idiopathic granulomatous mastitis. Thank you.
Thank you, Dr. Deeptendra, for throwing light on a darker aspect of a gray zone disease in the breast. This was really, I think, will be an eye-opener for many of us. And Dr. Som, would you like to conclude?
No, excellent topic. He always gives the tough topics are made very easy by Deeptendra. Fantastic work, and this paper also I have read. Excellent work. Congratulations. Thank you very much.
Thank you very much.
Thank you very much. Just a e-certificate to Dr. Deeptendra Sarkar for his talk, and a certificate to Dr. Som Shekhar for chairing the session, and Dr. Sanjay Jain for chairing the session. So with this, we come to the end of this session, and we move on to the next session, which is a video session of how I do it. So we move on to the next session, and here I would invite Dr. Arnab Gupta and Dr. Nishit to please chair the session. And Dr. Arnab Gupta is the Medical Director, Surgical Oncologist of Saroj Gupta Cancer Center and Research Institute, Kolkata, and he is the President of IASO. Dr. Nishit Ekka is Assistant Professor, Surgery and in charge Emergency Services, RIMS Ranchi, and is the Treasurer of ASI Jharkhand State Chapter. So, sir, are you there?
Yeah, good afternoon, everybody. Can you hear me?
Yes, sir. Please go ahead.
Yeah, first of all, thanks to the organizers for having me, a simple man, for this particular conference. I must congratulate the team, ABSI Jharkhand, and also ASI Jharkhand, ABSI, for the wonderful show. Now, I thought of having 10 minutes break in between, but I must confess, for the last 3 hours, I was totally stuck to the chair. So all the faculties have been wonderful, and it is better than a physical conference like different state. And congratulations for ABSI for completing 10 years under the leadership of Dr. Raghuram, Dr. Chintamani, Dr. Deeptendra. Now we have Dr. Som Shekhar as well. Dr. Arunima Verma is like introducing the host. I don't think I should be wasting too much of time on that. Her credential is probably there on the slide. She is chairman-elect of ASI Jharkhand Chapter. She is editorial board member for Indian Journal of Surgery, Journal of Minimal Access Surgery, and she's EC member of ABSI as well. And obviously, she's a wonderful person. I've been to a lot of her modular courses and oncology courses in Tata Jamshedpur. And I really appreciate the efforts of Dr. Sunil Kumar and Dr. Arunima for organizing all these modules. And I would invite you to start your talk. I think you're going to talk on excision of breast lump. It's a master video, I understand. So I would request you to start this session. Thank you.
Thank you very much, sir, for those words. I hope I'm worthy of them. And once again, a very good afternoon to all the delegates, respected chairpersons and faculty. And in the next 5 minutes or so, I shall be talking about the very common surgeries, which will be more useful for the PGs, because we have got esteemed faculties who are showing us the latest techniques. And I'll be taking you to the very basics. And here we had this 21-year-old unmarried female who had multiple fibroadenomas in bilateral breast, but on the right breast, it was more prominent. So here is a surgery where we have done an enucleation of the breast. And
you need to share your screen. Arunima, you need to share the screen.
I'm already sharing my screen. You cannot see my screen?
No.
No,
we can see your screen, but it's showing your folder copy.
Okay. Can you see it now?
Yes.
Yeah.
So So a periareolar incision was taken and then deepened up to the lump. And then we actually, in the entirety, the lump is dissected bluntly with a finger. And after you do that, then you take out the lump, deliver the lump through the incision. And delivering the lump, there will be a bit of tissue that will be attached to the normal breast tissue, and that can be either cut with a cautery, or you can ligate it with a suture, or just do a sharp dissection. Here it is, enucleation is good enough in young females, because the normal tissue that was compressed because of fibroadenoma, that will spring back to its position, and it will give shape to the breast, as well as it will the normal growth of the breast. But in case of females who are in the age group of 30 to 50 years, and especially when you are dealing with a giant fibroadenoma where you have got any doubts of the phylloids, in those conditions you can take a thin margin of the normal breast tissue. But in young females, it is usually not required as far as this is concerned. Enucleation is a very good surgery for these young females. And we took out these multiple fibroadenomas through a single incision, because fibroadenomas are very mobile and they can actually be brought to the same incision. So you can do it with a single incision, and it does give a very good cosmetic result as well. And most of the patients do very well with this. And usually the cavity that is created, as I said, that the normal breast tissue usually springs in place. So they will usually close up, but I gave a few sutures just to bring it together, and then you can give a subcuticular stitch in these patients. So this was one surgery. And then these were the lumps that were excised from this patient. There were 3 of them in different positions of the breast. This was another case, which is a very interesting case of a very young 14-year-old girl who I used a Gillard Thomas incision. I won't be talking much about the incision because Dr. Dev has already explained a lot about incisions. But if you look at the operative specimen of this girl, both the breasts were almost replaced by multiple studded fibroadenomas. This is not very common. It is a very rare thing. The problem with Gillard-Thomas incision in adolescents is that you do not have a pendulous breast. And these incisions can be very visible, and at times when keloids are formed, they can be very ugly looking. But in this particular case, I did not have any option. A Gillard-Thomas incision is usually good for pendulous breast, where the scar is going to be buried under the submammary fold. Then Dr. Diptendra has already given a very good discussion on the granulomatous mastitis. I will not go into the details, but this is another condition where excision of benign breast lump is granulomatous mastitis, though a very nagging disease, is a benign condition. And these patients would need wide local excision. And when this was a patient who had presented with multiple discharging sinuses and a wide local excision, including all the sinuses, and the tissue was done. And when this is a video where I would be showing you wide local excision, and wide local excision in benign breast lump is not very different from what we do for cancer, except that we are not very much worried about the margin, except the fine points that Dr. Diptendra talked about, that if it is granulomatous, you have to take out the ducts and all. And here I am giving a incision over the lump along the Langer's line. And after giving the incision, again, we deepen the incision to the lump. You can hold the lump with a suture, but you can also do a dissection using forceps. And once using forceps, you have to take a rim of the tissue around the lump and take it out. Usually we go perpendicular. We don't try to raise flaps. We try to take a perpendicular. The whole thing should come out in one go. And after the dissection is carried around all around, then in this particular case we would see that there was pus. This is frank pus that is coming out, because this case was a case of chronic mastitis which had formed a very painful lump. And after taking out the lump, this is the lump that was taken out, including the little rim of the breast tissue. And then what we did was we took this out and thoroughly irrigated the cavity with normal saline and betadine. Because there was pus, we planned to close. Many people would argue that there is pus, you can leave the incision open, but that would give ugly scarring. So we put a drain, and then we just approximated the breast tissue with a few sutures and gave a subcuticular suture. The patient did very well, and this is the cavity where there is a drain that has been kept, and a few sutures have been taken, and then a subcuticular suture was placed. This is the subcuticular suture that is placed. There are many other endoscopic, novel techniques that have come up for excision of fibroadenomas, like endoscopic lumpectomies, then vacuum-assisted percutaneous excisional biopsies and percutaneous thermoablation. But they are all under evaluation, and none of them have yet become the standard of care. So these two are very basic surgeries, which all the PG students should at least know, because these are the surgeries you start with. Thank you very much for your patient hearing. I hope I did not rush through. I'm just trying to catch up with time. Thank you very much.
Thank you very much, Arunima. That was very wonderful, nice and crisp. And I'm sure you are very much aware how late you're running, so you made it really short and sweet. Any questions, I'm sure you'll be answering yourself on the YouTube.
Yes,
so,
sir.
Thank you very much. I think my co-chairperson, if you have any comments to make.
I hope Dr. Nitish has joined in, but these are the e-certificates. Thank you very much, sir, for chairing the session, Dr. Arnab Gupta. And now we move on to our next topic. And I would like to invite the chairpersons, Dr. Debashish Ghosh and Dr. D.K. Sinha. Dr. Debashish Ghosh, we have already heard his introduction through Dr. Chintamani when he presented his paper, the consultant oncoplastic breast surgeon from UK. And Dr. D.K. Sinha is professor of surgery from RIMS. So please take over.
Dr. Sinha, do you want to introduce, or I'll introduce Dr. Razina Ahmed, who is a very senior consultant in Kolkata, practicing for breast oncosurgery, and she works at Tata Medical Center, and she's going to show us axillary clearance. And axillary clearance is slowly becoming a dying art, because that's the last complex surgery we have in breast surgical armamentarium. And I think this is something we all have to know, we all have to learn, but it may become extinct. It's like one needs to know open cholecystectomy in spite of doing lots of lap cholecystectomies. In the future, we may be just left with targeted axillary dissections, but let's hear and see the performance of Dr. Razina Ahmed for axillary clearance.
Very right, sir. Thank you very much. Should I start or?
Yeah, sure, go ahead.
Okay, so I'm going to share the screen. Okay, yes, axillary dissection may be a dying art, but the problem is that, like with open cholecystectomy, it's for the difficult situation that you need to be able to do it. It's the patients with extensive lymph nodes, large lymph nodes, and often stuck. And it may be a dying art, but it's a very necessary art still. So I'd like to show you the way we do this. There's a lot to the anatomy. You think of the axilla as just being the pedicles, but there are a lot of other things. And what I'm going to show you first are the end points of the dissection, level 1, 2, and 3 with the important structures, but also remind you that there are some other structures that we need to take into account, not just the two main pedicles. So here we go. This is a patient who had a mastectomy. And here we are, there's pec minor at the top, and you can see pec minor underneath. In fact, you can see a lymph node just there, just lateral to pec minor. As we dissect here, we see the lateral pectoral vessels, and they lead us to the axillary vein. It's a good idea not to divide these right at the beginning of the procedure, but to use them to follow down to take us to where the vein is. We divide the clavipectoral fascia there in line with the ulnar border of the arm. And if we get the position right, it really doesn't take very much. And very soon we begin to see the axillary. There it is. So we've identified the axillary vein easily in level 1. We move along using scissors. Sharp dissection is always the best. And we just move along level 1. But now what I want to show you is the way we do it. Here we are just detaching now the pectoral vessels from there. And what we do is, instead of starting the dissection with level 1, Once we've identified the vein, we now move upwards. So just freeing up the vein a very little bit more. But then we go away from the vein onto the medial wall of the axilla, the lateral chest wall, and we move upwards. Here it's safe to use diathermy, which is something we don't want to use close to the vein. When we see the medial margin of the pec minor, we follow the pec minor, and there you are. You can see its medial margin. And look, there's a fascial layer that attaches the axillary fat to it. Just detach it a little bit there. And then we reposition the retractor and it shows us level 3. I hope you can see this. It's not the easiest operation to film, particularly in COVID. Anyway, then we move the level 3 tissue. We dissect it gently with scissors and move towards the vein. No traction at all on the vein. The tissue is gently swept towards the vein. And then we actually expose the vein in level 3 without having seen it at all really in level 2. We then take this tissue with a little bit of tension. And what this does is it pulls the medial interpectoral tissue down and continues to expose the vein. You can see that the apex is clearly visualized. We put 2 Liga clips in at the apex of the axilla to try to partner our radiotherapy colleagues. And then we come down, still staying away from the vein, clearing the tissue from the medial wall of the axilla. Pull the tissue down, and there we are along the inferior margin of the vein now. You can see my face shield coming into the picture. This was filmed last week, and it's very difficult to film anything just now when we're operating in times of COVID. Anyway, here we go. The tissue comes, and as we come down, the next structure we see is the intercostobrachial nerve, which we want to dissect out clearly and divide, sharp dissection, sharp division of the nerve. If you get a little bit of bleeding, well, you hold the vessel away from the nerve and you can just stop that bleeding with a short bit of diathermy. Now you come down to the long thoracic pedicle, and look, we're dividing tissue as it comes away from the chest wall towards us. We don't need to split into long white strands. By simply dividing the tissue with sharp division, we've easily exposed the long thoracic nerve there. Sometimes there are small vessels. We don't want to diathermy too much near the nerve, but we need it for the vessels. There's also a vascular pedicle, as you can see, running down there with the nerve. We stay lateral to that so that the long thoracic pedicle is on its own little mesentery and flips back onto the chest wall. Then we come back along the vein bit. To show you another structure which is important, which we often ignore. This is not the pedicle, this is the lateral thoracic vein. It's important as a marker for the thoracodorsal pedicle, but the other thing that it is important for is if you think of reconstructive surgery. So the thoracodorsal pedicle is on a much deeper plane. Go down, expose it. And once we've seen here, actually, the pedicle, the dorsal pedicle was medial to the lateral thoracic, which is a bit unusual. Liga clips on the vein and on the accompanying artery. And there you are. There's the pedicle, there's the nerve, and here are the vessels. You can actually see the pulsation of the artery. Now we come between the 2 pedicles. You can see the tissue being dissected off the thoracodorsal nerve. Now, I want to remind you that when you're dividing the tissue, it's actually not that difficult to damage these pedicles, even though you've already seen them. So they must be divided by turning the tissue this way and that, so that it's always divided with the nerves or the pedicles under derivation. I don't like using diathermy. We mostly do it with sharp dissection. There again is the long thoracic nerve, and look, you could easily damage it if you don't turn the tissue back and forth to have a good look at it. There is the nerve curving towards the chest wall. And the tissue, the axillary content comes off. We bring it down easily between, and you can see the first intercostal nerve as you come down the pedicle. You can actually see it higher up in this picture. So there we are. We do immediately dissecting the tissue off the thoracodorsal pedicle and moving inferiorly. And as we do that, we're going to come to the Y junction, which is the inferior margin of our dissection. We're going to take a little tissue off. We don't really dissect lateral to the pedicle unless there are big nodes there, which is sometimes the case. There are little vessels that come off here that sometimes need to be divided. And here we are, the axillary content of the serratus, of the latissimus dorsi muscle, which I think you can see just there. I want to show you, again, to do with COVID, use diathermy with your suction as a smoke extractor. Not all of us have the luxury of actually having a proper smoke evacuator. We review the apex, make sure everything's dry and that the Liga clips are in place. And then we come down and have another look at the two pedicles. There you are, long thoracic, thoracodorsal, and there, the inferior margin of the dissection. So I showed you this anatomy. These are all the major structures that you need to keep an eye open for. But when you dissect for early disease, you may not go up to level 3. So some of them become less important. But on the other hand, what is important is to remember the other structures, the lateral thoracic, the medial and lateral pectorals, the intercostal brachial and first intercostal, which we want to avoid damaging because we want to avoid complications such as nerve injuries, lymphedema, and shoulder stiffness. We do this by avoiding diathermy, being gentle with the way we dissect. And I think that's the end of my 10 minutes. Thank you.
Thank you, Dr. Rosina Ahmed, for your excellent presentation. Thank you, Dr. Rosina Ahmed, for your excellent presentation of axillary clearance.
Thank you.
Questions will be answered on YouTube, so I don't want to ask any question.
No, thank you, Rosina. That was a wonderful demonstration. As I said, every resident, every junior must learn the proper axillary clearance, and it's still the gold standard for patients with positive axillary nodes. And when you have a heavy burden of lymph node disease, you must, it is still better than having radiotherapy. So still need to learn and do a proper axillary clearance. Thank you.
Thank you very much, ma'am. Dr. Rosina Ahmed, this is a e-certificate for your talk, and e-certificate for Dr. Debashish Ghosh for chairing the session, Dr. D.K. Sinha for chairing the session. Thank you very much. We move on to the next talk, and I invite chairpersons Dr. Makhan Lal Saha, and I have taken the liberty of putting myself as the chairperson in between two of my own teachers, because Dr. Makhan Lal Saha, he is the professor and head of the Department of General Surgery, IBCMR, Kolkata, and is the Executive Council member of ASI. He's a member of ABSI and ex-honorary secretary of ASI West Bengal Chapter. And we all know, as students, we have all known him for his book. And this is me. I have been there since morning, so I will not introduce myself. I would ask Dr. Makhan Lal Saha to please introduce Dr. Chintamani, who actually doesn't need any introduction. Makhan, sir?
Yes. Am I audible?
Yes, sir, you are.
Dr. Chintamani is already introduced. So he is a very known face in ABSI, and he is the present governor and president of American College of Indian Chapter, president of Asian School of Astrology, and I introduce as a very dedicated PG teacher who can be in his chair from 9 o'clock in the morning to 10 p.m. at the night at a stretch. So he's a very dedicated PG teacher. He is known to all PG students throughout India, and I consider him as one of the best PG teacher in India. So it's my pleasure to present Dr. Chintamani for his talk. Dr. Chintamani, please.
Thank you so much. You're very kind, Mr. Shah. It's such a joy. You're always a part of what I do. So thank you very much. And Dr. Arinumak, I'm just trying to share my screen. If you could help me with that, I think I could do it now. Is my screen visible?
Yeah.
Thank you so much. And thank you very much, Arunima, for a wonderful. Sorry. Where do I stop it? Okay, let me mute it first. And I wanted to thank Dr. Arunima for organizing such a wonderful meeting, which actually is one of its kind. And as somebody pointed out, it will actually beat the conventional meeting. And many of us are going to see a new normal very soon. And this is going to be the way we will be probably doing it. Well, my task is a little overlapping with whatever I was not aware of the executive dissection part. So I made it into, I'll see if I can do anything about the video, and I'll probably try to speak briefly about what has been spoken. One good thing about breast meetings, and also the bad thing about breast meetings, is that even if you don't want it, there's a huge amount of overlap. And a lot of you would feel that something that is spoken in the morning is getting contradicted, but that's only good news, because you don't really know what is the correct answer. And if anybody says, I've given you the last answer to the problems in breast related disorders, probably he doesn't know anything about it. So I'm focusing on what Arunima wanted me to do. She insisted that I must speak on modified radical mastectomy, which I told her is a very, very old video of mine. It's been shown so many times, continues to be an educational video. So it'll have the basic steps of modified radical mastectomy. And I definitely echo what Dr. Rosina was saying. I don't think any of these things. Mastectomy is on the rise in the US. We won't discuss for what reasons. And axillary dissection is mandatory. You must know how to do it properly. Once you learn how much to do, you can tailor it. You can't start by tailoring. And I've been exposed to so many centers where a resident is not trained into doing axillary dissection at all. So I'm glad she mentioned about level 3. I'm going to reinforce on that. Learn it. You may not need it, but that doesn't mean you would not learn it. So about the incision, well, this is a modified Stewart incision. Remember, there's no rocket science here. Most incisions are placed along the lines of less tension, and we are looking at blood supply being excellent. And the flaps, the blood supply to the breast is through pedicles from all around perforators. So they're medial, superior, inferior, and lateral perforators. Therefore, the incision should be just about lateral to the lateral border of sternum, and anterior should end at the anterior axillary fold. You should not get into the axilla unless it is mandatory. You cannot say always. Always is always wrong in surgery and science and in life. Please don't ever say that. It varies. Nowadays, what we do is, if we need to go into the axilla, we go a little up. So that's called an oncoplastic mastectomy. I learned from somebody else, which is what I modified. So please remember, especially the postgraduates who are sitting there, I think they are the impressionable minds. They shouldn't go back thinking that everything has disappeared. We'll just wish and the cancer would disappear. We'll sing a song and the axilla would be dissected. It won't happen. We need to know how to do it, and then you can choose your cases. I fully agree. If level 1 is negative, the chances of level 3 being positive are less than 2%, so you may not do it all the time. But I'm going to stick to the conventional modified radical mastectomy. And first of all, what is it? Modified radical mastectomy is removal of the breast along with nipple areola complex, along with an ellipse of skin with a margin of 2 centimeters, along with pectoral fascia, along with the axillary tail of Spence, along with all the levels of lymph nodes, level 1, 2, 3, along with rotus nodes. And remember, sparing the pectoralis major and minor with their nerve supply, because there's no point preserving the muscle and not preserving the pectoral nerves, medial and lateral. And also making sure that you are preserving the thoracodorsal pedicle and the nerve to serratus anterior. So there is no mastectomy where axilla doesn't come into discussion. So Even if it amounts to repetition, I'll reinforce it and probably I'll say the same thing. So that's a conventional definition. Well, if the tumor is deeper than normal, then you can spare the skin. If the tumor is more superficial than deep, then you can spare the pectoral fascia. Then there are modifications. There are skin sparing, nipple areola skin sparing, mastectomy, what have you. But I would urge you that even today, 25% 5-year survival rate on the table you can get with a good modified radical mastectomy. I think it's a workhorse of a general surgeon, and every surgeon must learn to do a good modified radical mastectomy. There's an article of mine, editorial, which I did in 2011 on 10 commandments of modified radical mastectomy that will help to actually make that point. Now, I'll just try to move now. Yes. Hope it moves. Yes. Now, these are various incisions. Like this is a smile incision, which people have modified. What does it mean? What is actually, I mean, I have 20 minutes and I'll try to cover everything. Especially in the lower tumors, you can take an incision which kind of takes a smile here. You have a longer superior flap and you need to be extremely careful with the blood supply. But if you do that, you can actually get the closure, which is in the form of a smile incision. Now, so it'll be looking something like this, and you can actually give a smile to the patients. I mean, these are things which are modified. I think laziness was touched upon by I think Dr. Dev, and also by Dr. Devashish when he was mentioning about the incisions to be planned. There are multiple lesions, then you can probably, but you can see that I'm not getting into the axilla. Most incisions will be, the scars will be the signatures of the surgeon. So make it a point. I think if it is it moving? All right. Now that's the oncoplastic mastectomy incision, which I'm just talking about just because it is possible to do without getting into the beyond the anti-axillary fold. If you think it is must to probably take out more skin in this area, then we can take the incision up towards the axilla. Now, these are some modifications I thought I'll share with you. Now, this is a quick one. You can sometimes do a fishtailing at the ends, which again is something that you must learn about. That's fishtailing. What that will do is then pull up the fold that hangs down. That's demonstrated on a glove sling. You can go to the YouTube and probably see this video. It will prevent it from sagging. You often have these patients coming back with a sagging fat in the axilla. This would be quick, and then the video would follow. Now, how thick is thick? That's how thin is thin. I mean, we normally go by the plexus of veins rather than anything else. And then we go medial to lateral. This is our practice. It is easier to go medial to lateral when you're doing mastectomy because the breast by itself, by its own weight, acts as a traction. And medially, there is minimal breast, so you're able to reach the pectoral fascia and down if you want to. And you can get the medial perforators early and then go medial to lateral. I'm very, very particular on sharing this slide. It's a very old picture, but it shows medial and lateral pectoral nerve. And remember, medial is lateral and lateral is medial. So don't get confused by the term medial is medial. They're called so because of the cord from which they come. And if you preserve pectoralis major and don't preserve these nerves, you wasted your time, because then there's no point preserving the muscle and not preserving its nerve supply. So that's about the medial and lateral pectoral nerves. And then you see them, and this is actually classically what, if you do reconstruction with PMMC flaps and especially head and neck surgery, which we do quite frequently. And this is how the pedicle shows. This is the pectoral pedicle. You must preserve it. This is what supplies the pectoralis major, and this is what is responsible for the blood supply to the major part, which I was referring to. I'll quickly go through it, and then I'll have the video on. We almost nobody cuts pectoralis minor anymore. And as you saw in the axillary, the previous video also, you can simply lift it up, or you can take it on a sling. We take it on a sling and we do level 3 first. Although it's optional, we do level 3 first because that's kind of taking the top of the mountain and peeling it down rather than going from the base of the mountain going to the top. But it's a matter of training, and lift it up on a sling. And once you have it on a sling, it's easier to go either side. And remember, a lot of people, by taking the pectoralis minor either way, by flipping it here and there, make a level 2 into level 3. Anatomical landmarks, as Dr. Rosina showed, are mandatory to demonstrate at the end of the surgery. So it's not just the being medial to pectoralis minor would make it level 3, you must look for the endpoints. Well, a word about intercostal brachial nerve. If you demonstrate it, and if you think it's getting into the tumor, we should try and preserve. Now we have an era of nerve preserving axillary dissection, but remember, hyperesthesia is worse than hypoesthesia. So if you have The nerve getting into the tumor, it's safer to cut it, and never use a diathermy to cut it. It leads to neuromas, which cause persisting pain. And if you have to preserve, this is the one which we preserve, the topmost intercostal brachial nerve. And with lots of reverse XRD mapping work that we have recently published, if you stay below this, you're not getting to the arm lymphatics by and large. So that's one thing I wanted to share here. When you're cutting it, use the cold scissors to cut it. That's what you see. You will cut it with the cold scissors. You can see the nerve to serratus anterior. Once you've demonstrated that, then only you can do that. Or you can use sealants, and sealants really reduce the seroma rates. This is what we observe, although nobody knows what reduces seroma. Shall dissect from level 3 to level 1. This is these are some commandments that I've mentioned in my editorial, so you can always go back there. And level 3 for us is mandatory. We do it. We teach students, and actually importantly, if you don't expose them to it, the burden, the kind of auxiliary burden we have, I agree with so many mentioned that we are now doing about 50% breast conservation, unlike in the past when the breast conservation rates were very low, and they're getting better, but we still must talk about Indian solutions to Indian problems, something that I'm very, very particular and fussy about. We must deal with our problem, and our patients have auxiliary burden, so we must learn to do level 3 dissection. And there's nothing like you would add to the lymphedema rates just by adding to level 3 dissection, while unnecessary dissection is not required. And as I mentioned, if the level 1 and 2 are negative, well, level 1 is negative, they're rarely, with the possibility of level 3 being involved is less than 1%. Now, this is axillary vein that is being seen on the medial side. We look at the Halsted ligament as the medial limit. That's what is shown here. And the lateral limit is thoracodorsal pedicle. The lower limit is the angular vein, and superior limit is axillary vein. So you must know the endpoints before you proceed. This is how it looks at the end of the day. That's the axillary vein, superior border. That's the Halsted ligament. That's thoracodorsal pedicle. That's angular vein. We invariably take it on a sling to clear all around, as Dr. Rosina also mentioned, that you may sometimes just be clearing on the medial side and now to serratus anterior. It's not necessary to carry out an anatomical dissection, but depends on the scenario that you're in and also the axillary burden that you're dealing with. Well, so that's now to serratus anterior. Never try to peel it off completely. We don't use diathermy in the parts closer to the axillary vein. However, below you can use it. And even here we prefer to use a right angle mixture, which I've found very, very useful. And we train our students into learning the one correct way of doing it. This certainly is not the only way of doing it. So please bear with me when I say that this is to be done. There are 100 ways to skin a cat, 100 ways to reach Rome, as long as you reach there and you reach alive. Now, that's the sling I'm referring to, which is taking it on a glove sling causes minimal neuropraxia. This is another aspect of axillary dissection that we teach, or mastectomy we teach our residents. They must learn to dissect this pedicle, and we also now preserve lateral thoracic vessel, as Rosina also mentioned rightly, because that can be used for the flaps. And we published it way back, and this was optimum axillary dissection, the lower limit being the it'll look something like this once you've done mastectomy clearly. And must always orient your specimen. It's the same whether it's mastectomy or lumpectomy. Short superior, long lateral. We dissect our own lymph nodes. Our residents dissect count before we send level 1, 2, 3, because we invariably have found that pathologists end up counting less. Now, a word of caution here, we have actually done this randomized control trial, and we have published this with an ISR CTN number. Somebody who's been listening to it before would say that we keep talking about it. Lots of data has poured into it. We are going to go for a republication of this. Half suction is what we have found to be useful in our scenario. And the mistake here, as you can see, one, the incision has gone into the axilla, and also that the drain is far away. Never keep a drain too far away from the incision, because this will become the site for radiation to be included. So one has to be careful. You should not put drains too far away, especially in oncological scenario. The drain shouldn't come through the wound, but it shouldn't be too far away, as you can see in this picture. So this was obviously meant for that purpose. Now, I think, and that's the trial I was referring to, where we found that it can be a useful method. Now, that's a video which will be quick, and then I'll deal with you, and I'll probably deal with some of the aspects of the newer modalities that this is when we were validating. It's an old video, so we're validating a sentinel node biopsy. This is when it was that you make an incision. Never give an incision postgraduates. It's making. Incision is always made. There's no giving. And the superior flap is usually the way we go first. It's optional. Mute others, please. You mute. Thank you. Thank you. Now, Here's the superior flap. And as Dr. Deo mentioned beautifully, it is clavicle, which is upper limit, but don't look for it. You just need to remove the breast footprint. You don't need to go right up to the clavicle in all the cases. It depends on the build, the size of the breast, etc. In this case, I'm showing the classical and the conventional method. So we are trying to take the pectoral fascia, we chase it, and it's not mandatory, as I said. And you can see the plexus coming in. Now, how thick is thick and how thin is thin? Quickly here. Usually the postgraduates are taught, and I'm sure that's applicable to all surgeons who practice, and 80% of this surgery is done by general surgeons, which is not at all a problem because they do a fantastic job of the same thing if they learn the correct way. This is to go between the smaller fat lobules of the subcutaneous fat and the larger fat lobules of the breast. And this becomes difficult in an obese person. If you can stick to that plane, it's relatively avascular. But we rely on this plexus of veins, which again we have published based on 400 mastectomies that we did, that you can actually leave behind no breast tissue, and the skin necrosis rates are very, very low. There's no point leaving breast tissue on the flap if you're doing mastectomy. But you got no business to leave it if you're doing it. Otherwise, when you're doing something, you should do it properly. And remember, in cancer, treat cancer first. If you ask a patient, do you want what? You should not scare the hell out of the patient, but must always be clear that cancer needs to be fixed first. And that has not changed. And be very, very careful that we cannot afford to have a less than optimum job done. Now, and as Dr. Debashish mentioned beautifully, a good axillary dissection would be better than radiation. So I agree with him completely. So we lift it up, and you can see the ligament of Cooper. So you believe that they exist. We keep going, and as we lift the pectoral fascia, it's a bloodless plane, medial to lateral, and you can see more ligaments coming, and finally you'll be reaching the lateral border of pectoralis major. Now, it is important to understand that you cannot understand axillary dissection or mastectomy in isolation. I wasn't aware of it, but the two are connected. As to how do you do mastectomy, we'll decide how do you do axillary clearance. So laterally, we open the clavipectoral fascia, and we lift up the pectoralis minor on a sling. We use an infant feeding tube. Pardon my overlapping, but I think I'll quickly just be adding to what or reinforcing what has been already spoken. I use the right angle mixture. Traction, counter traction is a way in surgery you should clear off from the Halsted ligament. And it's going to come into view very soon. Halsted ligament is the medial limit and must demonstrate it. We used to put clip earlier, but we don't put it anymore because the radiation oncologist is benefited if you do that. Earlier, it was to just demonstrate that we are clear up to level 3. You can see the counter traction with the forceps and just gently peeling off the tissue. We don't have to bear the axillary vein completely, but this is where we see it first, and it's not difficult at all. It makes your job much easier because you start from level 3, you're just peeling it down, it becomes easier. And actually, you can see the supreme thoracic vessel, which is a part of the first branch of axillary. That's the first part is 1 branch, second part is 2 branches, third part is 3. The first is supreme thoracic, the second part is lateral thoracic and thoracoacromial, and third is anterior posterior circumflex humeral and subscapular, you know that. So this is what gentle dabbing is. We don't scrape with gauze. We use a wet gauze piece. This is a technique we have demonstrated all across the country in workshops. We gently just deliver the gauze down, and that will bring down level 3 to level 2. And remember, this is not by moving the pec minor that I decide level 2 has been done. Because the other reason why we insist on level 3 dissection to be taught is a lot of people then don't do even a good level 2 because they do 1.5. Because you see, if there's no landmark they stick to. So as you come down from level 3 to level 2, we reach the lateral thoracic vessels. This is an old video, and we don't sacrifice lateral thoracic vessels at all. And that is the lateral limit of level 2. We have already cleared the interpectoral group, rotus group, which is a part of level 2 only, mind you. So we will run into these 2 vessels, which you should know where they exist, because not seen is damaged these days. Seen is safe. So if you don't know where that's the nerve to serratus anterior, which shows automatically. Don't go chasing for it, but you must clear off all the lympho-fatty vascular tissue in this. When you're doing an axillary dissection, might as well do a good job of it. And lateral thoracic vessels may be left alone, as I'm repeating that constantly, because you can use lateral perforator flaps along with the lateral thoracic artery flaps or L-taps you can use for reconstruction. We are doing a project on that. In fact, it's the thesis of my postgraduate this year. So we preserve it, but how do you teach them how to preserve? That's thoracodorsal pedicle. It comes automatically as you go medial to lateral, and you can see all the three together. Artery, vein, and nerve, they may not be all the time. And in this case, you can see that's a nerve, that's a vein, and the artery. And we lift it up on a sling, glove sling. Earlier, we were using a nerve hook or some hook, but that causes neuropraxia to the supply. And this I teach all my students because Lexman's dorsal flap we teach to all our residents who are training under us. So they must know where the pedicle is. Once they know where it is, it becomes that much easier for them to preserve it. And that's a very simple way to do it. Now the glove sling minimizes the neuropraxic damage that can happen. Here again, you can see we're just teasing the tissue away. You don't need to use diathermy here, as was rightly brought out earlier. And the dissection just proceeds down and we reach the angular vein. Now that's about the nerve to serratus anterior, and that's intercostobrachial now. Now what do we do with that? We use a cold scissors to cut it, no diathermy. Although you can use a harmonic scalpel, that should be fair enough. But we have preserved the topmost intercostobrachial now. If at all we have to, but otherwise, I have no problem with hyposthesia. It is better than hyperesthesia, but preferable to preserve it, as I said, unless it's getting directly into the tumor, which in this case was the case. Now, the lateral limit would obviously be the latissimus dorsi. We trace this pedicle down to where the latissimus dorsi is. Actually, more than anything else, you bear with me. This is for teaching our students also. It's not just about us. It's about training the next generation into doing the right thing. And as somebody brought out very rightly, there are people who cannot do open cholecystectomy today. So laparoscopic cholecystectomy is the gold standard, but gold standard is not the best option all the time, remember. Gold standard is just a method of titration. Subscapularis muscle appears, and don't get the fascia out of it. Don't scrape the hell out of it. You should leave the fascia intact, but that's the floor of the, when you're doing the dissection. And like I said, I can't separate the two. So now you can see all three, artery, vein, and nerve. That's the thoracodorsal pedicle. And we take a lot of joy in sharing it with our students. Remember, angular vein sometimes can serve as the pivot for the flap also. So they should learn about the anatomy during this procedure, and they should be clear on what to do. And this fork, as they say, sometimes has lymphatics, which we must clear. And thoracodorsal, this is the nerve to serratus anterior, and we're more or less done. We should make sure that the vasa nervosa along with it is also preserved, so that we don't devascularize it. We were tying earlier. You can use clips. That's the Halstead ligament, and I'm showing it again. Level 3 and vein there, and properly done. Even in the last ABSI and Soma meet, we demonstrated that the rates of lymphedema may not be as significant as they are shown. The technique being very, very important. That's a pedicle I was referring to earlier. She's shown its picture. So that's about it when it comes to preserving these structures. After completion, I've shared with there are some, I think, since I cannot underplay the importance, you have one workhorse I've cut down on other major ones, which is round block mastopexy, which I considered. Our data is ready. This can be applied to almost all quadrants, and it can go beyond the distance that people refer to. That is about 3 to 5 centimeters. If you're in the mastectomy plane, you can take out most of the tumors. This is level 1, bordering level 2 oncoplasty. That is when you do less than 20%, depending on the cup size, many things. So this is already, the pictures were shown by Dr. Devashish, but quickly, I'll just take another 4 to 5 minutes to wind up. I still have time, but I'll be done with it very quickly. So that's basically it's called donut mastopexy, or the Benelli's technique, where it looks like the two concentric circles, making sure that deepithelize, all it does is it gives you a bigger window to get in. You can get a clear margin. Oncoplasty has made it possible to take larger margins, bigger margins, and you can actually, that's how it looks. And then you go in the mastectomy plane, you keep raising it exactly the same way. We demonstrate this venous plexus here also. We stick to that. That usually ensures the viability of the skin flap. Towards the nipple areola complex, you use the cold scissors, at least initially. And needless to say, the tumor was not barging in there. Otherwise, we'll take a biopsy, which we did in this case, the core to be sent for frozen to make sure that your medial border, which is a challenge here, is not positive. And we'll make sure that we mark it separately for the specimen imaging, which we do as a routine. And orienting the specimen becomes necessary. So short superior and long lateral, which we then basically it's the pillars which have to be approximated. A very simple, very easy procedure to learn and do. it is possible in most cancers, most scenarios, especially when you're thinking of breast conservation. We put the clips in the tumor bed for the boost or radiation oncologist to be guided. Axillary dissection is done as usual, so I'm skipping that. And then we take U stitches to get the pillars together. We don't do biplanar mobilization of these pillars. It's one that you should do. It shouldn't be too aggressive, otherwise you may devascularize these glandular pedicles. And then with the drain underneath, we can actually close it.
Part. This is the last part of the demonstration?
Yeah. I have 20 minutes, Dr. Shah, and I've got the watch in front.
Okay.
Now that's the last part. Don't worry, I'll just finish. Thank you so much. Now we put a purse string, and you will see that reduces the centrifugal force. And once you've done that, it kind of lifts up, it improves the ptosis. But remember, this marking is important, the one towards the areola. And we'll also put clips on the parts towards the skin, so that we can, when we do the specimen imaging, we'll be able to see how far, if at all, it's positive, or the microcalcs, which you can see, and the results are good. This is one procedure we swear by, and the hypothesis that we have is that it's applicable to all quadrants. We've tried in most of the quadrants. Inferior is a challenge, of course. With ptosis, it becomes difficult, may not be useful. And you can get very good results. So this was one, and this is a central quadrant tumor, which is the last part, which is just 2 minutes, maybe 1 minute. So we mark it. Grisotti was mentioned by Dr. Debashish. We must be, when it's a local flap, which is based on the lateral perforators, immediately we can cut it right across, and we measure the size of the nipple areola complex that we need to have here. And then based on the feeders from the lateral side, we try to keep the medial side intact, and it's kind of pushed into this space that will happen when we take the lesion out. Central quadrant used to be earlier a contraindication or a difficult scenario for conservation, but nowadays it's possible to do it. That's why I shared it. I was just keeping since I was given the task of dealing with some of the evolving procedures, I'm dealing with it. And the more you can watch on the YouTube videos, and we deepithelize this part. Naturally, this will go inside. We'll undermine the edges on both the sides of the skin. The skin would be basically covering it up. And the intent is to kind of make it into an advancement flap, which will fill in here once we get the tumor out. And it's not mandatory to be very, you don't need fancy, difficult oncoplasties all the time. Most of the time, it is possible to do it with simple incisions, which are placed properly. Like I mentioned about the oncoplastic mastectomy, anything which, which gives a good cosmetic outcome. And that is decided not by us all the time, but by the patient. And therefore, we should not do these procedures simply because you're watching them happen here or you're watching them happening elsewhere. And that doesn't make anybody a much superior surgeon. It's one way of treating cancer with good cosmetic outcome. And as you can read, oncoplastic means you get an oncological clearance as well as you get a plastic outcome. Well, this can get better. It's immediate post-op. And as you go along, it keeps on getting better and most patients are satisfied. Well, that's the last part of this is almost 15 seconds. That's wise pattern. If you're doing reduction mammoplasty along with the tumor located, you can actually get it in both the things fixed at the same time, but it's applicable to, this is advanced oncoplasty, which requires a teamwork and training, and it's not mandatory that one must learn it. It's not applicable to all scenarios. Patient should be willing. Patient should be willing for a contralateral surgery also. There's no point improving on one side and doing any kind of heroics on one side, and the other side the breast remains where it was. And a lot of our patients are not very keen on a contralateral breast handling, and that's where it can be a challenge. Just give me 15 seconds and it's over. And well, it's been made very fast so that I can cover it up. Basically, it'll show up in a little cartoon that will come. What do we actually do for the benefit of all the students and the general surgeons or others who are practicing? This is no rocket science. Everything is possible. You can learn it and do it. The key is learn one correct way of doing it, and you will be able to do most of these surgeries if you are trained. But the warning here is don't leave the cancer there. We are a referral tertiary center. We deal with all sorts of heroics done, which is not really necessary. Do a good mastectomy when you don't know what to do. This is the whole crux of it. Well, I just have made it faster so that we are done. And actually speaking, it's a teamwork. People trained into assisting you are also necessary. You cannot always be doing it in any setup. There is a mandatory MDT meeting for all cancers that we treat now. It is also getting on recorded. We keep everything recorded now. The data has to be recorded and processed. We have a challenge. We are a big hospital, poor man's hospital, but we can still do it. And every poor patient also deserves the best option. And we have done many and they are happy. But it is not always necessary. And that's the team you work with. Thank you very much for patient listening. Thank you, Professor Saha, and the organizers for giving me this opportunity. Thank you very much. I'm done.
Thank you very much, sir, for your wonderful presentation. I'm sure it was very useful to all students. And I would present this e-certificate to Dr. Chintamani for his talk. Dr. Makhalal Saha, thank you, sir, for chairing the session. And now we go on to the next speaker. And I invite the chairpersons, Dr. S.V.S. Dev and Dr. Pankaj Bodra. Dr. S.V.S. Dev is the head of the Department of Surgical Oncology, AIMS New Delhi, and is the president-elect of ABSI. And Dr. Pankaj Bodra is Professor, Department of Surgery, RIMS Ranchi, and is the ex-treasurer of ASI Jharkhand Chapter. Over to you, sirs.
Thank you, Dr. Arunima. I think I will introduce Dr. Ashwin. The next talk is by Dr. Ashwin. He is a consultant surgical oncologist and a robotic surgeon, HIPEC surgeon from Manipal Comprehensive Cancer Center. He is working with Dr. Somshekhar in that hospital. He is currently the honorary secretary of ABSI. He is a very young, dynamic surgeon, and he's going to speak on localizing non-palpable lesions in breast cancer. This is a very important topic. Dr. Ashwin, please.
Thank you, Dev, sir.
Okay.
It's a great honor that you introduced me. So I'll just start my slide. Is it visible, Dr. Anurima?
Yeah, it's visible now.
Okay.
And my co-chair is Dr. Pankaj Bodra. Sir, you can sum up the talk after my speech.
Yes.
Right. So my talk is basically about surgery for non-palpable lesions. And so this is what the experience of we do in Manipal. As you know, now it's coming up from minimally invasive surgery that's usually dependent on the radio-guided surgery. So there are three types of radio-guided surgery that we follow. One is the role that I'll be presenting on. It's basically radio-guided occult lesion localization for non-palpable breast lesion. Other is what has been already been discussed, sentinel lymph node biopsy. And another is a combination of both is called a SNOL, that is sentinel node and occult lesion localization. So I'll be presenting my on role, that is basically using radio guided dye in order to identify the suspicious non-palpable lesions. So why has this come about is because with the better screening programs by mammogram and ultrasound, we are seeing that more and more ladies are coming to the hospital and getting themselves screened on their own, and we are detecting early lesions and smaller lesions which are basically not palpable. And these lesions aren't stereotactic or ultrasound guided biopsies. If they're either suspicious or malignant, we need to excise them. So what we use is this radio guided method in order to localize and also excise. So there are basically two techniques. One is the radioactive injection sulfur colloid method. Another one, which is the newer one, which is the iodine I-125 seed implantation. So these are the occult lesions that we usually come across in Manipal, either by mammogram or by MR mammogram. It can be usually about 0.5 centimeters or less than 1 centimeter, which based on MR mammogram having showing suspicious activity, and they get biopsied. And if they're suspicious or if they're malignant, we offer them breast conservation surgery with the help of roll. What was gold standard or what is most popular is the wire localization. But the issue with wire localization is it is the poor patient compliance. Basically it takes a lot of you need a good radiologist to put the wire in the exact position. And not only that, because the wire part of the wire is sticking outside, it can move It can the tip can go to the adjacent area. There is basically migration, and even the small lesions, we end up using the bigger needles, so that also causes makes the excision tougher. And even more, there is data showing that wire localization has higher positive margins because all because of the movement of the needle. So what we use, one of the novel methods is called as roll, which is basically they are same, the either stereotactic or ultrasound guidance. We use the same dye that we use for SLNV, where 1 ml of technetium sulfur colloid is injected into the breast lesion under ultrasound guidance. It takes maybe about 30 seconds to inject it. Another method which is coming to India now, or which is very popular and actually pioneered by the Mayo Clinic, is the same iodine 125, the radioactive source. These are sources which were used for brachytherapy, but after complete degradation, this has been found that it still has a little activity, and iodine seeds can be implanted by stereotactic or ultrasound at the lesion. See, one of the advantages of iodine seed compared to the injection colloid is that iodine seed has a longer half-life, so it can be put overnight or even 1 week before. So you don't need to coordinate the radiology and the surgery. As you know, all these are daycare surgeries. So most of our patients come in the morning, they go to the radiology department, they get injected, dye injected, and within 1 hour they have to come to OT in case of the injection. But in iodine seed, one of the advantages is that this can be placed much before, 2-3 days before, in fact. But again, the disadvantage is that it is little expensive. And one more important thing is they both of them are different signatures with respect to the dye. So what we follow is, if it is a malignant lesion, we try to put the iodine 125 seed in the primary, and we use a technetium sulfur colloid for SLNB localization. So this way we see that there is no cross activity. So what is the technique? Like I said, the patient goes to the radiology department, and the nuclear medicine dye is ready, and they inject it and at the center of the lesion, and the patient is got to the OT. And under general anesthesia, we first we make sure that the setting of the Geiger counter is accurate, and we find the localize the lesion before incising the skin. And once this is done, the incision is planned on the cosmetic basis, and we go with the help of the Geiger counter, we go up till the lesion, and we basically go till the hot spot, and carefully we excise the entire hot spot with margins of about 1 centimeter. Once the excision of the hot spot is done, we have to do two things. One is make sure that the cavity, we use the counter to make sure that the counts have reduced to less than 10% of the original. And second, we mark, just like any other breast lump and of excision for malignancy, we mark short superior, long lateral, and double to the base, and we send it first for either specimen mammogram and also for frozen section for identity or making sure that it is indeed malignancy, and also to see that the margins are clear. So this is the same, the pictures of the patient that we have treated with the localization, with the confirmation based on the counter, and this is the specimen. This is a short video where our radiologist, with the help of ultrasound, goes identifies the lesion, and they have the sulfur colloid, which is injected with either a 23 gauge should be usually enough, and the patient is got to OT, where we localize the hot spot. We make sure that the entire hotspot or the entire lesion is completely excised, yeah, and the margins are marked. And again, the confirmation, like I said, has to be done outside the body, and also make sure the inside the cavity the counts are less. And this is our experience. We have done from 2005. We have started this, and up till now we have done about 92 cases. And now we have proceeded to started doing SNOL also. This is a publication by Dr. Somshekar and my mentor, Dr. Zaveri, who have published this. And this is the latest publication. And this is our the publication. So the 30 cases that we have published, few were malignancies, and also we found fibroadenosis and fat necrosis also. So basically the conclusion of doing role is that you get a precise localization and excision of non-palpable breast lesions, which is becoming very, very common now. And it has been found that localization and excision is significantly better in role compared to wire localization. So it is a simple, reliable, and easily it can be performed. And the amount of with respect to the activity, there are a lot of papers saying that amount of radioactivity that you get is very less, in fact even lesser than what chest x-ray, and safe both for the patients and the medical staff. And I think it's a breast conservation, it's good cost measures, and we can also add a sentinel lymph node biopsy at the same setting. Thank you.
Thank you, Dr. Ashwin Kia, for a very beautiful presentation on role and showing us the way how to locate non-palpable lesions then. And thank you again, my co-chair, Dr. Dev. Thank you. Thanks a lot.
Thank you.
Thank you. Thank you. Thank you, Dev, sir.
Thank you, Ashwin. Thank you. Well done.
Thank you, sir.
Present a e-certificate to Dr. Ashwin and Dr. S. Dev for chairing the session, and Dr. Pankaj Bodra for chairing the session. Thank you very much. And now we move on to our next session, that is the panel discussion. And since we are running a bit short of time, we are going to try and reduce the panel to at least 5 minutes. We'll try to have a panel discussion a little shorter. So I now invite my panelists. Just to, let me start off with it. So the panel is on management of breast cancer, the challenges at district level and the COVID era. The reason for taking this topic was that since Jharkhand, we have a lot of districts and we do not have a specialized breast center, we would be wanting to know what the surgeon at district level should be doing. So a good surgeon does not concentrate on technical ability, but also on the appropriateness of keeping this in mind, we shall be dealing with this topic, and this is the panel. I'm the moderator for the session, and I would welcome Dr. Arnab Gupta, who's the Medical Director and Surgical Oncologist of Saroj Gupta Cancer Center and Research Institute, Kolkata, the President of ISO. Dr. Debashish Ghosh, Consultant Oncoplastic Breast
Dr.
Surgeon.
Arnima, we cannot see your slides, please.
Okay. Yeah, I'll just share again.
Yes.
Can you see the slides?
Yes, yes. That's right.
So I was just introducing Dr. Debashish, who is the Consultant Oncoplastic Breast Surgeon and Associate Professor of UCL London, and is the undergraduate lead of USCL Medical School. Dr. Sandeep Kumar, he is the ex-professor of surgery, King George's Medical College, University, Lucknow, and is the editor-in-chief of Indian Journal of Surgery. Dr. Sunil Kumar, ex-professor and HOD of surgery, Tata Main Hospital, Jamshedpur, and is the GC member from Jharkhand for ASI, editorial board member of JMS, and is a council member of Royal College of Surgeons of Edinburgh. So with this enigmatic comment that when things get designated as a specialty, that's like everything in the world. It's a good and a bad thing. There's a yin and a yang to it. It's a pebble thrown into a pond, and the ripples, you don't always see them coming. With this, we'll have a bird's eye view of Indian scenario of breast cancer. And this is a very common scenario where a young lady comes to us with a breast lump and taking local traditional treatment. Here you can see there is an ulcerated growth and some herbs have been applied. Then this also is not uncommon, where some time back excision was done and no histopathological report is available and the lady presents with a recurrence of lump. We also find fungating growths who land up in sepsis, and there is nothing else left except control of sepsis and then doing a toilet mastectomy. If we look at the breast problem epidemiology, this is what was published in the Annals of Royal College of Surgeons of England, that out of the patients who present, it is only 12% of them who are referred for a carcinoma. Most of them are benign, but this 12% we cannot neglect because their outcome can be life-threatening. So we will also look at what we have in Jharkhand, and this is a publication from one of the surgeons from Jharkhand, who also reported that 90% of patients attending a breast clinic will have benign breast disease, and it is the 10% who are having malignancy. So here, my question would be, Dr. Sandeep, are you there? Can Dr. Sandeep hear me? Are my panelists there? Dr. Sunil?
Yes, I'm there.
Dr. Arnab?
Yes, I'm here.
Dr. Debashish?
Yeah, I'm here.
Yeah, so is Dr. Sandeep there? I think he has not logged in. He did say that he had some family commitment because we were running short of time. We were already late, so I think he got caught up. So I think I'll ask this question to Dr. Sunil, that what should be the approach of a district surgeon to a patient with breast problems?
See, my only 1 minute take is that because in most of the district, including Jharkhand, most of the surgeons are not able to manage the breast issue problem to the standard of care we have, whether it is a benign breast disease or a ruling out of breast cancer. So my only message would be to get conversant with a triple assessment. Anybody coming with a breast problem, breast lump, the surgeon needs to be trained that they need to do a triple assessment. So of course they know how to do a clinical examination, but after that imaging is a problem in the district. So I would suggest that at least one surgeons each district should get trained in the breast ultrasound and should be doing their own breast ultrasound to find out whether it's we are dealing with a benign lesion or a malignant lesion. The other training that they should be undergoing was that to do a true-cut biopsy. Now, getting a histopathologist in a district in a Jharkhand scenario may be a little difficult, but there can be a tie-up when that tissue, how to preserve it, can be transported, who can report to them. And third input possibly is that if that patient is not the breast cancer or suspicious of breast cancer, how to manage a benign breast disease. Because now there is ample evidence that the conservative management or non-operative management of the benign breast disease is a standard of care. That's all my take. Back to you, Anima.
So very rightly said, sir, that triple assessment is something that everybody should know. If we look at the breast cancer management algorithm, when you have a suspicious breast lump, you start with a triple assessment, go to the clinical staging of the disease, do a workup with biochemistry and imaging, and then the treatment modalities, which is multimodality, right from surgery, chemotherapy, radiotherapy to hormonal therapy and palliative therapy. So if we look at the district challenges, as you said, that biopsy, true-cut biopsy itself is a challenge because many surgeons are not trained. You might not be having the instruments, right instruments to be available. And multimodality treatment and the advanced imagings, they might not be available at district level. And to add to all this, the COVID era has added an additional problem of clinical examination as well as even the upfront surgery. So with this, I would like to ask Dr. Arnab, how best can the management algorithm be followed at district level, maintaining the standards of treatment? And the second question also, I'll put it together because you can add both together, that in the present COVID era, which is an additional problem, we have got a lot of lockdowns all across with restricted movement across the country. How would you suggest the district surgeons to manage the breast cancer patient at this time? Because they would land up to institutes like yours, because it's a cancer institute, in conditions which are worse. So, Dr. Arnab, what is your take on this?
To answer the first question, well, I mean, it doesn't always mean that if you're working in the district level, you don't have all the facilities, because many of the medical colleges in the district level are having many of the facilities that you want. But then if you don't have them, obviously mammography might be an issue, like you said, getting a core biopsy might be an issue. So I think people can, like through ABSI, if you can really train people to do a proper core biopsy, and if you have a good pathology backup, that should be good enough. Mammography can be replaced by ultrasonography, so that's not a very big issue. Ultrasound in the good hands can give you a good result. But yes, those are the challenges in diagnosis. And if you really are talking about the COVID era, we are actually seeing a lot of patients coming at very advanced stage. Last 3 months, we actually had patients who reported just before the lockdown. We thought of doing the operation after 3-4 weeks. Actually, from ISO, we devised a guideline based on the American guidelines and the NHS guideline that we can defer the surgery, we can go on to neoadjuvant treatment. But these are the patients who actually dropped out from the treatment altogether, got infected with COVID, and later on came back with, maybe from stage 2, they've moved on to stage 3 or stage 4 in last 3-4 months time. So it's a challenge. At district level, you can't always have telemedicine facility. So, they can come to, whichever is the closest center where they can give some basic management. It could be chemotherapy, it could be surgery. At that level, that treatment should start actually. They don't always have to go to a city for a very good care. So those are the, problems which I think we are facing at the moment.
And before the COVID era, also, what would be your advice to the district surgeon that till what level should they manage and then refer the patient to you?
Like I said, I know very good surgeons or good MDT teams still available in medical colleges, but again, you're right that it may not be available everywhere. So if they don't have the facility, at least they should not delay the treatment. Some people actually put them on alternative medicine, or some people would probably put them on antibiotics, thinking it's probably an infection. So people who are not really trained in looking at breast cancer and doing a triple assessment, they should be sending the patient to a proper center where they can have the facility. Many of these patients would be poor, so they don't have to go to a very 5-star corporate hospital. They could go to a medical college or a charitable hospital, or a hospital where the facilities are available at a low cost.
Right. So you have rightly said that the wait time should not be increased because of non-availability. They should be referred at the right time. So when looking at the wait time, there is no benchmark for wait time before breast cancer surgery, but less than 30 days is considered to be a modest delay with better prognosis and outcomes. And usually the reasons for delay for breast cancer patients is that they are undergoing a pre-operative workup or considerations of reconstructions, referral to tertiary care centers, and now it is the COVID. So all these together cause ethically, socially, and potentially these are all contentious issues, and delay between diagnosis and surgery may lead to anxiety in women and progression of disease, which will finally affect the outcome and will reduce the patient satisfaction score. So district level surgeons have to be very careful about this part, because in UK, as Dr. Debashish would agree, that they have a monitoring about the wait time. Dr. Debashish, would you like to add on this?
Okay, so can I just start? Can you give me 2 minutes to just tell you about COVID and how I got into it big time? So
COVID is a discussion which we
No. For the breast cancer, it's very important for the breast cancer. It's very important for breast cancer. So one of the most important things is COVID hardly affects women, and breast cancer affects mostly all women. And breast cancer will continue, but COVID may go away. And we cannot neglect breast cancer patients. That's the first most important thing we have to understand and accept. And this is one group of patients who can be saved, and they can be salvaged and treated very well. And just in order to, because of COVID crisis and because of the fear of COVID, across the world, we have sort of neglected patients across with breast cancer. And as Arnab very well pointed out, that there is upstaging of these cancers, and the patients are presenting at a much later stage, which with larger tumors, larger axillary burden, and going from stage 3 to stage 4. So it's very, very important. And here we are looking at district surgeons, how they manage this. And we were entrusted with this role of creating a strategy where this doesn't go down. And very well back in January 2020, when China had just broken out big time, Italy had started growing, we were entrusted to look at a strategy in January, end of January. And we saw to that breast cancer treatment wouldn't stop. We didn't stop it. And we made a point that we made hubs for breast cancer, which are COVID-free, surgeons who would be COVID-free. And please remember, this is the first time in history across the world, we have a situation, everyone has been equalized. Every world, Western world, Eastern world, developing, non-developing, all of us have been hit equally. We do not know the answers. We do not know what is the best way to do it. No one knows. Like, this is the time where one of the media guys uses the phrase, "Hamam mein sab nange hai." This is the first time we are all in the same boat. and we have to learn from each other. And at that point, when we were developing the strategy, we went for help to China, Italy, Spain, because they were already affected. And one of the things we learned is women are least affected, breast cancer is growing, we can't stop breast cancer. And surgeons are equally vulnerable and they can fall ill. My assistant, who was a surgical nurse practitioner, 45 years old, died from COVID. So everyone is equally affected. So what we, as earlier we were said, somebody said, we should identify centers which will be able to deal with just breast cancer. They are kept COVID free, and surgeons should collaborate. The old paradigm of one surgeon doing everything is not going to work. You may book a patient on the list, and on the day you may fall ill, and your colleague should be able to operate. Collaboration, working together in groups, virtual MDTs, that's the way forward. Even in the district level, we have to still isolate and have named centers, but you should be able to work in a collaborative way, and you should go out to that particular center to operate, keeping that COVID free. And if you identify a patient with COVID, and then this actually adds on to our old management of breast cancer, where working collaboratively, doing multidisciplinary teams, meetings, working, and this has really led to a much more cohesive way of working.
I think you have made a very important point that even in district, people have to develop a collaborative approach, because that is going to be in the interest of the surgeons as well as in the interest of the patient. Because India is a resource-restrained country, and it has got a very low per capita income, and it's unlike NHS. People have to pay from their own pockets, and the publicly funded institutes have got a huge waiting list. So by the time their number comes, they might have landed into a progression of disease and into a higher stage. So it's very important that if the district surgeons collaborate and somebody, as Sunil sir said, gets specialized in it, it might be useful. And this is what we have to tailor make for the Indian scenario. We have to taken into account our limitations and affordability. And once again, just emphasizing on the fact that if we do not have organ-specific training, then the quality of mastectomy, the axillary lymph node dissection, and pathology reporting, they are all varied across the country. So you cannot even compare your outcomes. Even the chemotherapy regimes or hormonal agents that you are using for treatment nowadays, you've got adjuvant online and all to assess whether you have to give what therapy to the patient. But when we come to India and the district scenario, they are not usually decided by the prognostic and predictive factor. Rather, they are decided by the logistics and the access of the patient. So, and in most of the district scenarios, what happens is that the treating doctor or an oncologist, they also become the pain physician, because pain also is a very important aspect of management of breast cancer. And these were a few papers I was just going through because I was thinking about the collaborative approach that you talked, whether a surgeon should be breast focused surgeon who should be dealing with it, or a general surgeon can deal with it. There are two contrary views that I found. One was that it is the domain of the general surgeon, where if the general surgeon is performing more than 15 breast cancer operations per year, is a good surgeon, and the outcomes is not based on the expertise of the surgeon, but because of the availability of the multimodal facility. On the other hand, the other view was that breast-focused surgeons have better outcomes with fewer positive margin, fewer re-excision, and more breast conservation. So on this, I would like to ask my panelists, and I would start with Dr. Arnab, Dr. Sunil, and Dr. Devashish Ghoshan, that what would be the ideal, whether a district surgeon becoming a breast focused surgeon, or we as the bodies like ABSI and ASI should lay down standard operating techniques of procedure, taking into account the logistics of districts, and then the surgeons following the same guidelines and operating.
Well, ideal obviously is breast focused surgeons, and everything should be organ oriented treatment in the near future. So somebody dealing with breast should be only doing breast, somebody doing liver should be only doing liver, but that's the ideal scenario. But in a country like India, is that possible? I don't think it is, because the kind of population we have, the ratio with the doctors, the clinicians, the oncologists are much, much less than ideal. So I think in future we have to think about breast focused surgeon. What ABSI should be focusing is, till that we reach that stage, I think the surgeon should be trained in doing safe, oncological surgery. So a proper axial lymph node dissection, a proper mastectomy, and a multidisciplinary team approach should be there. That should be trained at every level, so that we can actually have a standard of care till we actually have that kind of specialized oncological team.
Dr. Dave, what would you say on this matter? Because if we have a standard practice and somehow we develop a system of having monitoring of this, the kind of surgeries that are done, if we have kind of a audit, surgical audit at district level, that might, I think, improve the outcomes and would also lower the burden on the centers. Like Dr. Arnab has a specialized center, so those centers are overburdened. So if we have this, what would you say?
I think this is again where COVID has helped, virtual MDTs. So the general surgeon can still practice breast surgery, but let him run the case via the virtual MDT, which is associated with a specialized center. So then they get the advantage of some guidance from the people who are doing more. And this is where they can literally have a better outcome. This is when you actually learn. Sometimes, people are sitting in isolation in the past, but now with, say, like Zoom, so tomorrow you can have a MDT in, say, Jamshedpur, and somebody sitting somewhere in a small town in Jharkhand, dialing into the same MDT, presenting the case, showing the mammograms, ultrasound, and having an opinion, and that helps them to take it further.
Yeah, I think that's excellent. Even in, I think in NHS, every center does not have every facility, and most of the people are on telemedicine. So that is the way they have a proper MDT.
Yeah, I think the MDT should be possible, but the skills, level of skills have to be developed at local level, because that probably will not be possible through telemedicine.
I think that is where absolutely where budding up and having 2 or 3 surgeons working together and pooling their cases, doing so that they have more numbers pooled together. And whenever they do it together. And that helps. I think in the initial, not the initial phase, it's just way things are moving forwards. You may not be fit to operate in this current era. You do not know, you book a case, tomorrow you may not land up operating on that case. So if you work together, it's going to be in your best interest.
So I think what is coming out, because Dr. Sunil also emphasized on collaborative approach, Dr. Debashish is also emphasizing on the same. And Dr. Arnab, what would you say? Because you are saying that it is the skill which has to be taken care of. So what would be your message to the district surgeon? How would they, focus on their skills? The MDT part is fine, we'll be doing a telemedicine, but how would you suggest that they should focus on the skill?
Well, I think there are different ways of doing it, like Dr. Debashish has suggested. You can club up with another surgeon who has got the expertise, so that you develop your own expertise in that particular hospital. You can go to any local hospital where you can have access to within your driving distance, so that you can spend 1 or 2 days in a week to develop your skill, because you have to have that skill to operate on those sort of patients. And if you really can't, then eventually you have to probably turn up to any tertiary care cancer center, where you probably would have to spend some time. You can attend some fellowship courses if you're really serious about your subject. You want to really do justice to your patient.
So now coming to this very pertinent topic of COVID era, just like in any cancer, and Dr. Debashish already mentioned that breast cancer management cannot wait because of the COVID era, because it is there and we have to manage it. There are various guidelines from various societies that have become available for the COVID-19 pandemic. And they have all asked the patients to be divided into 3 priorities. Priority A, the patients who have life-threatening conditions and their treatment cannot wait. They have to be attended immediately. Then there is the priority B, who do not need immediate treatment, but their treatment cannot be postponed until the end of the pandemic. And then we have the priority C patients, in whom you can delay the treatment till the pandemic is over, because that will not adversely affect them. So with this, Dr. Debashish, I would give the panel to you that what should be the priority and how to maintain the standard state-of-art management in breast cancer in this COVID era.
Okay, so now remember, at different times of the COVID crisis, in the different parts of the curve, as you know, there'll be parts of the curve where we're going to be at the highest number of cases. So if I give you the scenario, there was a time when we were having about 1,500 deaths per day in UK and about 800 deaths per day in London itself. And in those cases, in that period of time where people were just falling down dead, or we were having the whole ITU was full. So in Royal Free, we had 64 ITU beds full of ITU COVID patients. So we couldn't operate in Royal Free. And mind you, Royal Free was the center for COVID because we were running the remdesivir trial. So because of that, we had to go to a different private hospital where we carried on doing cases, but we were not doing breast conservation surgery. We were not doing any mammoplasties, no oncoplastic surgery. Every patient just got mastectomy and sentinel node biopsy. That's what in the peak period. But then there were periods when, so right now we are in a period, we are at a low peak, but we are waiting for the second wave to come. And in the second, when we are awaiting the second wave, we are now still operating outside in a COVID-free hospital. But what we are doing is we are doing the same type of surgery. We have just restarted the reconstructions, but not going overboard in terms of doing risk-reducing mastectomies, not doing benign cases. So the priorities for each place, and I think we in India, we should not bother too much about priority A, B, or C. Just treat them as cancer per se. Do your standard mastectomy, because even sending patients for radiotherapy is going to be a problem. Don't forget, you just can't do a breast conservation surgery and not send them for radiotherapy, because where you send them to radiotherapy, the patient may go for 3 weeks of radiation or 4 weeks of radiation into the hospital, and then they get COVID from there, and you have got a patient who is dying. The other thing to be very careful is do not operate on COVID positive patients. So test the patient if they're positive. If they're positive, postpone for at least a month. If you operate on COVID positive patients, the mortality rate from anesthesia is 50%, literally 50%. This is what we are seeing. So my recommendation, or I shouldn't really, but again, as I said, every person has to, place has to develop their own local policy. Surgeons should group together, decide what is feasible, what is not feasible. Forget about commercial benefits at this time. Even the surgeon may be risking themselves to developing COVID. We have had surgeons who have been in ITU for 3 weeks. And remember, Asian male patient above 50 is the highest risk. We have found that. So do not think we are gods, that we are going to be safeguarded. But do not reject the patients. I think we should try and adopt the approach we did for HIV patients. We assume that everybody is HIV positive. Take universal precautions, but treat them. And that is the way forward.
I think you have rightly pointed out most of the aspects that we have to take care of. And just adding to this, when you said that all patients should be tested for COVID, there's just one more thing I would add, that once you test them, I think they should be kept in isolation till the date of surgery. They should not be meeting other patients who may again infect them.
So currently we are testing 3 days prior to the operation, and they are self-isolating for 3 days. And their family members are self-isolating for 3 days prior to coming into hospital. It's very important to safeguard yourself as surgeons as well, your other health personnel, your nurses, your anesthetists. So these are absolutely important steps.
So we are doing the same. Yeah, yes, sir.
Sorry, I think you could actually repeat the test, because RT-PCR we know has a false 30% negative report. We had occasions where the first report was negative. We were about to operate. Fortunately, we did the second test, it came positive. So just to be on the safer side, like Dr. Vashi said, once you're operating on a COVID patient, your full team and the patients are at risk of dying of COVID. So I think the second test would be justified. I think my little experience with our set of patients in India, that unlike UK, I think when the curve started coming down, in our country the curve is still going up. So we had been probably doing injustice to our patients by not operating at the initial phase when the incidence was really low. So now I regret about postponing the surgeries for certain patients. So I think at this moment, like Dr. Devashi said, we must take cancer patients as we used to do in the past, but at the same time be safeguarding yourself through COVID testing and through whatever is required.
And yes, sir, there are a few other guidelines for taking care now, like use of cautery, taking away the fumes and all that, all those norms, they are going to be the new normal for us. I think we all have to get that into practice. Sunil sir, do you want to add something?
No. I'm quite happy and agree with the two of our esteemed panelists. So interested to hear their views.
Okay. So, as I said, the new normal would be the staff precautions already elaborated by Dr. Debashish and Dr. Arnab, pre-operative COVID testing. And as I said, and Dr. Debashish said that he's getting the 3 days prior COVID testing and then they are self-isolating. Here, what we are doing is that we are actually admitting the patient in the hospital and keeping them there so that we are sure that, they are not meeting anyone else. And there's one more concern that there has been a change in first-line treatment of breast cancer in the form of chemotherapy and biologics instead of upfront surgery because of the concerns. Telemedicine role has definitely gone up, and you have to plan, just like Dr. Devashi said, that you have to look at the phase of COVID in your area, whether it's phase 1, 2, 3, whether it's the trough or the peak, and accordingly plan, because all this will impact the health system and your resources. So this is the new normal. I think COVID is here to stay. It is not going immediately. So we need to follow all these guidelines. And the management that I think that we need to follow now is that once you have a breast cancer patient, triage them, use telemedicine for OPD, follow-up and counseling. Look at the phase in your local environment, whether if it's the phase 1, then it's only the high priority A. This is the phase 1 is that when you have the low, this is a trough. So you can be treating all patients, as Dr. Arnab said, that he is repenting why he waited for those patients, because that time we were in phase 1. But then in phase 2, you have to, kind of choose your patients who need the treatment, because here your resources will become limited. And phase 3, actually, you will have to stop most of your elective surgeries. And in this case, you have to look at the strategy change, where early breast cancer, where upfront surgery was the first line, you might have to look at neoadjuvant endocrine therapy or neoadjuvant chemotherapy, like in triple negative breast cancer. Even in early cancers, neoadjuvant has a role, but maybe the other cancers also may have to be put on that. And definitely reconstruction surgeries need to be deferred, because you have to do the life-saving surgeries more. So before we wind up our
Arunima, one last thing.
please.
HER2 positive cancers do not give neoadjuvant Herceptin, do not give pertuzumab neoadjuvant,
yes,
because
very
they are the
important.
ones who are being so chemotherapy per se is not causing problems, but Herceptin and pertuzumab is causing problems.
Correct, for the COVID patients especially, very true. And here, before winding, I would want each of my panelists to give a takeaway message to the audience. So, sir, Dr. Debashish, we can start with you, and then Dr. Arnab, and then Dr. Sunil.
As I said, again, we are all prone to developing COVID and probably dying from it, but our patients are equally important. Treat your patients, take all adequate precautions, universal precautions while examining patients, universal precautions while operating. Remember, change over time, cleaning of theaters between patients, absolutely important. Very, very important. Social distancing, washing hands, you can't replace it. Please don't play Superman.
Just to add to that, I think for the district level, like you said, I think the topic was there that the local expertise has to be developed. So the people who are dealing with breast cancer, they have to develop their own expertise. They can take the help of ABSI or the local surgeons who are trained in dealing with breast cancer, or go to a tertiary cancer center to get the training complete, at least to treat the cancer patients. And secondly, what I was about to add, we have seen a lot of patients who are sent home because of advanced cancer patients, because the guidelines also say that we don't treat palliative care patients in our hospitals, must send them back. The unfortunate thing that is happening is a lot of local doctors are refusing to attend the patient. And these are patients that are dying without actually any treatment at all. Nobody's even going down to write a death certificate. So that's very unfortunate. I think we have to be brave enough to wear a PP and go to the patient's house and see the patient.
Sunil sir,
I have already expressed my view for the district surgeons, but in the larger perspective, my view is to protect yourself, protect your family, and then protect society, which includes your patients.
Thank you very much, all my esteemed panelists. That was wonderful. And I think the takeaway messages are strong. These are various links to the key guidelines available. And here I would like to give the e-certificate to Dr. Arnab. Thank you, sir, for being the panelist. Dr. Debashish, thank you for being here. And Dr. Sunil, thank you very much. Thank you. And
very much.
this is the company I work for, Tata Motors. And I think it's one of the most human company. Very proud to be a part of it. Thank you very much.
Thank you. Thank you.
Thank you. We go on to our next session without any delay because we are already running short of time. So,
but I must tell you, because I didn't restrain, because the quality of discussion and that was so high that I think we must get benefited from that.
Very much.
I agree. It was a wonderful panel, Arunima. Fantastic.
No, not only panel, right from the mornings. That's why I thought I will restrain, but right from 11 a.m., I thought it was one of the highest standard of discussion going
on. Absolutely.
Completely agreed, Dr. Sunil. It's fantastic. The way it is organized to the delivery level is fantastic.
Thank you, Dr. Dipendra. Thank you for all these encouraging words. And we go on to our next session. That is the sixth session. And this is the last session before we end up with the valedictory. And I invite my chairpersons, Dr. Nalini Kant and Dr. Abhiram Maji. Dr. Nalini Kant is the senior consultant.
Arunima, can I just stop for a minute? I will request all the esteemed faculty from UK and Dipendra, whoever is logging, to stay for some more time so that my valedictory people feel very motivated if you are there and show your first presentation.
So, Dr. Nalinikant Chaudhary, ex-chairman ASI Jharkhand Chapter and a senior consultant surgeon from Bokaro. Dr. Abhiram Maji, associate professor, Department of Surgery, Calcutta National Medical College, and he's the ABSI East Zone EC member. And I would ask them to take over. So you're there.
Hello.
Yeah.
Am I audible?
Yeah, you are audible. Yeah, you're audible.
Yes. Thanks, Dr. Sunil and Dr. Arunima, for organizing such a nice virtual conference. And it is going to be an example. Now I would like to invite Dr. Anand Sinha, MS MCH Plastic Surgery, Director of Dev Kamal Hospital, Ranchi, and accomplished plastic surgeon. So it is all yours, Dr. Anand Sinha. Please.
Yes, sir. Thank you very much. I'm slightly compromised. I'm at the airport. I will request the host to kindly show my presentation. I'll just take 4.5 minutes only. You're already getting late. Yes. Can my presentation be shared by the host?
Yes,
Yeah. I've already forwarded my presentation. I'm unfortunately about to catch a flight. But anyway, before that's being loaded on, the cosmetic surgery of the breast now is only of 3 reasons. Number 1, we have to increase the size, that is called augmentation mammoplasty, to reduce what we call the reduction mammoplasty. And to
Screen is not visible.
Yeah.
Screen is not visible.
Yeah, he'll come. By the time the screen comes, I'll just talk, sir. And the third thing is the mastopexy, when the breast has hang down, and for cosmetic reasons, you got to make it look slightly better. First of all, we'll start with the breast implants. The implants now come in various shapes and sizes. It all depends who needs it. When the slide comes, I'll be able to show you much better. It totally depends what the age group is. Even girls of 18 and 20 years have very small breasts, and they come to us with some kind of an inferiority complex, and it's very visible these days. The dressing sense has changed. So you need to have good contours. So we give them as per their height and weight, whatever size requires, ranging from 175 to 450 cc each side. Is my presentation coming along? Yes. Second thing is another age group is once they have 2 children.
So your presentation is just being loaded by the website person.
That's perfect. I can keep talking in the meantime. Yeah. And the second age group is when the woman has had 2 children and they feels that the breast has sagged down and they need to have a little bit more augmentation. We give them maybe a smaller implant, say 150, 175, 200 cc on each side. And the third is some ladies who do not marry, they keep wearing, yes, that's better. That's my slide. We work as 4 people together, 4 plastic surgeons together at Devkamal Hospital. And we've been able to establish a surgical center of excellence at our place. Next slide, please. Next slide. We have 3 approaches: the transaxillary, the inframammary, and the circumareolar. I'll show you transaxillary and the inframammary. We do not do circumareolar, it's quite technically difficult. Next. This is the no. Can I go back? Can I go? Yeah, that's the transaxillary approach. All you have to make is a 6 centimeter incision. That's the implant, which can be squeezed in. You either go behind the gland or you can go in front of the gland also, or sometime even under the pectoralis major muscle if the muscle is too lax. Next. That's the post-operative picture. She wanted to have a big breast. Next. Another girl, just 18 years. Next. The side profile. Next. We create an incision and then we create a pocket underneath the breast. If anybody who is 18 and is going to have a baby in future, we'd preferably go behind the breast. And this lady has 2 children after that. Next. And we recently removed her implant. What the implant looks like. Next. That's to show that I'm doing it. Some people say that you only copy a picture and post it. That's the post-operative picture. She came back to us about 6 months ago and got her implants removed because the breast had hypertrophied after 2 kids. Next. She didn't have a good scar because immediately got married and the scar stretched out, but the scars can be modified. Next. Lady, mother of 2, 38 years. Next. That's the post-operative picture against a transaxillary approach. Next. From the foot end. Next. 42-year-old nulliparous executive in a hi-fi company. Just wanted to look slightly better. Next. 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 That's the post-op picture from the foot end side. You got to hide the face. She didn't have a very good scar. We Indians don't get good scars, but still, this approach at least covers the undergarment properly. And inframammary, when they become older age, it may hang down and may start showing underneath the undergarment or the blouse. Next. This lady, she preferred inframammary. Next. Next. We just create a fold. Next. 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 Post-operative picture on table. Next. The side profile. Next. Next. Now, unilateral breast atrophy. On this side, on this patient, on the left-hand side, we will push in an implant so that it becomes near normal to the right. We can never give them a completely balanced line. Next. 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 Most important part. Surgery anybody can do. You got to plan and mark out. You got to keep in mind that if the breast implant goes in, it has to be slightly higher so that in future it may sag down and come down to the same level as the contralateral side. Next. What a measurement goes in that? Pocket created from memory. Next. Plant. Next. So when you're doing all these things, height, build, age matters, and above all, demand matters. Even if you tell that lady 300 cc would be good enough for you, no, I want 375 or 380 cc. They insist. But we make them right on the consent then that despite doctor telling me not to go for a very big implant, I'm going forward. Next. Next. The same lady. If you see that the left side breast is slightly higher, but with the ptosis of the implant, this will become lower, but never be symmetrical, it will be near symmetrical. Next. 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 2 age groups, 18 to 24, what's we call the vaginal hypertrophy. We try and conserve some breast. We've done about 20 so far, and 4 have been able to lactate. That's a good ratio. Next. Planning, a lot of planning goes into this, where the nipple has to be placed, a 6 intercostal space, and all those things. Next. Inferior pedicle approach. Next. Post-operative picture on table with 2 drains on the 2 sides. Next. Long-term picture. Slight asymmetry will be there, but all they have is a small line on the inferior aspect of the breast. Next. a bit difficult one. What we had in the previous one, she had a normal one on the right side and abnormal on the left. Now here it seems that the left is normal and the right is abnormal. So on the right side, we go for reduction of breast. Next. Next. A lot of planning goes again. Next. Next. Would we remove? Yes, next. On tape. So we've showed you all sides of things. Inversion of nipple is a very gratifying surgery. Now, the current trend is that the protrusion of the nipple should show if you are wearing a t-shirt. Believe me, the demand is tremendous. We do 2-3 in a month now. Next. Next. They're all self-explanatory. Next. We just go through the circumareolar incision with a small tunnel there with a 4-0 chromic catgut. Not tight enough so that it may not constrict the lactiferous duct. Next. Thank you so much for the time. And I'm sorry, I have to finish off first. Thank you so much. Any questions? I would be happy to answer now or maybe in the YouTube.
Can I ask you 2 questions quickly?
Yes, sir.
So I just, so first of all, you said about planning, you were just talking about the size, but I don't think we use size here as a criteria. It's the base width and projection what the patient uses. Number one, what is your views on ALCL and capsular contracture? How do you consent for those?
See, when we make them sign the consent form, we explain everything about all these things. When we do a breast implant, I take out a small piece of breast also, sent for histopathology. Number one, always without fail. And capsular contraction, yes, it is there. We've seen over 10
I
to
think
12
you missed
years.
ALCL. No, hang on. ALCL has nothing to do with biopsy.
No, I know that.
ALCL.
Yeah.
So it has nothing to do with biopsy.
Well, then I'm not completely aware of that. We are basically mechanical surgeons.
This is a breast forum and it's very, very important. ALCL has become a very hot topic across the world for breast surgeons because implants put in, they develop after 5 to 10 years. Patients present with just pure seroma. It is a blood cancer. And 1 in 24,000 patients with breast implants who are using, your textured implants are getting ALCL. Hence, Allergan implants have been completely withdrawn. We have to consent patients for ALCL. Very, very important. Hence, I wanted to bring this up. Sorry about this.
That's okay. We used to do Allergan, but now we switched over to Eurosilicon. I believe they are cheaper also because in India, the cost factor also is quite significant. And in the last 18 years, I still have had no problems because they keep coming back to us for follow-up. But capsular contraction is there.
Yeah, the point is well taken, Anand, very well presented, and we'll move on to the next topic, and all the queries can be answered on YouTube, please. Very nice, Anand. You have been a wonderful surgeon of Jharkhand and our pride. Thank you.
Thank you, sir.
Thank you, sir.
So, yes.
Thank you, Dr. Anand, for the nice deliberation. Thank you, my co-chairperson, and thank you, the organizers. Thank you. Am I audible? No?
Yes, sir, you are audible.
Hello?
Yeah, we can hear you.
So thank you all.
So we just give a e-certificate to Dr. Anand Sinha for his talk, Dr. Nalinikant Chaudhary for chairing the session, and Dr. Abhiram Maji. I think Dr. Nalinikant wanted to say something. Yes, sir, please.
No, only I wanted to extend my thanks to Dr. Anand Sinha, which I have done. All right. Thank you.
Okay, and Dr. Abhiram Maji. Yes, sir.
Thank you.
So we move on to our next talk, and I invite Dr. Sandeep Kumar and Dr. Ashwin to chair the session. Dr. Sandeep Kumar is ex-professor. I think I saw him join in the session. So please, are you there? And Dr. Ashwin, consultant surgical oncoplastic robotic and HIPEC specialist from Manipal Hospital, Bangalore, the honorary secretary of ABSI. Are you there, Dr. Ashwin?
Yeah, I'm here, Dr. Andruma.
Yeah. So I hand over to you.
Yeah. So I'll be introducing Dr. Satvir Singh, who is a consultant surgeon at Sri Hari Krishan Super Specialty Hospital, and who is an MS and who has done a fellowship in breast oncosurgery to give his talk on reduction mammoplasty.
Yeah, Dr. Satvir, you can share your screen, please. Yeah.
My screen is visible.
Yes, your screen is visible, but I think you have to maximize your presentation. Please put it on slideshow.
Yes.
Yeah, please.
Very good evening to everyone. I am very glad to be the part of this August meeting of eminent surgeons, and I am the youngest surgeon of the lot. And I am very thankful for being here to present one of my cases of reduction mammoplasty of opposite breast in breast cancer patients with macromastia. I know there are a lot of discussions of mammoplasty has been done, but I still want to show my experience at Tata Memorial Hospital, Mumbai, where I learned the basics of breast surgery and oncoplasty. To start with, the therapeutic mammoplasty has been a well-known technique, oncoplastic technique, which incorporates breast reduction, and it facilitates the removal of breast tumors with wide safety margins. It provides symmetry and uniform distribution of radiotherapy with less toxicity. It has a role of breast conservation surgery in ptotic and large breasts. So excision of more than 20% of the breast tissue usually leads to a poor cosmesis, and breast remodeling should be done when more than 20% of the breast tissue has been drawn. Due to this, oncoplastic mammoplasty techniques have been developed. So now let's talk about the safety of the procedure. Yes, is the procedure safe? Yes. So Spear et al. Told that bilateral reduction mammoplasty immediately after excision of the breast tumor with a report of 6 years, and they say that it's an oncological safe procedure avoiding the asymmetry following BCS. Loskin also performed a bilateral therapeutic mammoplasty with oncoplastic techniques for 20 patients over 10 years. And there was a mean follow-up of 23 months, and there was no recurrence. So let's talk about the advantages. So advantages are the good oncological and aesthetic results. So therapeutic mammoplasty we need to avoid in some patients where we have to properly counsel the patient before going a therapeutic mammoplasty. We have to tell them about the outcomes and the results. Now, lowering the complication rate and morbidity of an extensive surgery like totally removing the breast and doing a reconstruction. And it also minimizes the sensory loss, and it avoids the need for implantation. And basically, I have seen a lot of patients who have undergone BCT or modified radical mastectomy, and they are having large ptotic breasts. And in follow-up, they complain of back pain, neck pain, shoulder pain, rashes, headache, exercise intolerance, and lack of self-esteem due to macromastia. So these are the provocation factors for doing a reduction mammoplasty for the opposite breast. Goffman et al. Told that he did a study on 55 patients of macromastia with cup D and cup C breast, and therapeutic mammoplasty really reduced the problems to 88% of back pain, 82% of neck pain, 88% of shoulder pain, and so on. And it is basically done for a cup D or a cup B breast. Now, talking about types of breast reduction, there are a variety of operations and surgeries for breast reduction, but basically very common are the pedicle method, the free nipple graft, the inverted T resection, the Legionnaire incision, and liposuction. As a young surgeon, I will be talking about my experience on pedicle method. Basically, selection of technique is very important, and it depends on the size, the estimate of the resection of the volume, the breast shape, and the experience of the surgeon. So we talk about the breast hypertrophy. So if it's mild, the resection should be less than 200. If it's moderate, it should be 200 to 500. And if it's severe, it should be 500 to 1500. And in gigantic, it should be more than 1500. And before talking about any breast reduction surgery, we should be knowing the dimensions of the breast. So basically, it is a equilateral triangle. And if we maintain this equilateral triangle, we will definitely get good results. And for the young surgeons who want to go for oncoplastic techniques, I will always recommend them to do this reduction mammoplasty on those patients who already had undergone MRM or a BCS. So pre-operative marking is very, very important in it. Patient should be supine, all the measurements should be made, and the basic plan of where the new nipple is there should be marked pre-operatively, and the photograph should be taken. So this is, and I'll tell you a small tip. So basically you have to go inside the mammary crease and hold the breast, and with the thumb you can see here, you can mark a point where the nipple can be there. So this is a very robust marking scenario for going before any reduction mammoplasty. Now talking about the pedicle method, there are various pedicle methods: superior, lateral, medial, inferior. According to my experience, I am very well versed with the inferior pedicle. In the inferior pedicle was first described by Georgia et al. In 1977. It is a very versatile. You can reduce the breast from 300 to 1500. It is very well vascularized. There are less chances of nipple retraction, and it maintains the nipple sensitivity. Only the criticism is that you get a flat breast and you get inadequate projection. So to start with, I compared the clinical photographs and the book photographs, how it is done. So basically you can see these are the markings. This is the point A where the nipple has to be made, and these are the surrounding of the areolar markings. And this is the medial extent, and this is the lateral extent. So what exactly we do? We give an incision circumareolary on this inferior pedicle. And we then after that, we put skin clips, this skin staples. Why skin staples are important? Because while doing surgery, these markings might get lost. And these skin staples provide the landmarks of what marking you did in the preoperative era. So now what we have done, around the nipple area, we just de-epithelize this region of the inferior pedicle, which will go inside the flaps. And post up, depending upon how much the breast we have to reduce, we reduce this part. So what we have done, we have de-epithelized this part of the skin with the nipple around, and we reduce this part of it. Okay, so now depending on how much amount of breast you have to reduce. So from here, we have reduced this much amount of the breast, and which is around 200 to 250 grams. And then once we completely remove the flap, we have raised it. We raise this medial and the lateral flap, and then we close this at a T junction, and the nipple areola complex and this pedicle goes beneath it. After that, from this area, we measure 4 to 5 centimeter, and then we mark a circumareolar circumference so that the nipple can be projected out from it. Next, we have with a cookie cutter, we just remove this part and we projected the nipple out. And once this nipple is projected out, we suture around completely with Vicryl. We fix it with Vicryl, and then we do a subcuticular with monocryl. We have to think about the teardrop effect, which generally comes here. We have to take care while doing the suturing procedure. So this was the second patient which we did. Was she had undergone right MRM, but she was having a very huge breast and a lot of ptosis over this. And for this, we did a left reduction mammoplasty, and I think this is a very good outcome. The complication of this procedure are the defrigging ugly scars. Sometimes the hypertrophic scar, keloid develops, skin ischemia, necrosis develops. And what Dr. Ghosh even told, that necrosis of NAC is also a vivid complication, but it's just because of the complication or the procedure is very difficult. We should not think that we should be afraid, and we should not do all these procedures. And I want to encourage all the young surgeons and the postgraduate that they should take up breast as a training program, and they should train themselves and achieve good heights. Thank you.
Thank you, Dr. Satwir Singh, for an excellent presentation.
I would like that if any of the stalwart surgeons would like to give some inputs, so that young surgeons can come to this conference and present more and more of the cases or experience they are having.
Yeah, Dr. Satwir, that is the reason we offered that whoever wants to present, we try to do it first come first serve basis. And he is one of our Jharkhand breast focused surgeons. So thank you for your presentation. And this is a e-certificate to Dr. Satwir for his talk. Dr. Ashwin, thank you for chairing the session. I think Dr. Sandeep joined, and I think he has some family commitments, so he left. So we move on to our next topic. And I invite our chairpersons, Dr. Om Prakash, and I invite Dr. Makhan Lal Saha, because Dr. Shamita's father got admitted in hospital and she had to leave. So Dr. Makhan Lal Saha would be chairing the session. So Dr. Om Prakash, Senior Consultant Surgeon from Hazaribagh, and he's the immediate past chairman of ASI Jharkhand Chapter. And Dr. Makhan Lal Saha needs no introduction. He is one of the greatest academician of India, and his book is known to every PG student of surgery. And he is a great teacher, a very passionate teacher. I have attended his classes myself as a faculty with my own PG student. And sir, I hand over to you. Please introduce the speaker, and then we can move on to the talk, which is the last talk of the day. And I would request all faculty to stay for the valedictory as well. Yes, sir.
Hello, am I audible? Am I audible?
Yes, sir, you're audible.
Yes, I'm very. Hello.
Yes, sir.
I'm very thankful to Dr. Sunil Kumar and Dr. Arunima for giving me this opportunity to chair this session. Our speaker is very young, dynamic surgeon, Dr. Sanjay Kumar Jadhav. He is assistant professor from Netaji Subhash Chandra Bose Medical College, Jabalpur. He has done MS and MCS. He has published more than 50 publications in national and international journals, and he has presented over 10 papers in national and international conferences. He is editor, board of member of Artificial Intelligence in Cancer, and many more things. I will now invite him to deliver his prestigious lecture on hormone therapy in breast cancer.
Yes, Dr. Sanjay, please share your screen.
Thank you, sir. Yes, I am just trying to. I am not able to share, ma'am. I think
there's a share screen option.
Yes.
Hello.
Okay.
Yeah.
Yes. Now I got it. Yes.
Now
maximize your presentation.
Yes. Okay. Thank you. I thank organizers for giving me this opportunity. And I am an alumni of RIMS Ranchi, and one of my mentors, Dr. D.K. Sinha sir, is there amongst the audience. And I remember he pushed me to attend the second or third ABSI conference, which was held in Kolkata, which I attended. And after that, I was drawn towards this branch. So I will begin my talk by remembering the stalwart of breast surgery, Dr. Bernard Fisher. And he said that in God, we can trust blindly, but all other things must have data. So currently it is evidence-based medicine practice. So coming to my talk, hormonal therapy in breast cancer. So it can be used as in prevention of breast cancer, in neoadjuvant setting, in adjuvant setting, and in metastatic setting. So this slide shows the effect of hormones on breast cancer, mainly estrogen and progesterone in both premenopausal and postmenopausal women. In premenopausal women, the major source of estrogen and progesterone is ovary, and in postmenopausal, it is adrenal gland, and it is due to peripheral conversion. So the agents which are used as hormonal therapy are selective estrogen receptor modulators, tamoxifen, raloxifene, then selective estrogen receptor downregulators like fulvestrant, aromatase inhibitors, progesterones, progestins, and then oophorectomy, which can be surgical by radiotherapy or medical. So now this is the way that estrogen dependent growth in breast cancer is antagonized. So ovaries are major source of estrogen and progesterone. So ovarian function suppression has a major role in high risk premenopausal female patients. Then aromatase inhibitors, they convert peripheral, they inhibit peripheral conversion of androgens to estrogen, and then tamoxifen. So coming to adjuvant hormonal therapy in premenopausal women, tamoxifen is the agent of choice, and I will discuss it briefly because we are mainly using it as adjuvant hormonal therapy, and in postmenopausal women. So in premenopausal women, we have trials which have definitely showed that using hormonal therapy, tamoxifen in premenopausal women increases the disease-free survival. And also two large trials have shown that it also increases the overall survival. And the side effects associated with use of tamoxifen are endometrial cancer, which at 5 years, the incidence is 2.3%, but long-term mortality is almost nil. That we should keep in mind, that it, although it increases the risk of endometrial carcinoma, but long-term mortality is almost nil. Then other complications like DVT and pulmonary embolism, cerebrovascular disease and heart disease are there. So coming to duration in premenopausal women. So currently there are recommendations for 10 years use of tamoxifen, and these recommendations are based on ATOM and ATLAS trials. So when ATOM trial was reported in way back in 2008 for early analysis, that time they did not show any disease-free survival benefit. But ultimately, when after 10 years, when it was again reported, they showed a significant disease-free survival benefit, and which was also showed by ATLAS trials. So currently, these two trials have showed that there is significant disease-free survival benefit of using tamoxifen for more than 5 years. And based on these data, ASCO currently recommends that adjuvant hormonal therapy in breast cancer should be used for up to 10 years in pre and perimenopausal female patients with estrogen receptor positivity. Now coming to role of ovarian suppression, this trial was published by Francis et al. In NEJM of adjuvant ovarian suppression in premenopausal breast cancer patients, which did not show any significant benefit. But when it was adjusted to high risk group, means those female patients who received chemotherapy, then this showed that tamoxifen along with ovarian function suppression reduces the breast cancer recurrence risk. So in premenopausal women with hormone receptor positive early breast cancer, adjuvant treatment with exemestane plus ovarian suppression as compared with a tamoxifen plus ovarian suppression significantly reduces recurrence. Based on this, overall, we can say that premenopausal patients do not benefit from addition of ovarian function suppression to tamoxifen, because some do very well with tamoxifen alone. But when it is restricted to high risk group, then there is significant disease-free survival benefit. So it should be added to premenopausal female patients who are at high risk of recurrence. Now, there is some controversy regarding use of tamoxifen and radiotherapy, but it has settled now that tamoxifen can be given concurrent with radiotherapy, and risk of local recurrence is not increased, and risk of other complications like pneumonitis and cosmesis are similar, whether it is used concurrently or sequentially. And in postmenopausal women, aromatase inhibitors for 5 years are preferred. Then switch therapy is used like tamoxifen followed by aromatase inhibitor for total 5 years, or 2 to 3 years of aromatase inhibitor after 5 years of tamoxifen. And in many trials, it has been found that switch sequencing therapy and extended therapy has greater disease-free survival benefits. So coming to complications, compared with tamoxifen, aromatase inhibitors are associated with increased risk of cardiovascular events and bone fractures, whereas tamoxifen is associated with increased risk of endometrial cancer. So in postmenopausal women, choice of HT should be guided by underlying comorbidities. And St. Gallen International Expert Consensus also recommends tamoxifen 5 to 10 years or extended aromatase inhibitors in high risk premenopausal and postmenopausal group. So briefly regarding neoadjuvant hormonal therapy, it is mostly used in patients with locally advanced breast cancer who are deemed unfit for systemic chemotherapy. And 2 trials have showed there is significant objective response. And NSA-BP P1 trial, which was designed to evaluate the efficacy of tamoxifen in high-risk population, showed that adding tamoxifen in high-risk group detects, decreases the breast cancer occurrence. Hence, FDA has now approved the use of tamoxifen in high-risk women to reduce the breast cancer incidence. Similarly, ASCO guidelines also recommend the same, that this option should be discussed with the patients who are at high risk of developing breast cancer. And in hormonal therapy in metastatic setting in premenopausal female, ovarian suppression along with tamoxifen or aromatase inhibitors is preferred. And in postmenopausal female patients, women who progress at least 12 months after the end of adjuvant hormonal therapy, and patients who present with de novo metastatic breast cancer are eligible for first-line endocrine treatment, and preferred regimen is palbociclib with an aromatase inhibitor, although fulvestrant along with aromatase inhibitor can be tried. So this is pooled analysis of multiple trials analyzing palbociclib with aromatase inhibitor, and which have showed significant disease-free survival benefit. So I thank organizers again for giving me this opportunity. Thank you.
Okay, thank you. A good presentation of regarding different aspect of hormonal therapy.
Thank you, sir. Thank you.
Thank you, chairpersons, and this is a certificate to Dr. Sanjay for his presentation. Dr. Om Prakash and Dr. Makhan Lal Sahab, you will definitely give your certificate.
Okay.
And that's the end of the scientific session. And I thank each and every speaker for the beautiful presentations they had. And we did overshoot, but the point is the presentations were going so well and they were so informative that we did not want to stop. I hope you'll bear with us. And now we start our valedictory function. And I would request the ASI Jharkhand Chapter Secretary to give his report. Dr. Azad?
Oh,
Yes.
thank you.
Yes, sir.
Am I audible?
Yeah, you are
Good
audible.
afternoon, everybody. Good afternoon, everybody. First of all, I would like to extend my heartfelt to all guests and esteemed faculties, speakers, and chairpersons whose presence has made this conference a great. During this COVID era, we did two webinars. One was related to challenges posed by COVID-19, and second was meant for PG students where different important topics were discussed. Both webs were great. And today, with help of East Zone ABSI, we hosted this conference. These webinars and conference have given us much needed experience and expertise to host major event. I am taking this opportunity to announce that we are going to organize virtual conference of our state this year on 7th and 8th November. And I invite you all, chairpersons, faculties, and at last, I will like to thank especially Arunima and Sunil sir and RPS who have made this conference possible, hit successful. Thank you very much.
Dr. Uday, please can you give your presidential talk for a minute?
Thank you, Arima. I'm audible?
Yeah, you're audible. Yeah, you're audible.
Greetings to all who are present to witness this academic event on virtual platform. First of all, I would like to thank the office bearer of ABSI who gave us the opportunity to host East Zone ABSI conference. Thanks to Dr. Arunima, who took all the pain in her personal capacity to successfully organize this event, no doubt under guidance of Dr. Sunil Kumar, our state representative as GC member in ASI. I must thank Dr. Raghuram, our dynamic president, to be present and gracing the event. I must not forget to thank our patron.
तुमको मतलब देखो एक तो इंग्लैंड वाला को बुला लेना घोष को.
Not forget to thank our patron, the force behind every activity of ASI in Jharkhand, the none other than Dr. R.P. Srivastava. I am sure that every participant will agree that this is a grand successful event. I must thank all the participants, the faculty, the chairpersons, the viewers whose combined cooperation made this conference a successful event. It is constrained due to the pandemic that we are meeting on virtual platform. Otherwise, we would have a good gathering, enjoying and sharing our ideas. Hope in coming years, we will be able to do so. We had tried to touch every aspect of disease and management related to breast. The paper and presentations were commendable and hope every participants have gained a lot. At the end, I pray for good health of all our colleagues. Be safe, be healthy. Thanks. Thank you, Dr. Arnima.
Thank you, sir. And now we would want all the faculty to interact with us and give us feedback regarding the conference or any comment or any suggestion that you have. We have, most of you are here, Dr. Chintamani, Dr. Sanjay Jain, Dr. Debashish, Dr. Som Shekhar, Dr. Makhan Lal. All of you.
I'll suggest just ask each one of them. Otherwise, all of them will start speaking together. So let's start with someone. You do
Dr.
the who
Chintamani,
starts.
sir. Yes, sir.
Okay. First of all, hats off to you and Sunil, as always. Your mentor has always done it that way. And what can I say? I commend you for the way you've conducted this conference, which has gone off beautifully. I must thank Dr. Uday and Dr. Azad for making it, possible with the Jharkhand chapter. This is a wonderful chapter, actually. Lovable people. Most of them are very warm and very nice. I've interacted with them very, very frequently, thanks to both of you, because I've come to Jamshedpur so many times. Each time that you organize, when you organize something, it's always special. this too was special. So kudos to you. Many congratulations. All the very best. And thank you for having us. I'm sure this would be a landmark event for all breast activities that happen, and we know who to ask to arrange it. So that is how I would like to sum it up. We are looking forward to many more activities. Thank you, Dr. Uday, Dr. Azad. It's truly been a joy.
Sir.
Thank you very much.
Thank you,
Sir.
sir.
Thank you, sir.
Dr. Sanjay Jain, sir. Sir, please unmute yourself.
See, if you remember, I said the people were talking. People are still talking that we will have our conference on a virtual platform. But you did it, number one. Number two, the entire, I'll congratulate not you, your entire team, and especially the IT team. It was a flawless. Even I was little bit skeptical that whether how it will happen, how. So this is a path showing to others. Definitely, it is a commendable job, and I congratulate you and entire team. There's nothing much to say. It's very good, and time what we have exceeded. It actually speaks itself. The people, how much people love it and like it. So there is no problem.
Thank you, sir.
It's really great.
Thank you.
Thank you.
Yes, sir, thank you. Thank you
Thank
for
you, Sanjay. Thank you,
recognizing the IT
Sanjay.
team.
Thank you, Sanjay. IT team has done a wonderful job, but I must express a secret. IT team and Arunima has done the last 1 week with the IT team. She is also very IT savvy. So kudos to her also, Arunima.
Thank you so much, sir. Dr. Debashish Ghosh.
I think it's an absolutely wonderful experience. It's been a wonderful 5.5 hours interacting with everyone. First of all, thank you for inviting me. Second is, it brings back very fond memories to me. Interacting with Ranchi, Jharkhand, Jamshedpur. I have been to Tata main hospital as a child because two of my cousins, one of them was an anesthetist there. I think Dr. Sunil will probably remember. This is Dr. Sanat Rai, who lives in USA right now. And my dad's friend, RG Datta, who was the head of anesthesia. So they were all there. So been there several times. Great memories there. Second, I think it's an amazing organization. Amazing organization. I think, Arunima, you are literally, and your mentor, Dr. Sunil, the fact that he has mentored you in this way, he gets credit as well. But you've done a fantastic job. Well done. Keep it up.
Thank you so much, sir. Dr. Diptendra Sarkar. Sir, please unmute yourself.
Yeah, I take the words of Dr. Debashish Ghosh. I call him popularly Devda. I must congratulate that I still remember the first day you called me up and we had a small little video talk amongst three of us and we decided to have this conference. And at that time, we are running so many video conferences. I always had in mind the glitches that had come up because of this virtual platform. But I am really speechless. I mean, the way the whole thing ran, not for a single second we felt that we are being bored out by the speakers. And the way the whole thing was conducted, Katsi, your wonderful coordination that every time before the speech, there was a WhatsApp message. It speaks volumes of the capacity that this organization at your place in Jamshedpur and a broader perspective, the Jharkhand chapter can do. Once again, heartiest congratulations from my side. I am sure we are going to have lots and lots of such conferences. Thank you very much for inviting me, and I am truly blessed to be part of this conference. Thank you very much.
Thank you so much. And sir, here I would like to say that, okay, you were the guiding light behind it. And I would also like to acknowledge that Dr. Sanjay Jain did guide in his own way, giving us ideas of how best to do it. So I think all of you are also getting the credit for whatever has happened. Arnab sir, would you like to share something? Dr. Arnab? Yes, sir. Unmute yourself, please.
Yeah. Can you hear me?
Yes, sir.
Yes.
Yeah, wonderful conference. I can't add much to what other people have said. Really enjoyed the whole conference. The organization was excellent. I was missing a big conference for a pretty long time. Everything has been small webinars, over the days. So a proper full conference, and that too such nicely conducted, and all the faculties have been brilliant. So like I said, I was stuck to the chair for the last 4.5 hours or 5 hours. Really enjoyed every bit of it. I'm sure you will be organizing many more such lovely conferences, and I'll be happy to be a part of it, at least as an audience. Thank you.
Sir, Makhan Lal sir.
Really, I am amazed by the wonderful organization. It went on flawless. It went on beyond time for more than 2 hours, and everybody is in their chair. So beautiful organization, the selection of topics. It really covered a great part.
Yes, sir. Sir, thank you very much. I think your net is having
Discussion, and I think it is going to be new normal, and people will now start enjoying conference at home only without traveling and going out. Okay, thank you so much, Onima and the whole team. Done a fantastic job.
Thank you, sir. Rosina, ma'am, are you there? Dr. Rosina? Okay, Dr. Chandra C.K. Naidu, can you hear us? Would you like to share something? Yeah.
We have truly learned how to conduct a virtual meeting like this. You taught us something, and I was a bit skeptical in the beginning. After this, I didn't feel at all that it was virtual. It's almost real. I don't think even real would be like this. Congratulations.
Thank you
You've
so
done
much.
a wonderful job. Wonderful job. Kudos to your team. And
yes, sir.
We have learned, and in future, if we want to conduct, I will disturb you for your knowledge and know-how. Okay. Thank you very much.
Most welcome. And sir, my IT team is excellent. Please do recognize them also whenever you're conducting anything.
Yeah, it is the backbone.
Anand,
it is the backbone.
Anand and Sachin. And now I would ask Dr. Somshekhar to say something. Dr. Somshekhar.
Arunima, I'll tell you, there are two things. Wow, what a talent you have. And why are you not taken such a major lead in ASI and ABSI? Me, Dipten and Raghu, since last decade has been in search of dynamic, bump, a fantastic, talented, you are like a Mercury. People like you should take major lead in ABSI and ASI and reach great heights. And this is an eye opener for me for two reasons. As a president, me and also Dr. Ashwin as a secretary, we have received lot of requests on email from various ASI chapters to conduct a meet like this. This has become a gold standard benchmark. All I need to do is, first thing I told my secretary in the ABSI office is, this program, the way Arunima did, keep a copy. This is how a copy will be given to every other state chapter, how to do it. And then a person like you should really, go great heights in ABS and ASI. The whole success is exactly you, like single-handedly, how the Sutradhar takes, they say Mahabharata, but it's ultimately only the Krishna who ran that, control all the thread. So it is fantastic thing, the way flawless happened, and you should take a major lead in this. And I'm really wowed, and not a single glitch that happened in this. You remember every day used to think, how will it happen? Now everybody is scared to do event after this bit, because even if you compare, even if you are 100%, you will 10% of what you did today. So on behalf of ABSI, we are so proud we got associated. You enhanced the value of ASI and ABSI. You and Sunil Kumar and your team, congratulations. And I'm really happy the IT team is from Bangalore, and I just hope they do better job like this for us. Thank you.
Sir, thank you very much for those kind words. I hope I'm worthy of that. And definitely my IT team, Dr. Sunil, I think together, I think we made a great team, and all guidance from all you stalwarts. Thank you so much for guiding us. And I would now want Dr. Sunil to say a few words, and then we have Dr. R.P. Srivastava, our patron. And before Sunil, sir, I think we have got some young people who joined in from Jharkhand. Dr. Satvir and Dr. Sanjay, would you like to say something?
Yes, definitely. Thank you, ma'am, and thank you, every organizers. It was very useful for us. And as I said, this is an upcoming branch, and in future there will be lots of demands for breast focused surgeons. So these type of conferences are going to help spread the awareness regarding works we are doing. So thank you for giving us this opportunity.
Sunil sir.
Yeah, what more I can say? The person I have mentored for the last 12 years is now reaching height, and that I have told her that she has to fulfill the dream of whole India. She has so much of capability, and the only thing is that we need to just to give her empowerment. But it's not easy. When it's not that easy, lady. What you all are saying, very difficult lady. She's very tight taskmaster. And for an old mind like me, I'm still sitting here without having lunch. All said and done, she's a wonderful person, very competent surgeon, good organization capability, very IT savvy, perfectionist to the core. And I have told that I am giving my baton to her, and I'm seeing you, Anuma, and want to see you to the greater heights. And you can see the applause you're getting, and that gives me a lot of joy. And will continue to do so. All my blessings. I'll be always behind all of you as usual.
Thank you so much, sir. RP sir.
I think people have stolen all the words which I would have said, but still don't, I have few words left to me. I was just thinking all these 4.5 hours. What does the word Arunima means? What was taught to me in Hindi? And that is the first lalima, the redness of the rising sun. I'm very thankful to the Almighty that this joint venture on virtual platform has started from the east of the country. And that's perfect because we see the sunlight first in the country. And Arunima, fully capable, which she has proven today, along with her mentor and along with the teammates, she has proven that she is showing just the redness akin to her name. So this is the Lalima you have seen. The sun is rising and Arunima will rise to the horizon, beyond the horizon, and she will shine in the sky. And I'll be too happy, as Sunil said right in the beginning, that someone pushes my name beyond the only person coming out of Jharkhand to be the president of the a grand our association. So Arunima and Sunil, I give you, salute you. I wish you all the best. And I know that from Jamshedpur, you can take the activities to a height and make it happen. And please do so every time and any time. You see, I'm very fresh now. I'm fully energized. I know that the Almighty has left me on this earth to do something more. And I commit myself again to the activities of ASI, ABSI, and all other sections and the chapters. Let us do something much more than what people can think in other countries. I'm really indebted to all the friends who have joined us from abroad, particularly Dr. Devashish Ghosh, who is exemplary and who also told us about his root connection from Sahebganj. You know, the Sahebganj, there is a beautiful school which used to have boarding facility in the days of Bihar. And it is still there, but it is an exemplary city. Saheb logon ka shahar hai wo. It is a city of Sahebs. So it is all, Jharkhand has a lot of glory to its credit. World Tribal Day today, as Sunil said, Arunima and Sunil, I just salute you. And behind me, I have shifted my background to the Vigna Nashak Lord Ganesha for the ASI, for all the family members of ASI members and all the extended family. I pray the Almighty that this pandemic goes, it keeps all of us safe, and we out of the virtual, we come out into the real. So long live ASI, long live ASI Jharkhand Chapter, long live ABSI, and long live my friends.
Thank you so much, sir, for all your encouragement. And I would want all of you also to please acknowledge Mr. Anand and Mr. Sachin. They are a wonderful duo, the IT team that made this all possible. And I have been very demanding, as Dr. Sunil said, and they have actually done all that I asked them to do. Day and night, they've actually worked very hard, creating everything. So I do want to acknowledge them on this platform. And
So Arunima, according
Yes.
to his name, Anand has given us pleasure of lifetime. So let
Yes.
us all clap for him. Let us all
Yes.
clap for him. Right. Good.
Yes. Anand, you can come on screen. Yes. Yeah. Excellent work done. And this conference has been so good that day and night they've actually worked very. So I did not actually feel like ending this, but as we say that all's well that ends well. And we from Jharkhand are very privileged, honored, and happy to host and give this platform to the nationally and internationally recognized surgeons. And as our ASI president, Dr. Raghu, said that it is our blessing. I'm counting my blessings in the form of all that you said and all the platform that you all gave me. Thank you very much. And I hope to interact more with you all at different levels. Thank you very much for being here. And thank you very much from ASI Jharkhand Chapter and ABSI East Zone. Thank you.
Thank you.
And we are ending the meeting here. Hope to see you again very soon.
Bye. Take care. Have a nice
Thank you.
evening.
Thank you. Thank you.
Thanks, Chinks.
Thank you, sir.
Thank you.
Thank you very much.
Thank you.
Thank you, sir.
Prakash, Uday, Ajad, Chinks, Dr. Naidu. Bye.
Thank you, sir. Thank you.
Sanjay
Thank you.
Yadav, your
All the
talk was
best.
very informative. Very talented guy, Sanjay Yadav. Very nice.
Thank you, sir. Thank you so much.
Thank you, Dr. Naidu.
Thank you very much. It was a pleasure interacting with you.
Thank you, sir.
All the best. God bless.
Dr. Rosina, thank you very much.
So many thumbs up for Arunima.
Thank you, sir. Thank you.
Okay, Om Prakash ji, Uday and Ajad. Uday,
Okay,
बढ़िया your end lecture was exemplary. बहुत अच्छा बोल दिए तुम last में.
आप ही लोग का सिखाया हुआ कुछ है सर.
हाँ, तो बीच में सुनते. All is it going on YouTube now or can we
Yes,
be
sir.
little?
Yes, sir. It's on
It is going
YouTube.
on YouTube. It is on
आप
YouTube.
बंद कर दो.
Can I
Okay.
stop?
Uday,
Can I
well done,
stop
well
live,
done, Uday.
sir?
Yeah, please stop the live streaming, Anand.